Very good morning to one and all. It's my privilege to introduce Dr. Vijay L. Aras. Is presently working as associate consultant at Narayana Multi-Specialty Hospital, Mysore, and he is qualified in DM Neurology from Lucknow, MD General Medicine from RIMS Ranchi. Academic achievements and expertise is Dr. A.M. Kar Centenary Gold Medal Award and special interest in stroke and autoimmune neurology. And he also served as former assistant professor, Department of Neurology in KGM Lucknow. And he has published 4 publications in national and international journals. I request Dr. Vijay Tellaras to enlighten us for this session on unveiling the biology and the pathogenesis of dementia.
So, good morning, everyone. I'm very honored to be speaking in front of my teachers. I'm an alumni of this institute, 2007 batch. Uh, so, let us begin the speech on the biology of dementia, the amyloid hypothesis, tau propagation, neurodegeneration, and brain inflammation. Next slide. So, why this topic is important? The prevalence of dementia is rising globally. Currently, about 55 worldwide. The prevalence is around 55 to 60 million population affected with dementia. Among this, Alzheimer's accounts to about 60 to 70% of cases. Despite decades of research, the causative biology remains complex. New therapeutic targets, targeting amyloid, tau, inflammation, are in the clinical research. So clinicians must understand the biological rationale. Now, biomarker-driven diagnosis is changing the landscape of practice. CSF, plasma markers, as well as PET imaging have been introduced in clinical as well as research. The aim of this talk is to provide a coherent, updated biological framework to interpret disease, diagnosis, and therapies. Every day in our practice, we often come across patients who have memory complaints, some with subjective decline, some with MCI, some with progressive disease. What separates these trajectories? Why does biology diverge so early? Today, I'll try to simplify this biology of the disease, the normal physiology, what goes wrong, why only some patients convert from amyloid to tau, and how this shapes the clinical syndromes. So next, we'll have a brief timeline of key discoveries related to the Alzheimer's disease. It was first described by Professor Alois Alzheimer, who described it in a patient presenting senile dementia, pre-senile dementia in 1906. Fisher reported neuritic plaques in the case of senile dementia. The term Alzheimer's, it was labeled as Alzheimer's disease in 1910. In the 1960s, that is mid to late 1960s to 80s, there was biochemistry, and early 90s genetics, that is mutations in AD identified, presenilin gene, APP gene mutations, risk factors were identified, BRAC staging established, and brain imaging techniques were improved. 2000s and the second decade of 20th century have changed the landscape with introduction of PET markers of CSF as well as plasma. And the last 3 years, there have been multiple clinical research and approvals for anti-amyloid beta therapies, that is aducanumab and lecanemab. So let's begin with the physiology of amyloid. It is a amyloid precursor protein. It is a large transmembrane protein essential for normal neuronal function. The physiologic functions of APP include maintenance and formation of a synapse, neuronal growth, plasticity, cell adhesion, and neuronal development, as well as it modulates calcium homeostasis. Point.
Okay.
Okay. Next slide. So it is a transmembrane protein containing an extracellular N-terminal and intracellular carboxy terminal. So it is mainly found in neurons, especially in the synapses. It is expressed in axons, dendrites, presynaptic terminals, as well as postsynaptic densities. It is also found elsewhere in the body, like glia, muscles, and peripheral tissues, but brain accounts for most of its normal function and pathology. So every day, the amyloid precursor protein undergoes processing. This is APP is produced by APP gene located on chromosome 21. There are two pathways. This happens physiologically as well. 90% of the processing is through the alpha secretase, that is non-amyloidogenic pathway. About 10 to 15% is through the beta secretase pathway, that is base 1 enzyme gene. So this is the amyloidogenic pathway. So the alpha secretase cleaves into a soluble APP alpha and P3 as well as amyloid intracellular domain. So the P3 is the non-toxic form. Beta secretase cleaves followed by gamma secretase, which produces the A beta less soluble amyloidogenic form. So next. So all of these have normal physiological roles. The soluble amyloid precursor protein beta has a role in neurodevelopment. The alpha has neuroprotection, formation of synapses, dendritic growth. APP itself is involved in neuronal survival as well as regulation of endothelial nitric oxide, which has a protective role. The C99 and C83 residues have role in neurite growth. So next, coming to normal tau physiology. What is tau? Tau is a microtubule associated protein which helps maintain the integrity of microtubules and in the transportation of molecules across from axons to synapse. The primary functions are microtubule stabilization, axonal transport, neuronal plasticity, protection against microtubule depolarization in states of stress and cold induced, and have a role in development. So what are microtubules? These are considered as path roads which help in the transport of vesicles, neurotransmitters, mitochondria from the axon, soma, to the synapse and helps in retrograde transport. The phosphorylation, limited phosphorylation of tau protein helps bind it to the microtubule and stabilize the microtubule. Tau is intrinsically disordered. Similar to this has the N terminal as well as the carboxy terminal, tau 441, which is spliced by the MAPT gene into either 3 repeats or 4 repeats depending on the inclusion of exon 10. And this repeat region is the site prone for beta sheet aggregation. This protein rich domain, that is site for phosphorylation and other post transcription modification. The N terminal interacts with plasma membrane, actin, and signaling molecules, determines the spacing between microtubules. The C terminal helps regulate microtubule affinity, and it is also part of pathological filament core in AD. So what is tau is intrinsically disordered. So it has no stable 3D structure, which helps its versatility. So it can easily arrange the microtubules and keep its integrity as well as disintegrate and allow to form new microtubules. So normal tau homeostasis, how neurons maintain healthy tau, it is by a balance between phosphorylation and dephosphorylation. Phosphorylation through kinases, that is glucagon synthase kinase 3 beta, cyclin dependent kinase, microtubule affinity kinase, and calcium calmodulin dependent protein kinases, and a balance between phosphatases which dephosphorylate tau. The dynamic microtubule binding and release. Tau stabilizes axons. Controlled detachment supports transmode. Chaperone regulation, that is by prevent misfolding, refold tau and send damaged tau to degradation. Proteostasis pathways through ubiquitin proteasome system clears misfolded tau. The balance between 3R and 3 repeat and 4 repeat tau isoform expression. These are generally in 1:1 ratio or 4 repeat that promotes aggregation. The healthy mitochondria and low oxidative stress support proper phosphorylation and folding and controlled extracellular release. So homeostasis, no aggregation, maintains the stable axonal transport. There is no seeding or no propagation. So let's move on to the pathology of amyloid. So amyloid is not only associated with Alzheimer's disease, it is also associated with cerebral amyloid angiopathy, where A beta deposits in the leptomeningeal and cortical blood vessels, presenting as recurrent lobar hemorrhage or cortical bleeds, superficial microbleeds, and it often coexists with Alzheimer's disease. Dementia with Lewy body, about 6, though the primary pathology driving is alpha synuclein, about 60 to 80% have coexisting amyloid pathology as well. Then Parkinson's disease, a significant proportion of Parkinson's patients have amyloid. The amyloid positivity increases the risk of cognitive decline. Down syndrome, trisomy 21, that is additional APP gene, which increases the APP overproduction of APP and overproduction of A beta. Nearly all develop amyloid plaques by the age of 40, and this has a early onset AD phenotype. Normal pressure hydrocephalus, about up to 20% show amyloid positivity. This may affect, the amyloid positivity may affect prognosis post shunting. Chronic traumatic encephalopathy, it is also predominantly tau pathology, but amyloid plaques can be found. Vascular dementia is a mixed pathology. Then limbic predominant age-related TDP 43 associated encephalopathy is mixed pathology of TDP 43, amyloid beta pathology, as well as hippocampal sclerosis. In prion disease, it is not the amyloid beta, but PRP amyloid plaques. That is the systemic amyloidosis have AL as well as ATTR, and even with normal cognition, above 20 to 30% of people above the age of 70 show amyloid deposition. So amyloid beta is maintained in a steady state level. As I said earlier, there is normal physiologic process where alpha secretase and beta secretase are working in normal physiology. About only about only 10% of A beta is produced in day-to-day life. If the either production is more than the imbalance between production and clearance leads to pathology. So what are the factors that increase production? Genetic factors, that is mutation in the APP located on chromosome 21, presenilin gene 1 that is located on chromosome 14, presenilin gene 2 that is located on chromosome 1. This increases the gamma secretase activity, so increasing the cleavage of APP. Decreased clearance, the genetic factors are ApoE4 allele or SORL1 variants. Then coming to secretase activity, with aging, there is a shift from alpha secretase to beta secretase activity. So increased amyloid beta is generated, and decreased clearance, decrease in lymphatic flow, and decreased enzymatic activity. The enzymes involved in the process of A beta are neprilysin, insulin degrading enzyme, and endothelial converting enzyme. These become less active with age. Inflammation and stress, oxidative stress increases APP cleavage and lead to microglial dysfunction, chronic inflammation leading to decreased clearance. Vascular or blood-brain barrier leads to impaired transport. Damage to blood-brain barrier leads to impaired transport and cerebral amyloid angiopathy. So again the same. APP gene mutations, more amyloidogenic cleavage, increase A beta 42, increase gamma secretase cleavage shift. So there is more A beta, altered secretase activity with age related changes, aging neurons, there is subtle shift in secretase balance, oxidative stress, insulin resistance, hypoxia lead to increased production. Decreased clearance is by impaired lymphatic system. The most of the lymphatic is activated in the slow wave sleep, that is NREM stage 3, N3 sleep. So if sleep deprived, then sleep dependent CSF flow is reduced, poor perivascular clearance, reduced enzymatic degradation. ApoE carriers have impaired A beta transport across blood brain barrier, slower clearance. What is the genetic role of Alzheimer's? These are categorized into two categories. One is deterministic, that is autosomal dominant, rare, accounts to less than 1% of all Alzheimer's disease. These genes are APP, presenilin 1, presenilin 2. If someone has one of these mutations, they will develop Alzheimer's disease. Penetration is 100%. Penetrance is 100%, slightly less for APP and presenilin 2. They have the early onset Alzheimer's disease pathology. Other common risk genes, these increase non-deterministic. These are common. They increase risk, but do not guarantee the disease. Most important is E4. If a person has one allele of E4, the risk is 3 times earlier onset. 2 copies, the risk increases by 10 to 12 folds and much earlier onset. But it is not deterministic. Many carriers never develop AD, and many AD patients do not carry E4 allele. So environment and final determinant factors are environment and lifestyle. Other risk genes which are smaller effects are recently coming into clinical research and interest are TREM2, that is associated with microglia, APCA7, sorrel gene, already talked about involved in the clearance of A beta, BIN1. So the amyloid, it has deposits in 3 phases. One is the lag phase, where A beta monomer exists in dimer or trimer forms. These are soluble non-fibrillary oligomers. These are the most toxic and primary mediators of earlier synaptic damage. Then it can take 2 pathways. One is the non-soluble fibrillar oligomers, protofibrils. These are less toxic and they serve as chronic source of oligomers. The other is through non-fibrillary oligomers. A beta 42 is the isoform most prone to form both soluble and fibrillar oligomers. So how does this affect the normal synaptic transmission? How is it neurotoxic? So A beta binds to various receptors, AMPA receptors, acetylcholine receptors, NMDA receptors, as well as A beta itself can form pores in the synapses, which lead to calcium toxicity, dysregulation of homeostasis, mitochondrial damage, and production of reactive oxygen species, as well as it increases the activity of kinases, leading to hyperphosphorylation of tau, which finally leads to formation of neurofibrillary tangles, mitochondrial dysfunction, as well as synaptic dysfunction and neuronal loss. Now coming to the tau pathology, as earlier discussed, tau exists in predominantly 3 repeat tau or 4 repeat tau. If there is an imbalance, you can get one of pick disease, that is one variant of frontotemporal dementia. 4 repeat has PSP, CBD, so what normal tau versus pathological tau. Normal tau, there is balanced phosphorylation, it is reversible. Pathological tau, there is hyperphosphorylation and irreversible. Normal tau, it is soluble, exists in monomeric forms. Pathological tau exists as insoluble oligomers, fibrils, and tangles. Normal tau has strong binding to the microtubules, stabilizes axons. Pathological tau is detached, causing microtubule instability and axonal break. They are isoforms. It is in balanced 1:1 ratio. There is isoform imbalance in pathological tau. Misfolded in the pathological tau, the folding is maintained by HSP 70 or 90. Clearance, there is efficient ubiquitin proteasome system plus autophagy. Here the clearance is overwhelmed, leads to accumulation. These are mainly located in the axon or soma. These are mislocated to the dendrites. Seeding or spread, there is no propagation, and pathological tau lead prion-like propagation along the networks. They have stable axonal transport. They lead to synaptic failure and neuronal death. So what are the factors? There are genetic factors, that is mutation in the MAPT gene or APP-PS1 mutations. There is a disturbance in the ratio, loss of function or gain of toxic function, leading to tau dysfunction and aggregation, leading to neurodegeneration. So what happens? The physiologically phosphorylated tau binds and stabilizes microtubules. When they become hyperphosphorylated, they destabilize microtubules and detach. These monomers are more form soluble oligomers, which lead are more sticky, and they bind to one another, leading to formation of neurofibrillar tangles. So the neurofibrillar tangles then activate microglia, cause inflammatory cytokine release through IL-1 beta, which leads to, again, this becomes a positive feedback loop where more soluble, it causes hyperphosphorylation. Again, more microtubules are destabilized, more oligomers are produced, more tangles are formed. So what makes tau pathology unique in AD? Begins in entorhinal cortex even before amyloid. Amyloid presence massively accelerates spread into neocortex. The pattern follows functional networks, that is default mode network in the typical amnestic AD. Tau spread correlates directly with symptoms, memory followed by visuospatial and executive. As earlier said, that the imbalance between 3 repeat and 4 repeat tau leads to either pick disease, CBD, and other forms of taupathy. In Alzheimer's, the ratio is maintained, and these lead to formation of classic paired helical filaments. So A beta leads to microglial activation, leading to NLRP3 inflammasome, cytokine release, and tau phosphorylation. Tau is the primary driver of neurodegeneration, not amyloid. So AD needs both A beta and tau. Alzheimer's, tau without amyloid is primary age-related taupathy. It is localized, it is mild, slow. Amyloid without tau often cognitively normal. Both present, there is aggressive neocortical taupathy leading to clinical AD. So next we'll be talking on neuroinflammation, which has become the points of interest. For decades, AD focused mainly on amyloid and tau. Next. But failures in the amyloid only therapies highlighted the need to understand the third pillar, that is inflammation. Neuroinflammation is not just a response, but an early contributor. Like amyloid marker and tracers for tau, they have developed tracers for inflammation as well, that is translocator protein. So PET studies have shown that glial activation occurs even before there is measurable cognitive decline. Next slide. So microglia, they are central players in the AD inflammation. In the normal homeostasis, they help prevent formation of A beta and clearance of A beta. Once they are activated by TREM2 into or chronic inflammation leading to disease-associated microglia, which is driven by A beta, tau, and ApoE4 alleles. These lead to increased phagocytosis of amyloid, loss of function, and increased plaque toxicity, release of interleukins, tumor necrosis factor alpha, complement proteins, leading to synapse pruning. The previous slide. So this is the homeostatic microglia, and this is disease-associated microglia phenotype. It is a subset that are found near sites of neurodegeneration and express certain genes. These are upregulated by TREM2, ApoE, and other genes. It has early in the stage, it may have a protective role. Chronic inflammatory response becomes harmful in later stage. And this underscores the complex role of microglia in onset and progression of AD. So there is lot. So okay. Then let's go to the last few. Yeah, so because of want of time, we are skipping. So AD is a multi-pathway, not a single pathway. A beta is necessary, but it is not sufficient to form Alzheimer's. Tau determines where the degeneration happens, and microglia determine how fast it happens. Network determine whether it is affecting the typical default mode network or the semantic networks or the visuospatial cortex, which variant emerges. Neurodegeneration determines when the symptoms begin. Biomarkers now allow in vitro definition of pathology. Therapies are shifting from amyloid-centric to multi-target approaches. So precision diagnosis plus targeted therapy is the future direction.
Thank you for a wonderful session, sir. Now the session will be open for queries and questions. Once again, thank you, sir. It's an honor to have Dr. Vijay L. Aras, sir, with us today. We request sir to kindly accept our small token of appreciation. We request the chairpersons to hand over the memento and honor our speaker. Thank you, sir. We'd also like to thank Dr. Vidya C.S. ma'am and Dr. Vani K. ma'am for chairing the session. May I now request Dr. Sunita ma'am, Senior Physician, Adi Chanchandgiri Medical College, to present a small token of respect to our chairpersons. Thank you, ma'am. Thank you, dignitaries. May I now welcome Dr. Harsha S. Sir, Professor, HOD, Department of Neurology, Jesus Hospital, Mysuru, and Mr. Narendra Sir, Executive Director, ARDSI National Office, to chair the session. Let's begin the second session of the day on modern tools for early dementia detection, biomarkers explained by Dr. Yogesh Shah Sir, geriatrician and Director of Palliative Care Services at Broadlawns Medical Center in Des Moines, USA. We request the speaker of the session, Dr. Yogesh Shah Sir, to occupy the seat on the stage, and we request the chairpersons to introduce our speaker to all of us. Over to you, sir.
Pleased to welcome Dr. Yogesh Shah. He is Medical Director in Broadlines Medical Center, Des Moines, Iowa. And he has fellowship from Fulbright, and also he has been past associated with Mayo Clinic till 2013. And then he has been a recipient of Iowa Physicians Watch in 2025. And he has been also the Iowa Welcome to the World Award by Iowa International Center, and he has specialization in geriatrics, family medicine, hospice care, and palliative care. And his clinical focus has been working at the Broadlands Geriatric and Memory Center, and his medical training has been in Mumbai. And he has accomplished
Narendra, I
lot
think we
many
should
things.
be.
Yeah.
I got only 20 minutes to
Yeah.
talk. If you talk,
Thank you.
thank you.
So
Thank you.
we welcome. It is a very proud moment for us. Thank you so much.
Thank you, thank you, thank you all. So let me just start, since the time is of essence. And Dr. Urg, you did a wonderful summary on the pathophysiology of amyloid. So what I'll do is talk the clinical application, and that's what I do in my practical life in USA. So whatever I talk about, unfortunately, fortunately, it will be focused on US based, but as I see India progress is so fast and leapfrog many things, very likely what I'm doing in USA will not be just limited to AIMS or NIMHANS, but will become part of many hospitals. And so that's my focus of how to apply what we heard from Dr. Urs about applications. So currently, as you heard, by the time dementia diagnosis happens, especially the Alzheimer's diagnosis happens in the clinic, in my clinic, the brain has seen changes 20 years prior to the clinical symptoms. So 20 years before the clinical symptoms, Alzheimer's protein, amyloid protein gets collected. And now we have capacity, and including in India, we have blood tests. I do blood tests every day in my practice to check for these amyloid levels, whether it's p-tau 217 or p-tau 181. And that's the application we'll talk about. So let me explain to you what clinically happens in the mechanism, what we heard about. So by the time somebody, this is the x-axis is the clinical stage, and this is the y-axis, the biomarkers. So on x-axis, by the time somebody gets diagnosed with dementia, especially Alzheimer's dementia in 2025, the pathology of that has started in the brain approximately 20 years before that. So in 2005, that brain has started to collect extra amyloid. As you heard from Dr. Urs, there's excess production and less of the excretion of the amyloid protein. And that amyloid protein, now we can check in the form of p-tau 217 in the blood. And there are other ways also to check it. There are, of course, CSF, there's amyloid scan and others. And this amyloid, excess amyloid in the brain, causes intracellular changes in the form of tau phosphorylation. And this tau is the neuronal transportation. So now, because the tau collection causes the inflammation and the brain cell death. So that's the process which starts long time before the clinical changes happen. So let me summarize. By the time clinical diagnosis happen in the brain, the brain has seen changes 20 years before in the form of amyloid. And that's what so far we're going to target about. That's not the only mechanism, but one of the main mechanism. And that causes tau changes. Tau phosphorylation happens in many ways, and that causes a cellular death, inflammation, as you heard. And in future, very likely there'll be anti-inflammation drugs come out. And that inflammation causes very early changes, clinical changes called mild cognitive impairment, or if not treated or not diagnosed early, that MCI then becomes clinical dementia, where the person is now not able to function enough and lose the independence in some way, whether it's in the form of not able to cook on their own, not able to drive on their own without getting lost, or getting into financial scam. I was just talking to someone, and then even in India, the financial scams, especially among seniors, are becoming more common because of possible memory changes, possible dementia in that person without the diagnosis. Unfortunately, in India, in USA, 50 to 70 to 80% of patients with clinical diagnosis of dementia do not get the formal diagnosis. It's a huge number, huge gap, and that's what we are all here today to work on that. So that's the window of opportunity for us, that what can we do if we can focus on, and luckily since so many of you are students in pharmacy, in medicine, nursing, if we can focus on this early stage of MCI, mild cognitive impairment, I feel we can make significant impact in diagnosing the people early on. So that's the window of opportunity I feel strongly feel we have. And so what is the opportunity? And Dr. Manjari Tripathi is going to talk about this, that if we detect people early, the question was asked to me outside earlier, what can we do and how can we do, what can we do to reduce our risk? Now the science tells us that up to 45%, maybe more in India, maybe up to 70% of patients, we can reduce the risk of dementia by managing some of the risk factors. There are currently, according to Lancet, there are 14 risk factors which are focused on. Dr. Tripathi, I'm sure, will go into a lot more detail, but I want to just show you that there are 14 risk factors which the science tells us. Some more applies to India, fewer to other countries. But for here, for example, if we can manage our vascular risk factors, diabetes, hypertension, cholesterol, we can reduce the risk of vascular and Alzheimer's dementia significantly. So what are the biomarkers? How can we do this? These are again applied more for US, more for research centers here, NIMHANS and AIMS and others, but very likely it will become part of our pathology, part of, I hope you can see from there. If you want to come on this side, the slides are more probably, yeah, feel free to come here. It's hard to, so what are the biomarkers available? Based on what we know, as I mentioned, if the clinical pathology happens 20 years before, and now these are the few of the ways we can detect biology of the changes early on, meaning the CSF changes in the brain in the form of less CSF coming out in the CSF in the brain, more getting collected. That happens 20 years before the clinical diagnosis. So if I do LP in somebody now and they have LP less of amyloid beta 42 and 40, their chance of becoming MCI in 15, 20 years is very high. That's what it means. And then the amyloid PET scans are available in few countries and very likely here. So I do patients, everybody who gets the treatment of anti-amyloid, we get amyloid scans. Then after that, the tau pathology starts changing. We can check on that also. And then comes the inflammation. And very lately, actually, just few years before the clinical diagnosis, the actual MRI changes happen. So by the time we get MRI, and if we see the MRI changes of the lower hippocampal volume or overall brain atrophy, that's quite late in the pathology, as Dr. Urs, you mentioned. So So what can we do? Three major ways we can check the biomarkers. One is, of course, the neuroradiology, the oldest way. Second, newer ways are LP, lumbar puncture, CSF. And the most recent way is the blood biomarker, the plasma biomarkers. So I'll just quickly go over what's available in USA, in the rest of the world, and what is possible in India also. The CT MRI is the most common. We can check, but that doesn't tell us what type of pathology. It just tells us somebody has microvascular changes or not. The FDG PET scans are available. There is more to check difference between Alzheimer's and frontotemporal dementia. And more recent one are the amyloid specific, amyloid or tau specific PET scans. These are some of the images of my patient population where amyloid scans are done. If it is negative, it will show less of these bright colors. There are three different tracers available in US. That's why these are the three different types of amyloid PET scans. And the tau PET scans are not clinically available in US yet. It's more in research, but very likely in future when the tau pathology, tau treatments become available, we'll have tau PET scans also. CSF is most commonly done here. It's available in the different forms. We can check for the ratio between amyloid beta 42 and 40. And if less is out in the CSF, that means more is collected in the brain, and that means person is likely having Alzheimer's pathology. The total tau is checked or phosphorylated out in the form of p-tau 181. And most recently, just before I came from US, the Mayo Clinic has started to now check for alpha-synucleinopathy in the CSF, check for somebody with Lewy body or the whole spectrum of alpha-synucleinopathies. What are the blood-based biomarkers? These are some of the more common ones currently used and approved by FDA in USA, and most recently approved the Fuji Rubio lab is approved in India also, which is the p-tau 217 and p-tau 181. 181 in US is approved more for very high negative value, meaning it's used for primary care. If it is negative, that means the person has less likely to be amyloid positive, and p-tau 217 is more specific and specificity for Alzheimer's. So if it is positive, the person is more likely to have Alzheimer's. These are the future one. The NFLC, which is inflammation. GFAB is also again inflammation, and ATN is amyloid, tau, and neurodegeneration. So this is my knowledge, and Dr. Tripathi and others in the room might have better, but I feel currently some of the tauopathies, CSF is available here, as well as the very likely this blood, at least the Agape I know is doing it with Japanese company Fuji Rubio, and very likely many others will come soon. So this is going to be one of the fastest growing field in the dementia, in Alzheimer's, about plasma-based biomarkers. So let me tell you what's in the future, and then end by going into what is coming in the treatment-wise. Very likely the future of biomarkers will have some kind of combination biomarker, even at the point of service, even in the primary care someday, where we'll be able to check for amyloid beta 181. So how do you apply all this knowledge in clinical practice? Two ways. One, we have currently symptomatic treatments. As you know, those of you are pharmacy students, we have currently acetylcholinesterase inhibitors and NMDA antagonists. Those are available, but they don't do anything to the pathology. They don't change the amyloid, they don't change the tau. It's mainly symptomatic. But now also we have disease modifying therapies in the form of amyloid targeting therapies. As I mentioned, one of them got recently approved in India just last couple of weeks ago. And in my practice in US, I use them, both of them, quite regularly. So I have patients receiving both. There are two types of anti-amyloid targets. One is by a Japanese company called Eisai. It's a lecanemab, Leqembi, And second one by Lilly got approved here. It's donanemab or Kisunla in US. So I have patients on both of them with relatively good results. Thank you. And very likely the future will have combination therapies, as Dr. Urs you mentioned. Will have anti-amyloid targeting therapy. Will have possible anti-tau therapy someday, anti-inflammation, and along with that, the treatments with symptomatic treatment and prevention. What you'll hear from Dr. Tripathi. So I feel, to close, that I strongly feel that this is right time for all of us who are interested in the field of dementia to be more involved, for the students especially. This is the right time to be involved and see what's happening. And I strongly feel in very near future, the use of biomarkers, the use of dementia targeting therapies will become more and more common. Currently, it's very expensive. It's $26,000 in US, almost 28, 30 lakhs rupees. But of course, the price has to go down to be more practical. So with that, I'll stop here. I don't want to go over my time. I was told 20 minutes. So, and then take any questions if there's time. Thank you.
Thank you, Dr. Shah, for a wonderful exposition of the biomarkers in Alzheimer's. Now,
do you see them replacing the CSF biomarkers? Because CSF is very painful to do at this age. Usually the ligaments are all calcified, the needle doesn't get in, and it's not a pleasant procedure.
No, agree. So the question is, what's the role of plasma biomarker now and CSF? So, as I mentioned, my practice is only on US based, but I have, in last 2 years, since the plasma biomarker has become more popular, I have hardly had to do CSF. The only time I do CSF now, if it is a mixed pathology. If somebody is already having Lewy body symptoms along with Alzheimer's symptoms, then I would need LP to make sure what's the combination. But if it is more clinically relevant to pure Alzheimer's pathology, I don't even do CSF. Very likely, even for amyloid targeting therapy, the need for second confirmation will be less and less. So in US, the Washington State WashU University in St. Louis, they don't even do LP or amyloid scan to start the therapy. They just do it on the plasma. So I feel that the pathology and the sensitivity and specificity of plasma is as close as CSF. The need for CSF will go down significantly. So the question is about what are the other biological ways we can check for this amyloid protein, even the alpha synucleoprotein. So currently, the most proven way is plasma, CSF, and amyloid scan. Those are the three one. The many others are other tissues are tried. Skin biopsy is one of them for alpha synucleinopathy, which I do it, and it's 90% sensitive. So the skin biopsies from cervical, above the knee, above the ankle can be done, and because the alpha synucleinopathy for Lewy body comes from periphery, that can be checked. Same way, there are a lot of studies going on. Should we check the retina, the back of the eye, for the vascular changes, the amyloid changes? Should we check saliva for other biomarkers? Not well proven yet, but I think it's a good approach. The question will be, what's the sensitivity, specificity? And since if blood is getting better, then why go for others? But I think the blood, I feel there was one small study in Germany that even the dry sample taken from the hospital, just dry sample is as sensitive to the plasma. And if that becomes more and more well proven, the dry sampling can be also applicable. Just like what we do for the blood sugar, for hemoglobin A1C, just the one drop of blood will pick up amyloid also. So the question, yeah, go ahead.
Or patient presenting even as a preventive.
So the question is about when to use, if this blood biomarkers p-tau 181 217 becomes more and more available, when to use it. I think the reason in USA the FDA approved both is exactly what you're saying, meaning the hopes are that in primary care for family physician, GPs, internal medicine, we can, if patient comes with or without symptoms at age of 60, 65, my recommendation is to do annual check on cognition, either through MOCA, Minicog, Hindi, MMSE, or other tools you might be used to, and rule out any reversible cause, thyroid, B12, and do p-tau 181 if other rules are not there. So that's in the primary care. If they come to the specialty clinic like mine, then I do p-tau 217 to confirm the diagnosis. So I think both have role depending on what site we use it.
Do you recommend anti-amyloid therapy?
Yeah, good question.
Biomarkers in tracking the outcome of the disease modifying drugs.
So both are,
The level of these biomarkers, are they monitored during the treatment?
Sure. Before I go further, I want to look at the organizers, make sure I'm not going above the time. Last question. Okay. So last question. So I think both are good questions about how should we use the biomarkers for either following the treatment or deciding when to treat. So amyloid p-tau, even though it's called p-tau, phosphorylate tau 217 or p-tau 181, it's checking more amyloid than tau. It's a 60-40 ratio. So 217, if it is positive, and then at Mayo there's a range. It's not a one number. It's a negative, positive, and there's an intermediate range. So if that is positive, there is a chance that my amyloid is high, and 60% of that comes from amyloid, 30-40% comes from tau. So if it is a mixed pathology, it can be still positive, but not as much. If it is pure tau pathology, then less likely to be 217 to be positive. So it's not tauopathy, it's amyloidopathy. For monitoring, yes, I think I use as a monitoring, meaning once everybody gets p-tau 217 before starting donanemab or lecanemab, and every 6 months, I check and see what happens to that level. In many cases, it will come down because that's what anti-amyloid therapy is doing. So it does match very well with amyloid PET scan that the pathology is down. I have enough few patients where the positive before starting treatment with Kisunla, donanemab, and the amyloid scan becomes negative and the biomarkers become negative. Thank you. Thank you all.
Thank you, sir, for such an informative session. It's an honor to have Dr. Yogesh Shah, sir, with us today. I request sir to accept our small token of respect. May I request our chairpersons to honor our speaker by presenting him with a memento. Thank you, sir. We'd also like to thank Dr. Harsha S. Sir and Mr. Narendra Sir for chairing the session. May I now request Dr. Yogesh Shah Sir to present our chairpersons with the memento as a token of our appreciation. Thank you, dignitaries. I request all the participants of oral presentation to assemble in the geriatric library present in 4th floor. I repeat, I request all the participants of oral presentation to assemble in the geriatric library at 4th floor after the inauguration. I request all the dignitaries to kindly assume the seats on the dais. I now request Dr. Yogesh Shah Sir, Dr. Basavanagaudappa Sir, Dr. Manjunatha Sir, Srimati Venu Vora Sir, Ma'am, Dr. Hanumantachar Joshi Sir, and Dr. Pratibha Parera Ma'am, and Dr. Madhu CP Sir to kindly assume the seats on the dais. By seeking the blessings of His Holiness, Jagat Guru Sri Shivaratri Deshi Kendra Mahaswamiji, I wish you all a very good morning. It is with immense joy and pride that we welcome you all to the ARDSICON 2025 International Conference on Dementia, Policy, Practice and Progress, organized by Alzheimer's and Related Disorders Society of India, Mysuru chapter, together in association with Department of Geriatrics, Jesus Hospital, Jesus Academy of Higher Education and Research, Mysuru, Sharda Vilas College of Pharmacy, Mysuru, and People's Association for Geriatric Empowerment. Respected dignitaries on the dais and off the dais, delegates, teaching and non-teaching staff, press and students, it brings us immense joy to present to you a plethora of knowledge to seek and imbibe. Dementia is a relentless and progressive brain disorder which gradually erodes a person's memory, thinking ability, and eventually their ability to carry out simple tasks. The condition not only affects the patients, it places an immense burden on families and caregivers as well. And as the important pillars of healthcare system, it is our duty to spread awareness about dementia, the current policies, practices, and progresses. And we are immensely thankful to the organizers for organizing this wonderful event and for paving the path towards better policies, practices, and approaches in the field of dementia. As Plutarch once said, the mind is not a vessel to be filled, but a fire to be kindled. With this vision, we once again welcome you all to ARDSICON 2025 International Conference on Dementia, Policy, Practices and Progress. With this, let's begin this auspicious day by invoking divine presence. May I now call upon Ms. Yashashwini and Neha from 2nd Farm D for a Saraswati Vandana.
मुदाकरात्तमोदकं सदा विमुक्तिसाधकं कलाधरावतंसकं विलासिलोकरक्षकम् अनायकैकनायकं विनाशिते वदैत्यकं नताशुभाशुनाशकं नमामि तं विनायकम् न तेतरातिभीकरं नवोदितार्कभास्वरं न मत्सुरारिनिश्चरं न तादिकापदुद्धरम् सुरेश्वरं निधीश्वरं गजेश्वरं गणेश्वरं महेश्वरं तमाश्रय परात्परं निरन्तरम् समस्तलोकशङ्करं निरस्तदैत्यकुञ्जरं दरेदरोदरं वरं वरेवक्त्रमक्षरम् कृपाकरं क्षमाकरं मुदाकरं यशस्करं मनस्करं नमस्कृतं नमस्करोमि भास्वरम् अकिञ्चनार्तिमार्जनं चिरन्तनोक्तिभाजनं पुरारिपूर्वनन्दनं सुरारिगर्वचर्वणम् प्रपञ्चनाशभीषणं धनञ्जयादिभूषणं कपोलदानवारणं भजे पुराणवारणम् मुदाकरात्तमोदकं सदा विमुक्तिसाधकं कलाधरावतंसकं विलासिलोकरक्षकम् अनायकैकनायकं विनाशते वदैत्यकं नताशुभाशुनाशकं नमामि तं विनायकम् जय गणेश जय गणेश जय गणेश पाहि मां जय गणेश जय गणेश जय गणेश रक्ष मां जय गणेश जय गणेश जय गणेश पाहि मां जय गणेश जय गणेश जय गणेश रक्ष माम्
Thank you for a melodious invocation. May I now request Dr. Tejaswini Ma'am, Associate Professor, JSS Medical College, Mysuru, to kindly welcome the gathering.
Yeah, a very good morning to all. With the divine blessings of His Holiness Jagat Guru Sri Sri Deshikendra Mahaswamiji, I extend a warm welcome to each one of you gathered here today for ARDSICON 2025. Jnanadeep, Jnanam, Dayamarg. Knowledge is the lamp and compassion is the path. This is the true essence of this conference. It's an honor to begin this event in the presence of our esteemed chief guest, Dr. Baswan Gaudappa Sir, our Vice Chancellor of JSS University. He's a remarkable and a visionary leader whose commitment to education, health, and innovation has empowered our university to what it stands today. We are truly grateful to have you with us today, sir. Thank you. A special welcome to Srimati Renu Hora, Chairperson of ARDSI India and Secretary General of ARDSI New Delhi Chapter. Ma'am, your tireless efforts in dementia care and advocacy provides hope to countless families. Welcome. We are also honored to have Dr. Yogesh Shah from Broadlands Medical Center, USA, as a special guest. Dr. Yogesh's contributions to geriatric medicine and community health are truly commendable. A hearty welcome to you, sir. My respectful welcome goes to Dr. Hanumantachar Joshi, President ARDSI Mysore Chapter, Principal of Sharda Vilas Pharmacy College, Mysuru, and the organizing chairperson of this conference. So your guidance and dedication are instrumental in making this event possible in our city. Thank you. I also take great pride in welcoming Dr. Pratibha Pereira, Organizing Secretary, Head of the Department of Geriatrics, and my mentor. Ma'am, your leadership, enthusiasm, and energy, they continue to inspire us every single day. I also extend a warm welcome to our medical director, Dr. C.P. Madhu, who's been a pillar of strength and an inspiration to all of us. Welcome, sir. To all other dignitaries, delegates across globe, and dear friends, thank you for being here. Your presence reflects a shared commitment and dedication to build a more inclusive and supportive society. Once again, I welcome you all and wish you a meaningful, insightful, and an enriching experience throughout the conference. Thank you, one and all.
Thank you, ma'am. A warm welcome to you too. Asatoma Sadgamaya, Tamasoma Jyotirgamaya, Mrityorma Amritangamaya, Om Shanti Shanti Shanti. Light expels darkness and brings life. May I now request Dr. Yogesh Shah Sir, Medical Director, Broadlawns Memory Center, USA, to inaugurate the day by lighting the lamp. I request all the dignitaries to join the same.
चक्रबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः.
Thank you, sir. Thank you, dignitaries. May I now request Dr. Yogesh Shah Sir for an inaugural address.
Oh, this is quite an honor. This is my first. I've given many talks in USA and around the world, but this is the first time I got to do this. Thank you. It's quite an honor to be part and to do the inauguration ceremony. I've seen many times and on pictures, and I thought, someday, what is this? And it must be big. So thank you. I feel part of it. So what I like to do, couple of things I like to share, and luckily there are so many students. So I would like this inaugural event and conference to be we can envision the future where we can apply what you're going to hear today, the biomarkers you heard, you're going to hear about risk reduction. And if we can vision to apply this knowledge and detect our patients. Sorry? Detect our patient.
100 to 120 per minute.
I think I've given. I'll finish. So 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 I think we should work towards, and especially students, if you can use these next 2 days of the conference, where you can meet and talk to us, meet us, learn from the teachers, and see how we can use this knowledge to apply in our practice, where we can use the science of risk reduction, science of biomarkers, and pick up patients as early as possible, and then reduce the rate of dementia. Even if we do small reduction, it will go long ways to make a real social impact. So my heartily congratulations to the Mysuru group, the Artsy National Group, the GSS Hospital Geriatric Department, Madam. A wonderful way to have all of us together to make some meaningful scientific discussions. And the next 2 days, all the best to all of us to do in next 2 days some good, meaningful talks about how to reduce the risk and early detection. And as you know, so far, unfortunately, dementia has become a social thing, a social stigma. But with this knowledge of biomarkers, the knowledge of early detection, the knowledge of prevention, more and more in US, I see a lot of younger people coming to me now, people in their 50s and 60s, especially post-menopausal women. They come and they are now coming out to do something meaningful. So we can all learn from that. So thank you again, Dr. Joshi, and I had a good time discussion yesterday about the future. So I very thankful to be part of this big event. Thank you.
Thank you for a wonderful address, sir. It's an honor to have Dr. Yogesh Shah, sir, with us today. I request sir to kindly accept the front seat and accept a small token of respect. I request the dignitaries to do the honors. Thank you, sir. Thank you, dignitaries. May I now request Dr. Basavana Gaudappa, sir, Vice Chancellor, JSSA HER, to kindly release the conference proceedings of the ARDSICON 2025 International Conference on Dementia, Policy, Practice and Progress. I request the dignitaries to join the same. Thank you, sir. Thank you, dignitaries. It's an honor to have Dr. Basavana Gaudappa, sir, with us today. I request sir to kindly occupy the front seat and accept a small token of respect. I now request Dr. Basavana Gaudappa, sir, for an address.
Good morning to everyone. At the outset, I submit my sincere pranams to the lotus feet of His Holiness Jagadguru, Shivratri Rajendra Mahaswamiji, who created Mahavidyapita, created education provision for millions in this country. I submit my pranams, seek blessings from the present pontiff, our chancellor, Sri Shivratri Deshkendra Mahaswamiji, whose blessings are there for this program also. And our pro-chancellor, Dr. B. Suresh, has sent his blessings for this program. He was supposed to be here with us as one of the guests, but because of inevitable program, he has conveyed his message to all the organizing committee and the participants for a grand success of this program. The eminent speaker and the guest today, Dr. Yogesh Shah, organizing team, Dr. Pratibha Pereira, the admin secretary, as well as Hanumanthachar Joshi, convener, and our director of the hospital, Dr. Madhu, and president of this program, Renu Vora, and all the eminent distinguished faculty who have come from various parts of the country and world, and my dear participants who have come here to learn all about dementia. I like this, the terminology of policy, practice, and progress. We need to know every day some progress keep happening, and we need to update ourselves. I need not mention here about the magnitude of the problem of dementia across the world, in the country as well. The numbers are simply growing up because of three important reasons. One, we're making people to live longer than what they were pre-independence, where life expectancy was only 37 years, and now we have reached 70 plus. So naturally, when you have more and more geriatric population and more people are surviving, combating other diseases, we need to know that inevitably dementia is one important component that creeps in. Second, with the efforts by eminent neuroscientists, the chances of we picking up the diagnosis is increasing, though it is not to the extent of what should be happening, but it is increasing. So naturally, your numbers will grow up. Number three, the pattern of life we are living with and various augmenting, cascading risk factors culminating into an induction of dementia in early life is happening than earlier. So with all these three reasons, we have enormous magnitude of dementia in the world, in the country. So it gives a challenge to the medical fraternity, medical researchers to do more than what's happening right now. I was just discussing with Yogisha. He said he gave up chief medical officer position and concentrated looking at the magnitude of the problem, started working in that area. Such focused work has to happen from various researchers. As mentioned by him, first is, can we prevent this disease? If so, how do we do that? He said 14 risk factors are identified. If you can reduce the risk, you are preventing to extent possible. The second is early diagnosis, which is not happening in most of the time. Diagnosis of dementia is already when it is progressed. When they come and tell, oh, this is what's happening to my father. So you pick up, by the time it's already too late, too much of damage would have occurred. So there is a need for early diagnosis. He went on mentioning in his presentation about the advancing neuroimaging, number one. Number two, the new and new innovative biomarkers, either in CSF or serum or saliva, somebody was asking. So there are advances happening, but there is need of more and more such thing to happen. So we pick up before it starts, or pick up at least at the early stage of the disease, so that the misery of progression can be prevented by apt use of the newer molecules, like he was talking about, the disease modifying therapies like monoclonal antibodies. If that can come in and prevent and retard the progress of the disease, we can prevent the misery of dementia creeping in and posing a challenge to the caregivers and the family members, as well as the medical professionals at home. Most important component is managing once you have diagnosed. It is not just by medication. More importantly, it is by developing professional caregivers of various strata, starting from his caregiving, from nutritional need requirement to be taken up. How do we avoid embarrassing situation faced by the individual, and also taking care of his daily needs in advanced stage, and keeping the dignity of humanity as a prime focus. We need to put our efforts to produce. There are hardly professional caregivers for this disorder. There are few, they are insufficient in numbers, because the number of dementia is growing so fast that we need to concentrate on providing and creating more human resource, like professional caregivers at various levels, starting from his basic need to be met with to advanced medical assistance. Having said this, I will not take much time, because these platforms, I told Pratibha as well as Hanumanta Joshi that the interaction should be there in adequate quantum, with a sensible question and a very appropriate answer from the experts who have done a lot of work. And also, the conference should conclude with a questions on where do we move forward in the area of all these areas, like, can we prevent it much better than what's happening today? Can we make it pick up very early? And can we have better advanced therapy to reverse the disease if possible? If not possible, let it retard the progression. With these few words, I congratulate the organizing committee for convening such a wonderful event, and I'm thankful to all the resource persons who have come here to deliberate and give the needed knowledge and skill to the participating delegates. Thank you all.
Thank you for the words of encouragement, sir. It's an honor to have Dr. Basavanagaudappa sir with us today. I request sir to kindly accept a small token of respect. I request the dignitaries to do the honors. Thank you, sir. Thank you, dignitaries. May I now request Dr. C.P. Madhu sir, Medical Director, Jesus Hospital, Mysuru, to kindly address the gathering.
As my friends, all the participants, I would like to congratulate again Department of Geriatrics led by Dr. Pratibha Pereira, having organized such a wonderful program. As addressed by your previous speakers, dementia is a very challenging problem. There were days when people realized, that dementia means at the end of the life. It's not so anymore. As said by Dr. Basungura, I think a lot of risk factors are there. And these are risk factors which are identifiable. If you can identify the risk factors and prevent them, to a large extent, dementia can be addressed. And a lot of new things have emerged. And in this direction, I think to address, we have pioneers in the field of dementia who have come from abroad and from India also. I hope by the end of today or by tomorrow, I think we would have had a lot of information, a lot of interaction, a lot of discussion on this subject. And I hope all of you will enjoy this program. Good wishes. Thank you very much.
Thank you for the wonderful address, sir. It's an immense pleasure to have Dr. C.P. Madhu sir with us today. I request sir to kindly occupy the front seat and accept our respect. I request the dignitaries to do the honors. It's an immense pleasure to have Srimati Renu Vora ma'am, Chairperson, Alzheimer's and Related Disorders Society of India, New Delhi, to have with us. I ask ma'am to kindly occupy the seat on the dais and accept our small token of respect. I request the dignitaries to do the honors. Thank you, ma'am. Thank you, dignitaries. May I now request Dr. H. Joshi, sir, Chairman, LOC, ARDSICON 2025, and Principal, Shardavilas College of Pharmacy, Mysuru, for an address.
Very good morning to everyone, and a hearty welcome to Mysuru to all the delegates who have come to the conference. The dignitaries on the dais, especially Dr. Basavan Gaudappa, the Honorable Vice Chancellor, JSS AHER Mysuru, Dr. CP Madhu sir, the Director of JSS Hospitals, Mrs. Renu Vora, the Chairperson of ARDSI, New Delhi, and our energy, our mentor and guide, Dr. Pratibha Madam, the Head of Department of Geriatrics, JSS Medical College, Mysuru, and our dear friend, now he has become almost like Mysorean after 2 days, Dr. Yogesh Shah, who has come all the way from USA to deliver a wonderful talk. And all our friends here who have been really working for the cause of Alzheimer's and dementia in the country and as well as abroad. We know very well for what we have assembled here. The main objective of ARDSI, that is Alzheimer's Related Disorder Society of India, is to create an awareness and advocacy among the people. We have wonderful doctors here who have spent their lifetime for finding something new. Maybe not be a complete cure, at least to make a proper management here. But it mainly relies on the general public, because till now many people are not aware what exactly is Alzheimer's and dementia, which we can clearly see in the newspapers. Yesterday we had a small debate when Alzheimer's and dementia was mentioned as Buddhi Mandate in Kannada. Those people who know Kannada here. This is the real condition in our country. Dementia has been considered as mental retardation, which is very unfortunate among the even educated people. So our intention is to make people aware and understand what are the real problems of dementia. Doctors are really doing a very tremendous work, but everything cannot be done by them, right? Researchers across the country have been working around the clock to find some remedy, a cure, which is unfortunately not available at present. Complete cure is not available. So that's why we have assembled here. Awareness is the key, and which the RC Mysore has been doing from past 13 years under the leadership of Renuji. Miraji is not here, the entire group. I am hopeful that this 2 days conference will find and will at least instigate some kind of the interest among the people here. We have the speakers, we have the chairperson as well as the delegates here who come from pharmacy, medical, nursing, Ayurveda, and all fraternities of science. And we also have general public also. We also have some dementia caregivers. So we are hopeful that they will definitely get a good opportunity to interact with the speakers here. Rightly mentioned by Dr. Basan Gaudappa sir, interaction is very much required. So I would request my young friends here, so kindly be free to interact with people. And yes, let us work for dementia, because very well our slogan, remember those who cannot remember, right? So with this, I thank the Department of Geriatrics and all the leadership of JSS University, because we have been getting a wonderful encouragement, not only this program, in the past 13 years. And especially Dr. Pratibha Madam, who I had already told you, energy, you will come to know when you interact with her. Whether it can be screening for memory. Let 1 minute I'll just take, because we should know what being done. It can be a Rotary Club meetings, it can be Lion Club meetings, or any the elderly citizen the gathering. Our team is there along with Paige, which Madam leads. People are made aware by conducting a test called as MMSE, Mini Mental State Examination, and there is also some scales available. So first people are made aware what is Alzheimer's and dementia in local language and as well as in English. And then our volunteers, especially from PharmD, they conduct MMSE test. So the people who are really concerned with memory, they get some kind of interest and they will come to any hospital, mainly JSS hospital, they'll come down here. And but very well, it's a neglected area, rightly said by even Basavan Gaudappa sir. Even though we have a lot of facilities in the entire country, I think somewhere we are lacking. May not be only medical fraternity, in all the fields also. A lot of stress is not given for people with dementia. It is always regarded as a general process of losing the memory. It's a natural process of aging, which is absolutely not. So I request everyone to kindly be attentive. Please use the opportunity. And thanks again to the JSS leadership and all the people who have assembled here. And I am very hopeful that it is going to be very successful. Thank you so much.
Thank you for the words of wisdom, sir. May I now request Dr. Pratibha Pereira ma'am, Head, Department of Geriatrics, JSS Medical College, JSS AHER, Mysuru, to kindly address the gathering.
I just want to say thank you very, very much for coming here. And I hope we do a good job to, right on track of what this is all about, policy, progress and practice. Thank you very, very much. So let's get into scientific after the vote of thanks. Thank you.
Thank you, ma'am. May I now request Srimati Renu Vora ma'am, Chairperson, Alzheimer's and Related Disorders Society of India, New Delhi, to present the presidential address.
Dear delegates, experts, and organizers, my greetings and good wishes to all of you, and as well as the dignitaries on the dais, including my colleague, Dr. Joshi. A warm welcome to ARDSI 2025 here in Mysuru. It's an honor to gather with all of you as we work together to strengthen dementia care in India. This year's theme, Dementia, Policy, Practice and Progress, brings clinicians, researchers, policymakers, caregivers, and advocates onto one platform over the next few sessions. We will learn from new research practice care, models, and each other's experience. My sincere thanks to our speakers for sharing their knowledge, and to the ARDSI Mysuru chapter and JSS partners for their excellent organization and warm hospitality. To all our delegates, I urge you to participate fully, ask questions, build connections, and take back ideas that can make a real difference to our communities. Thank you all and wish you a meaningful ARDSICon 2025. Thank you.
Thank you, ma'am. Thankfulness is the beginning of gratitude. Gratitude is the completion of thankfulness. Thankfulness may consist of words, but gratitude is shown in acts. With one such act of gratitude, may I request Dr. Shilpa ma'am, Joint Organizing Secretary, Associate Professor, JSS Medical College, Mysuru, to present the vote of thanks.
A very good morning to everyone. Seeking blessings from His Holiness Jagadguru Sri Shivratri Deshikendra Mahaswamiji, I extend my heartfelt thanks for giving me this opportunity to deliver the vote of thanks of this inaugural ceremony. First of all, I would extend my heartfelt thanks for Jagadguru Sri Suttur Swamiji, the entire JSS HER team, JSS Medical College and Hospital Management for blessing us with this venue. Hence, we mark the beginning of this conference for having an inspired and blessed venue. So I now extend my thanks for the collaborators with ARDSI Mysore chapter, which is headed by Joshi sir, ARDSI JSS Department of Geriatrics headed by Pratibha ma'am, along with Medical College, Hospital and JSS HER and Sharda Vilas College of Pharmacy and the PAGE team who are the collaborators to have this event meticulously planned. Thank you all once again. With this, I also extend my heartfelt thanks to all the speakers, students, offline, online, delegates, international speakers who are here to have this wonderful academic feast. I extend my heartfelt thanks for each one of the dignitaries, especially our very own, my teacher, our principal previously, now who is presently Vice Chancellor, Professor Baswan Gaudappa sir, who is very, very, very strong support, each one of us. I believe all of us agree with this. He's always there with whatever we go, and it is a yes. And he's here today with, despite his busy schedule. Thanks to Biji sir from all of us. Thank you, sir. I extend my thanks to Pro-Chancellor B. Suresh sir. I'm sure he would have been here due to his commitments. He has not been able to join us here. A heartfelt thanks to Professor Suresh sir
for having been with us in meticulously planning this conference. I had my heartfelt thanks to CP Madhu sir. Madhu sir, since he's in the hospital and more approachable for us, we keep going to his chamber now and then for lot of works, and he's always had lot of patience in saying yes to whatever we ask. Madhu sir, thank you very much for joining us for this inaugural ceremony. I extend my heartfelt thanks to Dr. Yogesh sir. I did have some time to speak to him this morning. Speaking to him for a couple of minutes did give me a lot of knowledge, and I think we all have lot of topics to research on listening to his wonderful session this morning. And heartfelt thanks to you for coming all the way and joining us in this conference. Thank you, sir. Renu Ora ma'am, and this is the first time seeing you in person, but I've heard a lot about her. I'm sure most of us here do know her. And it is wonderful to have you here in Mysore. And thanks for joining us on this inaugural ceremony, ma'am. I thank Dr. H. Joshi sir, who has been pillar and meticulously planned from day one to have all of us here on this occasion. So Joshi sir and team of ARDSI Mysore chapter, along with Sharda Vilas College, entire organizing committee members who are with Joshi sir, led by his planning. Thanks to each one of you, and thanks to Joshi sir for letting us with him in planning this conference. Not much to say about the dynamic, energetic Pratibha Pereira ma'am, head of Department of Geriatrics, and she's the organizing secretary of ARDSI, and she's been there much before we planned this conference, and she always encourages all the staff members and colleagues and postgraduates. Thank you, ma'am. Thanks for being here. I now extend my thanks to each of the delegates, speakers, and the sponsors, caterers, press, media, and the technical staff for being here. Apologies if I missed thanking anyone. Of course, we'll thank you in person. And I wish all of you have a wonderful, fruitful, and an inspiring conference for the next 2 days. Thank you all once again. Wish you all a fruitful conference. Thank you very much.
Thank you, ma'am. With this, we conclude our inaugural program and proceed with our 2 days of international conference. I once again welcome each one of you to join us in this journey and make it a successful one. Thank you, one and all. It's now time for a tea break. I request the gathering to kindly accept the refreshments arranged and gather back in the auditorium at the earliest for the scientific session. I repeat, I request the gathering to kindly accept the refreshments arranged and gather back in the auditorium at the earliest for the scientific session. We'll be announcing when the oral presentation and e-poster presentation will be sooner. So I request all the gathering to gather back here for the scientific session. Thank you. I request everyone to kindly gather in the auditorium. I request everyone to kindly gather back in the auditorium. I need a bit of
I request all the delegates to please take your seats in the auditorium. There's a small announcement. We have couple of stalls to the left of the auditorium, and we have Supreme Pharmaceuticals who have come up with few food products. When time permits, you can visit their stalls. And there's a brand called Multiply, and they have some accessories for elderly, especially those with dementia. There are some accessories which could be helpful to for the caretakers to take care of the patients with dementia. And also, just a small note until we have all the delegates in the auditorium, there's an application available both in your Google as well as Android, and it is called Verify You. VERIFYU, Verify You app. This is a young entrepreneurs who have come up with an application. Basically, if we put in our data in that application and our data is stored, suppose, say we have 100 of them who have these Verify You app and we have put their data. Could be a youngster or a older person, specially done to help people with Alzheimer's. Suppose a patient with Alzheimer's has missed or he has gone missing. Suppose the person who has Verify You app scans his face, his details will come on the application. So that way it will be easy to trace him. We can get connected to their family members. And this has been validated on youngsters in a run club wherein the volunteers have given their data, and in case of road traffic accidents also they have tried to scan the face and get the details. So this application is available both in Google as well as Android as well as iStore. So you all can go through that, and they have been they have contributed to this conference as well. Thank you.
Welcome back, everyone. It's now time to resume the scientific session. May I now welcome the moderators of the session, Dr. M. Kishore Sir, Professor and Head, Department of Psychiatry, JSS Medical College and Hospital, JSS AHER, Mysuru. May I now welcome the debaters, Dr. Steve Paul Manjai Sir, Senior Consultant, Geriatrician, Apollo Hospitals, Banerghatta Road, Bangalore, and Dr. Shashastra P. Sir, Dr. Shastra P. Sir, Associate Professor, Department of Neurology, JSS Medical College and Hospital, JSS AHER, Mysuru, for a debate on a wonderful topic, resource allocation in dementia. Should dementia cure research be prioritized over care? I request Dr. M. Kishore Sir to kindly introduce our speakers of the session. Over to you, sir.
Slides. So post tea, you have a great debate now, and I would like to introduce Dr. Shastara, who is our faculty here in the neurology department as associate professor. He did his MBBS here, and then he did his MD medicine from the Bangalore Medical College, and then he has done the neurology here, and he has also fellowship from the World Headache Society.
and he has numerous gold medals and awards for his works in research related to the neurological condition. I welcome Dr. Shastara. He is going to talk that the fund should go for research, and he will try to tell the audience why it is so important for the funding. It should go for the research related to dementia. The next speaker, Steve. Dr. Steve is my batchmate, so it is delight to have my batchmate as one of the person in the debate who is going to talk passionately why the funding should be going for care of dementia patients. Steve did his MBBS from Siddharth Medical College and DNB from DNB Medicine, and then he has done DGM from the NIMHANS. And he has numerous awards, and he has worked extensively in the geriatric medicine. He was also the head of the Department of Geriatric Medicine at the Jubilee Mission Medical College, Thrissur, Kerala. And he is going to talk passionately about why all the funds should go for care of patients with dementia. And I believe audience are also keen to listen why there should be this debate, where should the policies, practices and progress towards the funding, should it be for care, should it be for research purposes. And as we know, dementia is one of the most important conditions in clinical practice, and many people with diverse background are continuously working on identifying, targeting the focused approach towards delaying the advancement. Also, for those who have full-fledged dementia, how we can reduce the morbidity and mortality associated with dementia. And it will be interesting for you to note that the national and the international governments are spending huge lot of funds to understand and prevent. And in the last decade, we have seen newer and newer medications which have come in the market for the treatment and management of patients with dementia. So this debate will run in 2 or 3 rounds. In each round, the proponents will take up their respective stage and talk passionately about why it should happen. And there will also be some audience rounds for you to actively participate in the debate. But if you are in the audience and you are very active, there are some goodies for you. Okay. Either you will be in the care or research. Okay. So now we would request Dr. Shastara. He will take and he will say why funding should happen in research related to dementia. Over to you, Dr. Shastara.
Very good morning. I extend my sincere gratitude to the Department of Geriatrics for this wonderful opportunity. Dr. Kishore sir is my teacher, and very nice to meet you, Dr. Steve. So, as a clinician, as a pediatrician, as a geriatrician, it could be anything. As a doctor, what do you want for any disease? To cure the disease. That is why we are doctors. That is a fundamental principle behind why we became doctors, because we want to cure everything. We want to bring that smile in their face, and we need to get rid of the disease. I'll go just splitting the word cure versus care. Let us just think about cure. Cure restores independence. Care sustains dependence. Cure ends suffering at the root. Care only manages branches. Cure is sustainable. Care is endlessly expensive. Cure drives scientific innovation to human progress. Cure removes the emotional burden of families. Cure eliminates inequalities. Care widens them. Cure gives hope. Care often maintains despair. Cure benefits entire population. Care benefits individuals. Cure transforms a nation's productivity. Cure honors human potential. Care accepts limitation. That is a very fundamental word, cure. That is why this debate is very, very important. Mahatma Gandhi said, it is health that is real wealth and not piece of gold and silver. Cure returns this wealth to an entire society. Benjamin Franklin said, cure uplifts families and strengthens economies. Care comforts the present, but cure transforms the future. That is why the cure word is very important for us. Going further, do you think I am a fool to tell that care is not required? Definitely not. Care is very, very important for any disease. But what I'd like to tell you is, if you think cure means we are going to remove every amyloid plaque of the patient and make him dementia free, it is not the right sense. So what exactly cure means? Cure means erasing every plaque of overnight is true? No. But if cure means preventing the disease, reversing when it is possible, biologically slowing it down, then dementia is partly already curable, then rapidly moving further in that direction. That is the real meaning of cure in dementia versus a disease like dengue fever or malaria or chikungunya. That is the difference between the cure of dementia versus cure of an infectious disease. So what all cure includes? Primary prevention, stopping dementia ever happening is cure. Reversal of the dementia, of secondary dementias is cure. And biological disease modifying therapy directly targeting the pathology and to slow down the progression is cure in real sense in dementia. I will give evidences for that. Prevention at the population level, 45% of dementia can be prevented if you look after all the risk factors: hypertension, diabetes, obesity, smoking, alcohol, hearing loss, social isolation. We are all becoming nuclear. Nuclear and nuclear and nuclear is becoming social isolation. We don't know who is your neighbor in the apartment. We don't look into them. We show a grin face and walk away. That is social isolation. That is causing dementia. Depression. And Kishore sir is right here. He knows how depression and dementia can be so confused sometimes. Depression overlaps with dementia. Dementia overlaps with depression. So 45% can be prevented. That is a cure in real sense. Further updates, we can increase risk factors to multiple levels, including cholesterol and other things, which can be a prevention of the cure of the dementia. So this is a very important part of my slide. It is clear that delaying dementia by 5 years will reduce the prevalence up to 40%. That is massively cutting the cost. Just delay the dementia by 5 years in the world. It is going to reduce the prevalence by 40%. That is a huge number. So even if my opponent argues, these drugs are not effective, they just prolong by 5 years, I will tell, yes, prolong it by 5 years. I will reduce the prevalence by 40%. That is a huge number for the world. That is the importance of this particular slide. Care is what we do after failure. Prevention is cure at a population level, and current evidence says that 45% of dementia could be prevented or delayed if we act on modifiable risk factors. So simple diabetes and hearing loss or isolation has to be taken very seriously. It is not always about amyloid imaging, PET imaging, and functional MRIs. Think of simple things. So another thing, many times we just label it as dementia. 1 in every 10 dementia is treatable. NPH, hypothyroidism, B12 deficiency, HIV, normal person hydrocephalus, depression, neurosyphilis, chronic SDH, autoimmune encephalitis, paraneoplastic encephalitis, metabolic problems, all are treatable. So we don't just have a knee-jerk reaction of writing a donepem or an alzilem for a memory problem patient. Think of all these problems. They can be prevented and cured. So when we give up on cure, we miss treatable disorders. 1 in 10 dementia can be potentially curable. Evidence. We have good drugs. It is not like in the past. I know the pipeline is quite big and it is clogged with multiple research molecules. That is what all of us think, because we have handful number of drugs at practice at our disposal at this point of time. However, things are going to change. Think of lecanemab, think of donanemab. Very good molecules, both from the research point of view and practice point of view. If you think of Clarity trial and the Trailblazer trials, which are the hallmark trials for these two diseases, you can see the versus placebo over 18 months, 27% progression in case of lecanemab, and in case of donanemab, around 35 to 40% of slowing of the progression versus placebo. It's a very good number when you think of whole world, whole society, and the entire population which are going to be benefited. I know cost is expensive. I know India has approved it. The donanemab, it will come next year. So all those debates are there. However, it is a promising molecule. All these drugs are expensive. Nobody can afford it. And they're all only for research molecules. Think of oncology. Think of rheumatology. Think of immunology. Think of HIV medicine. Think of cancer medicine. 10 years ago, 15 years ago, how many drugs were there in the market? How expensive they were. Now everybody can afford oncology molecules. Everybody can afford rheumatological molecules, immunological molecules. It is just the point of time. We are not looking into the current generation alone. Think of the next generation. When you think of next generation and we toil with research in this generation, that is where the fruit comes. So it is not just about me or you, it is about the global population. So every drug or a molecule which is expensive today need not be expensive tomorrow. There are funds and grants and other so many things going on. We have to think and act on that can make our life better. Cure is not just about drugs, diagnosis. Many times a proper diagnosis is a cure. Earlier, we required clinical profile, we required CSF, we required all other invasive tests. But now we have a serum test which can diagnose dementia. It is FDA approved. Tau 217 can diagnose with 88% sensitivity. It can rule out disease by around 97%. Very good number. Very, very good number. It may not be available today in our hospital, but one or other day will be available. DEXA scan was not available in our hospital 5 years ago. It is available right now. That is how it is. A serum marker is there which can be used to diagnose dementia. That is a very good improvement in our field. For cure, you need early detection. You do not require expensive PET scans and amyloid imagings. We can even have serum tests are coming up for all the type of dementia in near future. Care alone does not demand this level of precision diagnosis. A cure-focused mindset does. Because of that, diagnostics are finally catching up. Think of economics, because the important policy of today's conference is policies and economics. A very small word, a small biological gain. I'm talking about a small biological gain. I agree it is a small biological gain. It's a massive real world impact. Massive. That is the importance of these drugs. 57 million people with dementia and 10 million cases every new year, and it is rising and rising. So this is an important statement I was telling. Just prolong by 5 years, you will reduce the prevalence by 40%. We have multiple, it's not just Alzheimer's disease. I'll have 2-3 slides more. It is not just AD. Think of liver body dementia, frontotemporal dementia, vascular dementia. All of them have drugs in pipeline. All of them have diagnostics in pipeline. If you think of the DLBD, we have alpha synuclein, synuclein, and some amplification assay coming up. And we have got antibodies to them, which are still coming up. They are in clinical trials. Obviously, it will take time. Patience is very important. Dedication, passion, compassion, and perseverance are extremely important for drug development. One drug takes 10 years minimum for a normal antibody to develop. And what about these genetic disorders and dementias? It takes time. Have that patience, we will have beautiful days ahead. CRISPR technology has done wonders in FTDs. We have CNORF72, which is an important gene expression in case of FTD, and we have got targets for that and antibodies being developed for that. And we have a lot of antisense oligonucleotide antibodies going on to develop for multiple FTDs and ALS prototypes. Vascular dementia is very much treatable. We can give antiplatelets, we can use elastazole, and there are multiple drugs coming up for this as well. So it is slow but sustained. We have got neurofilament chain assays, GFAP assays, synuclein amplification analysis, and imaging biomarkers available already for all these disorders. It has to become cheap. It has to become accessible. It will take time. That is the idea. Care, just 2 slides. Care without cure is resignation. Cure without care is cruelty. As a neurologist, I am not arguing against care. I am arguing against therapeutic nihilism. Hey, yen madakagala, iste madakagadu hogbidu. Iste kodakagadu nanu. I can only give this much. That is not. That is called therapeutic nihilism. Don't settle for nihilism. Be optimistic. That is life. Every patient deserves comfort and assurance that we have aggressively ruled out treatable causes, optimized risk factors, and offered any available disease-modifying therapy. Proof of concept, not perfection. The first anti-amyloid drugs are not perfect, but they prove a principle. They work on a principle. They change the biology, and you can change the trajectory of dementia. That is the idea of cure. Dementia care is now we honor people today. Dementia cure through prevention, detection, and disease modification. How we honor the next generation. Think of next generation. As a neurologist, I refuse to choose between them, but I am forced to pick one. The direction of the future I will pick, and I must stand on the side of the cure. Thank you so much.
So Dr. Shastara has put all his energy. It's a high volume, high impact work. And Steve, you have a tough job, but the definition of dementia begins with irreversible loss. If you are talking about irreversible loss, then Steve should tell us why we should invest in the cure, not the research.
Dr. Shastara gave a wonderful presentation, and I did not know if I'll be able to match up to his energy. I must confess, I didn't come ready with a PPT or a presentation or any research, but this is what I have. You cannot do great things We do a lot of great things, but is it enough? But we can do a lot of small things with great love. By talking about great love and smaller things, I do not say that we should not focus on care. But let me begin with a story. My uncle, a neighbor, my dad's closest friend, um, he he was a singer. I remember him. He was very strong, and every time we lived on the second, third floor of my small apartment, no lift those days. Every time I had to take my cycle down, with struggle, we'll roll it down, carry it down, but bringing it up was a big task. And if Venu uncle was there, if often, whenever there was a situation where he came at a time when I had to lift the cycle, he would lift it with one hand and come up. And he was hero to me because taking the cycle up was a big deal. We lived on opposite houses. In fact, jokingly, we said we lived in the same house. The doors were open. We had lunch at his house. His children were my brother's age. They used to come to our house, and we lived like a family. He also suffered from chronic kidney disease. He also was under dialysis. A week ago, I heard he had severe gangrene of the foot, and he's being shifted from Aster cortical to Aster Cochin. 3 minutes ago, I got a call saying that he passed away just before I enter here. Do we have treatments for CKD? Do we have a cure? We have renal transplantation. Do we have cure for gangrene? Yes, we have cure. We have good molecules. We have good drugs. But did it save him? No. Do we have cure for cancer? Yes, as Dr. Shastra said, we have newer molecules now. We have umpteen maps. You name it, there's a monoclonal antibody for everything. It gives more satisfaction to the oncologist to treat a patient with a new monoclonal antibody, even if the patient has got osteoporosis, even if he's got dementia, even if he's bedbound, even if he has no resources, even if he is going to die, even if the monoclonal antibody can increase his lifespan by 1 month, they will write it, and the family that doesn't know will subscribe for it because there is a treatment. Why should I not go for the treatment? Because there is a cure. But are we really curing? Do we have treatment for heart failure? Anybody, any of the students here know the treatment for heart failure? There are various methods we can treat. We can look at the risk factors, modify them. Even there are advanced techniques now. There are intra-aortic balloon pumps, etc., which we can do and manage heart failure in a better way and cure. But are we really curing? Aren't people dying of oncological related problems? Aren't people dying of heart failure? Aren't people dying of CKD? He said, Dr. Shastra said about cost. Cost, everything is expensive. Which is more expensive, cure or care? Care. Care is more expensive, definitely, because you need more people, which is why we need to invest more in care. We need to invest more in care only then, because cure never ends. Care never ends. There is always a new molecule, there's always something that you come up with. But what doesn't end is care. Do we not continue to care even if there's a good cure? We have to continue to care. As a doctor, if I can write a monoclonal antibody for the prevention of Alzheimer's or to treat Alzheimer's, it gives me much more relief than adding a donepezil and memantine, etc., because I know something more is being done. But does that reduce my need for providing care? I still have to provide care. I have to take care of the patient. I have to take care of his failing memory. I have to take care of his failing independence. I have to take care of his wife, who's equally as old as him. I have to take care of his sons, who's worried that his mother cannot handle his father anymore because she's equally old. She does not have the patience to handle the memory problems of and the cognitive issues of her husband anymore. She cannot handle the behavioral issues he's got. He's wandering around shouting at people. He's abusive. He beats the maid. And he's displaying a lot of emotional and psychological issues, which was never heretofore seen. And I need to care for her too. I have no cure for her. I have only care for her. So he spoke about therapeutic nihilism. There's a saying in the Bible, you may have faith to move mountains. You may have faith to achieve great miracles. But if we do not have love, nothing is achieved. For in order to provide good care or cure, you need love. Love transcends everything. And if you have love, you can provide cure. For because cure comes only if you have good care. I will close my statement with this quote. As doctors, we have to cure sometimes, treat often, but always comfort, always care, because without care, there is no cure. I rest my case. I'm open for discussion.
So Steve has put his ball on the care, and he says that's the most important aspect despite the thing. Before we go for rounds, anybody quick opinion? Anybody in the audience, either for the care or cure? Yeah, please. Yeah, there's another. Just two of them.
Of treatment in whatever way most of the doctors put it. But then, see, for example, you have a patient with multimorbidity, and we have something which has come up with the newest drug which would give you the best cure. And exactly like Dr. Steve sir mentioned, he had a lot of problems, there is no money. So would you still support cure or care there? Because this is something, it's not about blindly supporting, but then I personally feel as a geriatric department, we often I agree, I'm sure most of us agree with this, because we face the situation day in and day out. There are one group of patients and family who want to do everything, and they don't want to leave any stone unturned. And again, we see people who want to know the reality. This is where dharma sankata for us, where we have to tell them what do we do. So I usually tell them, if I was you, I would do this, but then we give them the choice of whether care or cure. But then this is a dilemma for us to decide what has to be done in such situation.
We'll take it later. Another person? Yeah, somebody? Yeah, please.
Yeah, as she rightly put it, being a geriatrician, again, our primary focus mainly is on care. And as you know, Alzheimer's is not a disease which has been diagnosed very recently. It's been there since so many decades. But still, what we notice is it happens to be in persons who, like people who get Alzheimer's or any sort of dementia, they are old. And as you see, there are a lot of people who are multimorbid there, right? So you just find a solution for cure in a multimorbid patient. It is not going to work that way. So again, the policymakers, when they are deciding on the division of the resources, then I feel the maximum must go to care rather than cure. I'm not saying cure should be an option, but still, as a geriatrician and what we see it right now, the care has to take a larger chunk.
One last point before we take the next round. And organizers, please tell me how much time I have.
I think she's in the legal field.
Yes,
she
please.
came here because she sees patients with dementia coming, and she faces problem. But
Harvi.
before I give it to her, I go for cure.
Okay.
Because every family wants their loved one to live for a little longer time. So if I don't look at cure, then I don't give a chance for the person to live a longer time for them to care. And there will be something that they want to do even a day longer if my medicine can extend. So here I will go with Shastara.
Yeah.
Okay, I come from a legal fraternity. So we face challenges in two segments too. Okay, the more challenges we find to cure, to less to care. So here, I'm here to understand more about helping a normal citizen to live a normal life. I don't understand the crux of the language what the medicine speaks, as the other fraternity don't understand the crux what lawyers speak. So we are here. I'm here to understand more on, how I, as a who belong to a legal fraternity, help the individual when they come. They are in need of basic advice from us. First on cure when they come. They say that we have had this issue. They could have suggested a better treatment to us. Unfortunately, we were misguided. That's the first factor. The second fact is that when the issue of addressing a care, they had not guided us properly. So we could have matched these two. A blend of these two would have helped my family, my loved ones being in the place where they should have been. We have gone through from pillar to post. So I'm here to understand on those aspects. But yes, I do agree. I seeing a lot on these issue. I would feel that a cure would play a very predominant role in the normal human being. So I would suggest that give us a light on this, which would be of great help to us.
Okay. So before we go to Shastara for round 2, how much time we have? Another 5 minutes. Okay, I have real conflict of interest because all my funding from DST, DBT, ICMR is for research related to dementia. It's 5 crores. But every day I see patients in psychiatry ward and I have to spend a lot of time for helping them to think about care. And there are no funds except JSS gives them 50 rupees OPD charges, which they can come for any times. They cannot come to neurology, but they can come to psychiatry. Neurology, they have to pay 100 rupees. For psychiatry, they can come to 50 rupees all through the year and we'll serve. So, Shastara, please, stage is yours. 2 minutes for you, and then Steve, 2 minutes.
I think I made it very clear. I am not against care. See, our medical field is a flowing water. It's not a stagnant water. How do you make the water flow? By doing research, by giving money, by developing new drugs. So new drugs are important. See, you can choose between cotrimoxazole or meropenem for a patient. If that patient is enough to be worked with cotrimoxazole, give that only for that patient. If he requires meropenem, you give meropenem. That is where our judgment we have to make. The same way, if there is a strict guidelines on dementia, this stage, this drug has to be used. If that comes in the future, obviously, if you don't give it, it will become a negligence, as Madam was telling. So we are not gone to that stage yet. So we hope we go to that stage so that we can have that all authority to write that drug. Right now, it is still we are in the fence. Should we write? Should we use? Should we not use? But I really hope, like how for multiple sclerosis, earlier there was only steroids. Now we have multiple molecules which are working. For example, rituximab, which I use on day in and day to basis, will really make the patient walk from a quadriplegic state. So I hope a dementia patient who is not remembering his own child can actually remember them and make a better life. That is a point of cure. So I am not against care. Steve has done a wonderful job of talking about the care. Care and cure has to go hand in hand. We'll join both the hands and we'll move forward. Thank you.
Steve, 2 minutes. Mother Teresa is backing you up. She's there. She's not given up on you.
So as I said earlier, in order to provide a good cure, you need to care for the patient. Without caring, you cannot bring in a good cure. Cure is possible where care is there. And my interest would not be to not care for the patient. As I said earlier, writing a cure does not confirm or does not guarantee success in a good outcome. A cure treatment does not translate into good outcomes. For a good outcome, you need good care. And if you are able to care for the patient, you will find a cure. Which is why I agree with Dr. Shastara. Care and cure has to be together. For without care or without love, you cannot find a solution. As our famous poet, famous author, Paulo Coelho mentions, when you truly, truly, truly desire something from your deep heart, the universe conspires to make your dream possible. With this, I rest my case.
Thank you. Any patients or patient relatives would like to talk? Somebody who has patients with, somebody, family member with dementia, would you like to? Yeah, please. Give the mic.
Good morning. My father-in-law was an Alzheimer patient. And you rightly put it, when he was actually diagnosed of Alzheimer, it had already crossed the limit. And it was very, very difficult for us to manage with care and cure both. So I would request that what is the initial stage? How can we identify a patient who is going to be an Alzheimer eventually? Or is there any way that within the family we can identify the patient at an earlier stage and we can start caring and curing together? That's one thing. Second thing, he was advised of a, uh, you know, what do you call, patch, which was supposed to be administered on his spinal cord. We actually did not know how it helps him, but many people said that will, make him more aggressive, and in fact it did. So, as you said, that there are very many drugs available and it can be cured very fast. But I doubt he suffered actually more than us. He suffered for more than 7 years. Later stages was really horrible, and he was not under control at all. It was like problem for us also to maintain. So please, can you enlighten us on this?
We'll take up that later. Any other final comments? Anybody? Yeah, please. The youngsters.
Sir has mentioned about modifiable risk factors, which is for cure. And within modifiable risk factors, I think psychosocial care, mental health care becomes a very crucial one. By addressing this care oriented treatment or whatever this point is, I think we ultimately reach cure by funding care.
Fantastic. That's a closing statement that there is a lot of agreement that where we should be funding both for care as well as for cure. I have real dilemmas when I see a dementia patient brought by their children's. Very interestingly, it is the daughters who get them. And if you are seeing 3 or 4 daughters getting their father who has dementia, and then you ask them what is that they are looking for, they are neither looking for care or cure. They are keen the property. There's a lot of property which the person has given it to the son. Son does not come for care, but there are daughters, but they want money. The resources are with the son. So you can understand the dynamics. Some people do not want any of them. They are keen on these people who have huge property. Now I want to inform the team. The SBI has around 19,000 crores, which has not been claimed by anybody. These are the people who have dementia. We should put a policy that the money should go for care of elderly. They forget their account details. They forget where they have kept. If the SBI is able to give at least 10% of the 19,000 crores, I think it will be judicious both for care and cure. With this, we close the debate, and you can meet Steve and Shastara here. Thank you so much.
I thank the dignitaries for the wonderful debate. It's our pleasure to have Dr. Shastara P. Sir and Dr. Steve Paul Manjali Sir with us today. I request our speakers to kindly accept a small token of respect, and I request Dr. Yam Kishore Sir to kindly present the memento to our debaters. Thank you, dignitaries. It's an immense joy to have Dr. Yam Kishore Sir with us today. I request Dr. Shastara P. Sir It's an immense joy to have Dr. Yam Kishore Sir with us today. I request Dr. Shastara P. Sir and Dr. Steve Paul Manjali Sir to present Sir with a small token of respect. Thank you, dignitaries. May I now welcome Dr. Shivanand Manohar Sir, Associate Professor, Department of Psychiatry, to chair the session on Risk and Prevention in Cognitive Decline by Dr. M. Manjari Tripathi Ma'am, Head of Department Neurology, All India Institute of Medical Sciences, New Delhi, India. I request the chairperson to introduce our speaker.
Good morning, everyone. It is a privilege to have Dr. Manjari Tripathi, who is the professor and head neurology at AIIMS. She has honors and awards and recognition like she is an NIH fellow, UCLA, FNAS, FIN, and FNAMS. In the professional interest is in cognition, epilepsy, and sleep disorders. She is the president of Alzheimer's Related Disorders Society of India, Delhi chapter. Observed functioning of dementia.
I think I'll interrupt you there, and I'll rather take the extra 2 minutes from you.
Thank you, madam. Please.
Thank you. And it's really an interesting discussion and debate we've had on care and cure. But I can assure you this care and cure should not be starting at the age of 55 or 60. And that is pertaining to my talk. This care and cure has to be so that we can identify the risks in our own individual lives and hence prevent the disorder from happening within ourselves and within our community. So, risk is something which we Indians are not averse to. We take a lot of risks, isn't it? Whether it's hopping on to the motorcycle without the helmet, or whether it's riding the car without the seat belt. But then there are consequences to this. And, sometimes it's even enjoyable to try to understand the Indian psyche as to, why we would take risks. Risks are, quite exciting to take on. But Alzheimer's or any type of dementia is definitely not an exciting risk to take on. So let's familiarize ourselves with risk. We keep talking about risk, but what exactly is this risk in scientific terms? So it's a variable which is associated with the occurrence in our condition, a disease. We are talking about diseases. And the risk has to be present before the onset of the disease, sometimes many decades before. And it is presumed to have causal implications. That is, if this risk was not there in my life, maybe I wouldn't have had this problem. Okay, so it is presumed to have causal implications. But then you have what is known as a definite causal risk factor and a probable causal risk factor. Okay, so what is a definite causal risk factor? When do we as doctors say this is a definite risk factor? When we show by randomized controlled studies, which have been done in a blinded manner, in a very, very, rigid, rigorous studies, we find that these randomized studies show that removal of that risk factor resulted in prevention or cure of this particular disease. So that's a definite risk factor. A probable causal risk factor is where we don't have a RCT study, we don't have a level 1 evidence, but then we do have epidemiological case and control studies. Is it clear? So it's not a vague term, it's a very specific term. And we have to know when we talk about risk, what we are talking about. So risk factors and preventive factors, again, have their own definitions. So risk factors is exposures more common in people who go on to develop the disease and associated with higher incidence of the disease and earlier onset of the disease. Whereas protective factors were exposures less common in those who later develop the disease. So if I have a protective factor, then I'm not going to be at a risk of that particular disease. So I hope by the first 3 slides, I've emphasized that the risk factor is not equivalent to the cause unless you've done RCT and proven it to be. And the risk factor may be there in the causal pathway. It may increase disease susceptibility. It may or may not be modifiable and may help us understand mechanisms which help us search for the cure. Is it clear? So risk factor may or may not be modifiable. So everybody in this hall knows that in dementia, if we take Alzheimer's dementia as the prototype, we know that there are certain modifiable risk factors and certain which are not modifiable. So with anybody in the audience who's young, tell me which are the non-modifiable risk factors, which every one of us may have. Yes? Genetics, very good. But genetics, not all of us will have. Okay? So genetics can be of two types. It is unmodifiable. One is, of course, you heard of the definite causative genes, the presenilin, 1, 2, and APP. But then you also have the at-risk genes, which is the ApoE4E4 homozygous state or the ApoE3E4 homozygous. These are unmodifiable, but they may not be present in each one of us. What is present as an unmodifiable risk factor in each one of us? Age. So age is the most important unmodifiable risk factor. And that is why we talk about staving off dementia for 5 years, staving off dementia for 6 years by these modification of the modifiable risk factors, because age catches up and that is a huge risk factor unless we know how to keep young and not have dementia. Now, cognitive health is not something we should be thinking of at the age of 50 or 60. It is something that starts right from conception to delivery to nurturing in infancy and childhood. It's not something, the cognitive health perspectives don't start at later age, and it's a lifelong thing which is probably preventable, and this is Hachinsky saying so. Now, how many, and this is not rocket science, this is completely doable. How many of you all think that all these which are listed here, whether it's the relative risk or it's the population attributable risk. PAR is how the population behaves, how the Indian population behaves. How we are behaving? We are the highest number in which disease in the world? Diabetes. Now, diabetes is a huge risk factor. You can see here, it is a risk factor. And we haven't learned to modify this. Even now, we'll have very sugary coffee, we'll have very sugary cakes, we'll have, whatever, we'll not be exercising. So, these are things which are very, very preventable. And these can be worked on not only from the individual level, but also from population and intervention-based levels. So, as I told you that it's a lifelong phenomenon. And this is how this article which Hachinsky has written is in childhood. How many of us have actually observed this in our own relatives? Avoid parental smoking. It's a preventable risk factor. So we all have families, we have extended families, we have joint families. How many of us have actually tried to modify this in our own family? It's completely modifiable. Detect and treat ADHD. Okay, sorry. Detect and treat ADHD. Now, how many of us realize how many of our children or how many of our youth are not able to sit quietly for a few minutes or even go into the ADHD spectrum? Not many of us. Completely preventable, manageable. Continuing education. Okay, dropouts, school dropouts. There is a huge risk again of cognitive decline at older age. And school dropouts occur in every community, particularly in the have-nots. The community is now divided into those who have and those who have not. We have a large population which does not have things and does not have access to education. The girls and the boys have to drop out of education, start working from a very young age. Again, preventable. Optimize diet and nutrition. Exercise regularly, treat depression, thyroid, hormone, vitamin deficiencies. How many of us even get our thyroids tested annually? Avoid smoking again comes here. Maintain healthy weight, maintain hypertension, maintain cognitive flexibility, cognitive test for early signs of dementia. Now we're talking about cure. We're talking about cure. Do you know the antibodies which have to be used now have to be started either in MCI, which is going towards dementia, or early dementia. And do you know in AIMS how many patients come to us early? Just 10%. So what are we talking about? Most of them
are told by the family or their relatives that he has become old. Okay, they don't even pick up the memory decline. There is no concept of going to a memory clinic and getting a baseline memory tested, whether that be with a medicine department, be it with a geriatric department or a neurology department or a psychiatry department. There's so many players and care the medical fraternity involved in dementia care. But to tell you frankly, we still see patients coming in the middle stage of the disease, when you really won't have much use of the cure which has come up right now. And the cure is expensive. What we're talking about is 20 to 30 lakhs. Okay, that means you have to sell off half your flat or break your FDs to have that cure. So this is much easier than that cure. We talked about this paper. The first one came in 2020, where we learned that 40% is modifiable. And if you look at this 40%, topping it 7%, less education. Okay, then you come here, hearing loss. How many of the elderly in our family have hearing aids? How many of them are, my father has a hearing aid, we got it for him, but he's not convinced about using it regularly. He uses it only when I need to speak to him because I get irritated when he's not using it. But the rest of the time it's off. And I tell him that you have to use it. We spend quite a lot on it. So you have the hearing aid, but you're not using it. So hearing loss, you're not receiving information. The first step of memory is what? Registration. How do we register? We register by our senses, by our vision, by our hearing, by our smell, by our touch. How many times have you gone and touched the old person in the family? Okay. So this is the first step of memory. Your emotional memory is formed by a warm hug in the morning. What you're talking to your parents is formed by hearing. So if you're not correcting the hearing in the elderly, obviously there's going to be cognitive decline because the first step of memory, which is registration, isn't happening. Traumatic brain injuries, hypertension, alcohol, obesity. Alcohol is served in all conferences and weddings, and they think it's a great thing, but even a single drop of alcohol is a toxin. Smoking, depression, social isolation, physical inactivity, air pollution, diabetes, and hence, 40% is modifiable by the 2020 paper. But you go on further to 2024 and you find two new things, added on, which is vision loss and high LDL. How many of y'all have got your LDL corrected above 35 years? How many of y'all have got it checked? 35 years and above. Good. So you should be doing an annual check of your LDLs and of course the vision also. Now, we were the first to undertake the, case control study. It wasn't an intervention study, which looked at risk factors in our population. And this was way back. This was with my UCLA because I did my fellowship from UCLA. Mario Mendez was here. And this was way back in 2011 that we published this data, which we gathered from our patients. And you can see here that, the things which are told in 2020 and 2024, we had told even then in our paper. Okay, so depression, eating pickles, we found those consuming large amount of pickles in our population. What do pickles have? Salt and oil. And salt will cause hypertension and oil, of course, will cause your LDLs to go haywire. So we identified in our population depression, pickles, saturated fats, a high BMI, ApoE4, E4 we did in the study, and that was a risk. And we also found LDL way back then. So it was known to us then, but how much of it have we able to translate into our population? All these things, I can tell at this stage that this is risk and this is preventive. But I want you all to right now, put your hand here, all of you, and say each one of you is going to look in your own families about these preventable factors and risk factors. Because this is something you have to start doing now, not at the age of 60. And that is what we are trying to drive at. Air pollution, of course, I'm coming from Delhi. I won't even mention it. I'm literally, we are, sometimes I go into depression. I'm sorry to confess it. But then I think, what am I doing in AIMS? What am I treating? And then I've stopped telling my stroke patients not to smoke. I say, even I'm smoking 20 cigarettes a day. So it doesn't make sense to me. But what makes sense is, of course, that we must work on increasing our cognitive reserve. And conferences are a part of it, education, cognitive training, exercising, and reducing inflammation. We talked about inflammation, role of NSAIDs, the diet, Some of our diet is good, some of it is bad. And then, of course, removing any kind of stress. Do you know it's not just physical stress which is causing repeated head injuries, which is injurious for Alzheimer's? It's also emotional stress. So if you have somebody who's faced a lot of emotional stress, and you go back to your patients and take a history from them, many of your patients would have faced a lot of emotion turmoil when they were, bringing up their families and growing up. And we published this in our context, that we have had patients with dementia whose stress scales have been so high throughout their life that it's caused an toxic stress, which is of the emotional kind. So it's not just physical but emotional. So basically we build on building. Now we're coming to prevention. So reserve, building up the cognitive reserve, and how this has been proven by you look at the Katzman. He says that when they autopsied brains, they may have had incipient Alzheimer's disease, but escaped loss of large neurons, or alternatively started with larger brains and more large neurons. And that means they had larger reserves. So I'll just finish in 2 minutes. Then, of course, what makes certain people more resilient against dementia? What leads to individual differences? Why is everybody different, even in the same family, exposed to the same environments, the same diet, the same stress, etc.? So basically, the concept of cognitive resilience, which represents an individual's ability to sustain better than expected cognitive performance, and in relation to the amount of neurodegeneration. And how does one do this? So these are the things: education, occupational complexity. Thank God you are doctors, or you are working in an environment which deals with a lot of complex situations, complex leisure activities, physical activity, and social engagement. Now, this has gone for a 6, social engagement. Tiny tots to old age, everybody's on their mobile, and everybody wants to put everything out there in Insta, Facebook, and they're constantly engaged not with the other person in front of them, but with a virtual reality. I'll end very quickly. Education I've already touched upon. This also improves your resilience. Then, of course, this has been shown scientifically. So we're not talking off the hat. I don't know why the slides are not moving. Has someone frozen my slides? Oh, the battery is gone. Somebody needs to help me. It's not moving. You can go to the next. I just will end. Yeah, so it's not moving with this. The pointer has frozen. Can you check this? Can you do it manually from there? Yeah. So just go on to the next. So all of us know 2 languages. At least I know 5 languages: Kannada, Telugu, Oriya, Marathi. I can understand Hindi and English. So if you learn more languages, you are switching your networks. You're switching between Hindi network versus English network versus Kannada network. So definitely there are several studies now, and please encourage your own children. The problem is not with the older generation. The children are the one who is restricting themselves to English. Some of them learn German, French nowadays, and now they're learning Chinese too. Physical activity, conference sitting definitely is a hazard. We sit there from morning to evening. So it's been found that if you can have chairs which have exercise cycles, they will reduce your cognitive decline. Again, it stopped working. And social relationships, have meaningful relationships. Purpose of life. Okay. I feel good when I think of what I've done in the past and what I hope to do in the future. I have a sense of direction and purpose in life. I enjoy making plans for the future and working for them to a reality. I'm an active person in carrying out plans which I set out for myself. So if we can have a mission statement like this, it gives us a purpose of life. And of course, that is very important. Just don't feel wasted. So ideally, one should want all this, which is listed here: healthy parents, birth without trauma, nurturing during development, increasing levels of education, control vascular risk factors, control diabetes, control hypertension, prevent stroke, physical activity, engaging in complex leisure activities, speaking multiple languages, skilled activities, develop social networks, include yourself in social activities. And our spiritual activities which we do in festivals is a grand way of doing it. Somebody's preparing laddu, somebody's preparing prasad, somebody's doing the mandap. The whole thing was there in our tradition, and we shouldn't be losing out. And of course, good sleep. 7 hours of sleep, because in sleep your lymphatics are going to dilate, and they are going to suck out all your amyloid beta, even if you're collecting it. And avoid stress. Finger India is ongoing with the Center of Brain Research. Last but not the least, we must involve policymakers. We must involve governments, because unless we have that in place, sufficient political will to tackle pollution, to tackle, make walking tracks, make cycling tracks. We don't have walking tracks. We don't have cycling tracks. That will help us stay younger. This I borrowed from Dr. Shah when he came to AIMS 2 years back. And I give it to all my patients, Dr. Shah, and it's a modified version. There's a list of drugs out there. Believe me, it's been shown that pantoprazole, chronic use, is associated with with cognitive decline. Now, how many of our patients are on pantoprazole for decades? Okay, not just that, they are on amitriptyline for a very long time. They are on cough syrups sometimes. People get addicted at older age for cough syrups. They just go on swallowing cough syrups. So all these can worsen cognition, and one must look into the prescription that an elderly person has. Personally, I feel if any elderly person has more than 3 tablets written on that prescription, it's a hazard for their health, because the tablets are going to cause more problems than solutions. I would like to conclude that risks stratification and prevention is multifactorial. No one thing will work. It's a lifestyle issue that we're dealing with. And even if we detect Alzheimer's early, even if we have these patients coming to us in huge numbers to the clinic early, if along with the MABs we don't do the prevention, it's not going to work well. And Dr. Yogesh Shah will agree with this, because he himself has told me that all his patients receive a heavy prevention package along with their MAB prescription. So with this, I'd like to thank you, and if there are any questions, I could take them.
Thank you, madam, for a very holistic presentation. I know the session is open for any questions or contributions.
Yeah. Dr. Shah needs a mic.
Thank you, Dr. Tripathi. Thank you. So, in India, whose role it would be to, if we know that all this prevention has a lot of weight, a lot of work to be done, whether it's a diabetes or hypertension, whose role it becomes primarily, whether it's public health nurses, GPs, internists, or does it memory clinic? Because the problem in the all over the world, including US, is who is the primary owner of this prevention information?
So ideally, I believe that nothing works in isolation. There has to be a top-down approach and a bottom-up approach to every problem, because the top-down will be your policymakers who will make policies which facilitate, walking, exercising, cycling, etc., and taking care of the environmental pollution. So you need a top-down approach, and that is your policymakers. And the bottom-up approach is your parenting, is your teachers. How many times, to tell you the truth, parents are giving mobiles to their kids because they don't want them making noise and they want to do their work, and the kids will be silent. So if you're going to hand over, the family is not going to be involved, the parenting is not going to be involved in bottom-up approach, and we're going to hand them devices which they're using the whole day. I've seen kids where the mother pulls the mobile and they're wailing and having a behavioral issue. So there you're teaching them sedentary lifestyle. They're sitting, looking at their mobiles. So that bottom-up approach, family, community, individual, and then of course your hospitals, all need to be involved. Top down, bottom up will merge somewhere to produce an effective strategy. But the department in healthcare is the social and preventive medicine. I think they have a huge role to play in seeing that this top down and bottom up happens. We can take off the cure, and ARDSI can take care of the care, but it needs to be done by the SPM department too. Yeah. Thank you.
Thank you for a wonderful session, ma'am. It's an honor to have Dr. Manjari Tripathi ma'am with us today. We request ma'am to accept a small token of appreciation. I request Dr. Head Joshi sir to hand over the memento and honor Dr. Manjari Tripathi ma'am. Thank you, sir. Thank you, ma'am. We'd also like to thank Dr. Shivananda Manohar, sir, Associate Professor, Department of Psychiatry, JSS Medical College. May I request Ganesh GS, sir, to present a small token of respect for our chairperson. Thank you, sir. Thank you, dignitaries. May I now welcome Dr. Ravi Kumar YS, sir, Professor and HOD, Department of General Medicine, JSS Medical College, Mysuru, and Dr. Sunita DK, ma'am, Professor and HOD, Department of Emergency Medicine, Adi Chanchandgiri Institute of Medical Sciences, Beluru, to chair the session on dementia care in geriatrician perspective by Dr. Prabha Adhikari, ma'am, Vice President Page, Professor of Geriatric, Enapoya Medical College and Hospital, Mangalore. I request the chairpersons to introduce our speaker.
Good afternoon, all. First of all, we would like to thank the organizers for making us a part of this wonderful academic session. And I'm very happy to introduce Dr. Prabha Adhikari, Madam, who is Professor of Geriatric Medicine in Enapoya Medical College. She was former Professor and HOD in General Medicine, KMC Manipal, and she has around 300 plus publications to her credit, and she has been awarded so many awards and honors, 32 around, and she had taken many research grants, and she had done so many variations, more than 8 or 10, and her special interest fields are infectious disease, neurodegenerative diseases, diabetes, and now she's more into geriatrics. Over to you, madam.
Yeah, thank you. Can have my slide. Respected chairpersons and dignitaries in the audience and dear students. So I bring greetings from Enapoya Medical College, where we have a wonderful team. So if you talk about dementia care, maybe 20 to 25 years ago, this was the care, and we have moved a long way from then. So today I'm going to talk about a geriatrician's perspective, how we address a person with dementia. Risk factors have been already dealt with, multiple pathologies and treatment, which is evidence-based and pharmacological and non-pharmacological, and some experience-based therapies that we give to our patients. So when we talk about, I think geriatricians are aware of it, that the geriatrics originated from UK, from Marjorie Warren, when she had a ward full of patients with multiple problems, of which dementia was also there, and she assessed them in all 8 domains that are mentioned here: their mobility, balance, medications, nutritional issues, memory, social issues, mood, everything she addressed, and she broke it up into these components and addressed each one of it individually, and she could discharge these patients in the, who were assigned to live there and die there. So then came the era of Bernard Isaac. He called geriatric issues as 5 I's, which is immobility, instability, intellectual impairment, incontinence, and inappropriate medications. Why he called them as geriatric giants? Because they impair the quality of life of the older person and also function, but it is multifactorial. That means there are many risk factors which we can target. It is due to multiple pathology. Again, we can target multiple pathologies, and that is the solution. So if you think dementia is just one disease because of amyloid or tau, you will not be able to find a solution. But if you think dementia is due to the depression associated with maybe retirement or not having purpose in life, or because of his uncontrolled diabetes, hypertension, smoking, alcohol, etc., you have lots of things to do for the patient. So I start with my experience with dementia, and unfortunately it was with my own father. You can see him in 1991 with my daughter on his lap. He was absolutely fine. And you can see the progression in 2002. But when I think back, when did it happen in the beginning? Because we could not recognize for a long, long time. It started with in 1993 when he lost his vision after a cataract surgery. He lost his vision in one eye, and the other eye also he lost vision because of after cataract. And at that time, nobody knew about it. And that's where he went into severe depression, being a highly intellectual person who has authored a textbook of physics for PUC, which ran for many, many years, heading every educational institution and contributing to university. When his vision was lost, he was into severe depression. By the time we got some vision in one eye, there was decline, and we attributed it to depression and so many vision, etc. And we, in between, he would have some delirium. So we thought it's only delirium due to that, this, and it went on like that. And in our own small place of Mangalore, there was no one who could diagnose dementia in him, or no one dared to diagnose dementia in him. So I had to take him to Nimans, admit him for 10 days, which was a very difficult task for us. And then we came back with the mixed dementia, Alzheimer's plus vascular. And then we started thinking about what to do, and we handled him until his last days. So when we talk about Alzheimer's disease, is this all the pathology, the tau protein and amyloid? Yes, it is there, but there are many other changes that can be coexisting. Like in India, what we see is most of them are mixed dementias. You have vascular changes due to atherosclerosis, small vessel disease, thromboembolism happening. You may have an extrapyramidal syndrome overlapping, autonomic dysfunction, and multisystem atrophy coming along. And of course, lots of behavioral issues because of the progression of the dementia itself. So if you break it up into components, you will find several solutions. Of course, the treatable dementias, again, it is forgotten. Moment the diagnosis of dementia is given, they don't even want to go for any test or even imaging. They will say, we'll get it done, and they never turn up. So there are so many reversible conditions that can be picked up in a given patient. What I see is at least I identify some 3 or 4 factors which I can work on. So quite a few patients of ours, they have developed sepsis, coagulopathy, and then they have worsened, and there has been a rapid downhill course. Again, following COVID, we have seen so many elders straight away progressed in dementia. Maybe they had mild cognitive impairment, and we have seen them going down and downhill. So other things also we have associated findings, like in my own father, he was a hypertensive, and through his journey through dementia, we found that his blood pressure was dropping, and even after withdrawal of all the antihypertensive, he was having orthostatic hypertension. And addressing that really stabilized him for a long time. Of course, we didn't have Midodrine those days. We tried giving him more salt and fludrocortisone, etc. Again, vascular Parkinsonism and vascular dementia overlap on top of Alzheimer's disease. And treating it with dopamine agonist, we have found a lot of improvement in our patients. Similarly, neuroinflammatory conditions, autoimmune conditions, they also overlap. And we have used small doses of steroids in these patients, and we have brought stability. So several things and several pathologies working on the same patient with Alzheimer's, we are able to bring some stability to the condition. I wouldn't say reversal, but
cognitive scores definitely improve. So while answering the question raised by one of the caregivers here, how to diagnose dementia early? The screening is, of course, all of us use one of the tools, memory test, but it may not pick up dementia in somebody who's got a very big cognitive reverse, cognitive reserve. Like my own father, nobody would believe that he has dementia because his MMBC score was something like 27 out of 30. Okay, but at the same time, he had lots of issues, behavioral and other issues, and that was what was finally found out in NIMHANS, that it is dementia, although cognitive scores were good. So we have to use advanced tools as well in memory testing. Of course, the biomarkers are, if it's accessible and available, they are the best because they can pick it up even before cognition drops. So these are overlapping things that are there. Sleep issues, it's a big issue, and addressing that itself will bring relief to the family members. Depression and delirium, again, they have to be looked into. Many of our patients have delirium and it is not picked up. They come with very low cognitive scores, but it is because of delirium, and if you address that, the cognition improves. So non-modifiable risk factors, of course, we cannot do anything, but my previous speaker has clearly told that we work on the risk factors, we get real good relief. So this study, finger study, she was talking about it, which is Finnish geriatric intervention study. And if you can see, this is the only study that has shown improvement in neurocognitive, almost by 25% through multi-domain intervention. Why are we not implementing it in our patients? This is easy to do. It is, it doesn't cost anything to do, and it is very, very easy to do. So what are those interventions? Mind diet, which is a combination of Mediterranean diet and DASH diet, which we use for hypertension. So there the low salt may be of benefit. What my previous speaker showed, that pickle in itself was a risk factor. So reduction of salt, diet which has got good amount of protein, low carbs, and of course vegetables and fruits in plenty, berries, healthy oils, nuts. That is mind diet, and we can easily give it to our patients. We have made an Indian mind diet for our patients so that we can prescribe it to our patients. Cognitive training. There are accepted cognitive stimulation activity models which can stimulate all the parts of the brain. And we have run such program on our patients, and we have found improvement in cognitive scores even in dementia patients. So it is our psychology, psychiatry, psychology and healthcare, other healthcare professionals can very well deliver it. It is simple, easy to deliver, but of course they can't self-deliver. Social activities, that means we have to get them together so that the social connections will improve neuroplasticity. And in this particular study, you can see the finger study, 83% improvement in executive function, 25% improvement in cognitive performance, and 50% improvement in the psychomotor speed. So that is something which we can apply and try in all our patients, and I have tried it. When I knew that there is no cure, this is home for the long-term care ward that Pratibha and I looked after while we were in KMC, and she got trained in geriatrics from Malta, and she came, and we should have a multidisciplinary team to get them up. And you can see we saw the improvement in the inmates. It was a class run by the teacher over there who did a Bharatanatyam dance, which he danced at the age of 13. Otherwise, she was a depressed lady. She was about to die. She said, I don't want to live, and she had consumed something and come. And we told her, you are a teacher, are you ready to teach? She was taking class for them. She was coaching them in exercise. She was teaching them songs, dance, everything. And We had no dementia in that group. 25 years they've lived in our hospital and there was no dementia. This is the center I started after my father developed dementia. I didn't know finger study at that time, but I said, I need a place for my father to go. So in our own hospital, we started an exercise center, and some of the familiar people whom my father knew, we called them and enrolled them. In 2002, we started this center. I'm happy to say that the center is still running, and more than 1,000 people have enrolled into this program. At a given day, there may be around 50 to 75 people coming. And that's an amazing intervention that I can see as preventing dementia, because among those 1,000 odd patients, only 2 patients developed dementia. That too, one was during COVID time where the center was closed, and one other person who never did anything, he would irregularly come and simply sit and go. So these were the only 2 people who developed dementia. They would have developed, maybe they died of some cancer or a fracture or pneumonia, some of them, but there is absolutely no dementia. In fact, some people during COVID time had real great cognitive decline, but they came back after COVID. So this is a second center in our Center for Basic Sciences, where physiology department gave space. So yoga was the predominant intervention there. This is Center 3, which I created in my father's house, which is running till even today. This is the 4th group, which is a dance group. A young person there has taught them dances, and that's a wonderful group. They have picnics, activities, everything. More than 60 to 80 people are enrolled into it. We have found other things as well, like frailty interventions, H. pylori, infection eradication. These are all things that are likely to at least prevent progression of the neurodegeneration, vision correction, etc. So we've run some home program for dementia also. The same finger study module we are delivering at home also, cognitive stimulation. Our coordinators go and give exercise, cognitive stimulation activities, then some school-like activities there. So all that is keeping our dementia patients active. And this is something we found, that as dementia progresses, especially in mixed dementia, they do develop Parkinsonism, and dementia rapidly progresses. That's the time we found that levodopa was not working, but pramipexole was working for them. And we were really very, very happy about the improvement we got in around 43 neurocognitive impairment. Of course, we did have side effects and we had to withdraw some of them. But however, for about 2 years, they maintained good cognition. But after 2 years, some of them developed edema, heart failure, and we had to withdraw. But still, we thought we have given 2 years of active life for them. Mobility improved, cognition improved. They still had Alzheimer's. The relatives will come. Still, he forgets whatever we tell him. I said, that is okay. You just keep them going. That's what I tell them. So, mixed pathology, that's what I told. So, we have found improvement with all this combined approach. Manage blood pressure, make it optimum, neither too high, they're saying control diabetes, control mobility issues, exercise, occupational therapy, sleep, everything. If we do, they really work well. We have tried it in a palliative care, neuropalliative care home also, and they've been able to manage most of the patients, even with behavioral issues, without much of antipsychotics. So, in geriatric department, we have found all this pathology in patients with dementia who have been dropped out as dementia. You can see how many treatable conditions were there. Okay, there was an add-on TB meningitis. There was one case with adenocarcinoma with brain mets, diagnosed as dementia and progression. But this was picked up and she was treated and she's still alive. Lung adenocarcinoma, pituitary mass, subdural hematomas, NPH we have found, cystosarcosis we have found, frontal lobe tumors, empty cellular syndrome. So many pathologies in the same patient of Alzheimer's. So these are some of the groups, I would say. So I conclude that from the geriatrician point of view, it is just a syndrome with multiple things that we can address, and are very positive about any dementia. Again, as Steve said, we care and we are positive and we want to bring positive change, at least for some time. If lecanemab is just slowing down the progression, we are able to slow down the progression with this multiple interventions. And looking at all the risk factors, not to forget even pollution. We tell them to go to areas where you get fresh oxygen. I said breathing fresh oxygen will improve cognition. In fact, I have moved to a place, to an apartment where I get fresh air, so that I and my husband don't develop dementia. And we feel, this oxygen is going to improve my cognition, and that feeling is so good.
Thank you, madam.
Yeah.
That was a wonderful talk on practical aspects of dementia, geriatric perspective. Yeah, a few questions are allowed.
Yeah, see, if it's for Alzheimer's, they will just forget the recent things, okay? Not flushing the toilet after they use it. That's the first symptom. Okay, then forgetting their tablets, especially the ones which are added later. Okay, old tablets they'll take, diabetes, hypertension they'll take. Something else you have added a tablet, only that tablet remains. Okay, so these are recent things. Later on, they asking repeated questioning. Those are the things that come. But the first symptom would be somebody who is very neat and clean comes out without flushing the toilet. That is an early symptom. So recent memory only is lost. After some time, they'll remember, okay? But like whatever had happened just now, that is lost. And that is taken as, okay, they can forget. That is, we should not. We should, that's what annual memory check. In fact, we do 6-monthly memory test for everybody. So we know your score. Like if you're, say, 30 out of 30 and when you're going to 27, that could be an early sign. So that memory testing is a very good tool. We are, I think Dr. Pratibha is making it everywhere in Mysore. Memory testing. Okay. So if patients don't come, we go to the community and do it. On any pretext, let it be Alzheimer's month, let it be diabetes day, let it be heart day, because when when you protect heart, your brain will be protected, but you could have already had cognitive decline. You have a heart disease, but brain also may not be getting enough blood supply. So everywhere we have to popularize this memory test, and we should tell them, don't get scared, we have treatment available. This is the treatment. Multiple treatment is available. It's not just one lecanemab they can't afford. There are many things which don't require there's no cost built to it. I think it was a rivastigmine patch. It's a memory enhancing drug. Okay, mostly. That is the only patch we prescribe. And that is supposed to improve cognition for some time. And it was my father who was the first patient who received rivastigmine from Nimans. And the worst symptom we had was he was not recognizing my mother. He was recognizing me, but not my mother. That's a stranger sitting in my house. She's going to take my property. She's going to take my gold. She's going to take my everything. And that was the most painful thing for my mother. But after rivastigmine, he was giving the sweetest smile to my mother. Although later on, he had a head injury, he couldn't speak. Every day, when I was taking him to the center, one big smile to my mother, and that would make my mother's day. And until last day, he recognized her, he remembered her. So That is the advantage of using. Some of the behavioral symptoms do improve. So we have to try it because it is started with a small dose and then we build the dose. We should not lose patience. We should use it for at least 3 months. Then only we see the benefit. And that controls most of the behavioral and some psychological symptoms. And I don't think so. I don't think so. That is not the cause of aggression, definitely.
There is any more question?
Yeah. Old memories will become as if it is done today. Okay. My father would get up and say, today is college day. Okay. But his brain has gone to the day when it was college day. We should accept that. We should say, yes, college day, let us go. After some time, they'll forget about it. Yeah.
Thank you, madam. Thank you for your wonderful talk.
Thank you for such an informative session, ma'am. It's an honor to have Dr. Prabha Adhikari ma'am with us today. We request ma'am to accept a small token of appreciation. We request the chairpersons to hand over the memento and honor our speaker. Thank you, ma'am. We'd also like to thank Dr. Ravi Kumar Vyas sir and Dr. Sunita DK ma'am for chairing the session. May I request Dr. Tejaswini ma'am and Dr. Ganesh Rao sir to present a small token of respect to our chairpersons. May I now welcome Dr. Bindu Anigeri ma'am, Assistant Professor, Department of Psychiatry, JSS Medical College, Mysuru, and Dr. Sudeep PK sir, Assistant Professor, Department of Clinical Psychology, JSS Hospital, Mysuru, to chair the session on Interventions to Enhance Cognitive Reserve in Early Alzheimer's Disease by Dr. Trishula D. ma'am, Assistant Professor, Department of Clinical Psychology, JSS Medical College and Hospital, JSS AHER, Mysuru. I request the chairpersons to introduce our speaker.
Dr. Trishna is Assistant Professor, Department of Clinical Psychology. She has finished her MSc in Clinical Psychology and MPhil in Clinical Psychology and PhD from JSS AHER. Her expertise is particularly in clinical psychology and behavior addictions, gaming disorder, and also in geriatric population. She has more than 5 years experience in academics and 7 years experience in clinical experience. So she has 6 publications. She has presented at multiple national and international conferences. Trishna ma'am, over to you.
Thank you, Sudeep sir. So, good morning, everyone. I'm really happy to talk about how we can help elderly, how to preserve their cognition. So, we all know in India, nearly 5 million people live with dementia, and this number is rising fast. Common risk factors we have already seen in many slides that low education and diabetes, hypertension, loneliness. For example, an older person who withdraws from social activities after retirement may may have their cognition decline very fast. That's why early and non-drug based approaches like social and mental stimulation are the key factors that we need to introduce. So what is cognitive reserve? Does anybody know what is cognitive reserve? We all have resilience power to, get bounce back from the capacity of stress. Cognitive reserve is also brain's ability to keep functioning despite having a damage. So that is cognitive reserve. Like it is like a mental savings account. So for example, a retired teacher who stays engaged may function well. So that is why we need active lifestyle. So why we need to build CR? Why do we need it? It is we can reduce the decline and also have maintain the independence of the person. People with strong CR stay sharper and more emotionally stable. So coming to the evidence-based intervention, most of it has been covered, but still, cognitive stimulation therapy, physical activity, social engagement, creative therapies, as well as multi-domain programs like FINGER are the evidence-based interventions. So coming to CST, this is what we use as a clinical psychologist. I use this more. So we have CST that we can do it in a group setup where it is for early dementia. We take like MOCA from mild to moderate score severity. We can take this group into the CST. So it will run for about 14 sessions. That is, we can do it for the twice in a week. Each session have different themes. Like it is a fun theme, like they can go back and think about their memory about childhood, or having one talk about like festival, Diwali, sweet. This is going to just trigger their recall and they build conversation and they can have the engagement throughout. So CST in Indian context, what we can see is there is adapted versions from AIMS and NIMHANS. So this is locally used in familiar languages, and also we are using Kannada CST group, like we use like devotional songs and also follow up by some memory tasks like crossword, as well as puzzles, and also some memory that they can think of. So this is what we are doing for about 14 sessions. So this is about CST. So coming to physical and lifestyle intervention, physical activity improves brain blood flow and it also reduces the inflammation. So we can try to think of yoga, walking, gardening are excellent for older adults. The walking, the only 45 minutes of walking has proven that there is an increase in the size of hippocampus, which is also reasonable for memory as well as learning. So exercise can also enhance your cognition, as well as it can also manage your BP, diabetes, and other things. Coming to social and leisure engagement, we can see social interaction is the crucial for brain health. So community we need to encourage elderly to go into community gatherings, temple events, and also spend a lot of time with family. Coming to India, it is like we have a boon, like we have joint family, which can help us to integrate all these. Creative and psychosocial therapies. Here we can see music, art, reminiscence therapy, which can boost their memory and also can reduce behavioral issues. Reminiscence therapy is nothing but about talking about childhood or one good memory which they can reconnect with their emotions as well as their memories. For example, I had a case and which Pratibha ma'am also had sent. The person has moderate to nearing to severe. She remembers the Carnatic music, but not the other things. She sings so well, even with the right connotations and also the right lyrics, and that is what making her keep going. So at last, it is integrated multi-domain program. It is that finger trial which has showed 30% slower decline in people who followed with mixed approach of all this. So what is the challenge in Indian context? It is lower literacy, lack of specialists, cultural diversity, and also lack of awareness in the people. So, but India's strength lies in community involvement. We can also train most of the people to get into CST and also do it among the community people. So, case example, Mrs. Meera, who is 68 years old, had mild memory loss. She joined a senior club offering CST sessions and yoga. After 6 months, we can see that she has become more confident, cheerful, and her memory stabilized. Her daughter learned some simple memory activities so that she can teach her at home. So, this case shows how CST can transform lives. So, coming to the conclusion, cognitive reserve can be built at any age. CST, yoga, and creative activities help elders remain independent and fulfilled. If we can integrate the low cost interventions into community health systems, we can promote healthy and dignified aging. Enhancing cognitive reserve is not just treatment, it is a way that we help our elders to live with pride and dignity. These are my references. Thank you. Thank you for the opportunity, ma'am, Pratibha ma'am, and also the Department of Geriatrics and ARDSICON. Thank you.
Thank you, Dr. Seshala.
Thank you.
The session is now open for discussion. Any questions are welcome.
What are the challenges you face? Because people, the attitude to testing your cognition, it's like a taboo. And once even they diagnose, to come regularly for this because you're not really giving tablets.
Yeah.
So what are the challenges you face?
One is that if I say them to come twice in a week, that itself is a challenging thing, that they say nobody is there to bring me here and I don't want to, burden others also to bring me here. That is the one challenge that I've always seen, ma'am.
Have you tried it, like online classes?
Online also.
Do they come, or that also they don't?
Online we have tried, but the emotional connect is very less over there. But they do come.
How about learning a new instrument? Does it help them?
Anything that learning new thing will definitely help everyone. It will definitely help. Learning something new, it might be an instrument, it might be something like knitting or something. Anything new skill that is the people are trying to learn, they will have some or the other improvement in their skill as well as the ADL.
We now have, like Dr. Prabhadikari ma'am had mentioned previously about music therapy, listening to 30 hertz music.
Yeah.
So we had one of the PGs doing a thesis on that. Do you have any information in that?
Right. I've been studying most of the research. It has definitely helped. Coming to the research that we have not tried, and I don't have much information on that.
Right now, that is a project because discussed with Prabha ma'am, and she had done that in Yenapoya. So we are starting that. One of the PG has taken that as a project. So thank you.
We have also started, one of the PG has started music therapy on some neurocognitive disorder.
But
Nice. Thank you, ma'am.
And I have a question.
Yes,
When is this cognitive training has to be initiated? When is the right time that we diagnose that a particular individual or a patient require that training? Just can you enlighten us on that?
I feel every individual who has started their 50 should come for the, assessment for the cognitive decline. So when there is a cognitive decline of or cognitive impairment of mild to moderate, we will start CST.
Okay, I'll come back on another question. When do you think, what do you mean by cognitive decline? So to give you because we are a normal individual, we are not doctors. So when we are talking about cognitive decline, to give you an example, is that at times we lose or missing out on carrying our mobiles, we step out of the house. So that's one incident. Others is that, very frequently we miss out on a lot of things which it was very predominantly a very important aspect to us. Is it these are the times that, we have to be careful, or how is that, we need to identify at the earlier stage, even though because a lot of issues are starting at the younger age. You said 50. I think a lot of issues are starting nowadays in the 30 itself. So it would be helpful.
Yeah. So usually in our busy lives, we see that most of them are forgetting few things. It might be because we have not registered it. It might be because of the we are thinking of something else and we are doing something else. That is different. And also coming to the cognitive decline, as Prabha ma'am was also telling, the moment they start to forget recent things and also be suspicious about it, that is when you need to come. Yeah.
Isolated events do not mean cognitive decline. They should be more persistent, should begin to cause an impairment in daily functioning. That's when we start thinking about cognitive decline.
Let me make it simple for you. It's like there are various things we remember. We remember person, we remember place, we remember time, and we remember certain, areas that what happened, events. That's one part of it. There's a next thing where I'm skilled, and I know I have to do that. So that is the skilled area. So the skilled area is one part of it. The next one is your emotional ability. Okay, all this is different parts of the brain. Your frontal, your temper. So different part of the brain does different functions. So it's like you may start declining one part of the brain. You may not start declining in the other part of the brain. So what this is, you don't know whether you have started in area where you're a skilled area, you're having a problem, or you're in the frontal where your social behavior, you remember, you know that if I have to use restroom, I have to go to that place only and use, and I'm not to do here. So there are, I'm aware of certain those areas. So now each person's understanding is different. So what she's coming to is, it's good that when you are 35, 40, you get it tested, because these are validated scales. So you may be in a different profession, you may be in a different profession, but if I'm going to tell you, you're going to have, I need to test him in a manner where my score will tell what is the decline in you. So yes, we pick you, you get worried. I'm getting few things. I was doing multitask. Now I'm not able to do a multitask. So you get worried. Am I losing my memory? It may not be. Okay. So you have to get it tested. There are lot of scales we have, and we will know which scale to use for you. Do I use ACE3? Do I use MOCA? That we will get it. And if your scale is, say, 30, score is 30 on 30, even if you're forgetting to take the mobile, does not mean you think I don't have, but it's a warning for you that I'm not able to multitask. So maybe I need to work on my registration, because the first part is I register, then my memory comes out. So that's an early indication that, you were not. So it's like we say, pick it early. So you work on it. So there are some do Sudoku, crossword, all of that will help you. Keep 25 things in a plate. When you forgot mobile, keep 25 things in a plate of different things. See for 2 minutes. Put it inside and then write down and remember how much of things do you really remember. So maybe you have to work on your focus. Okay. Is okay for you? Thank you.
Yes, sure.
Thank you for your good presentation. And
Yes.
just a comment that we are becoming more therapy focused sometimes. Many of things are good, but are we forgetting at the same time that there is a carer who is 24 hours with the person, either a spouse or a family member, and partnership with that person might help, and educate that person might help to keep this therapy going rather than focused on just highlights of therapies.
When the patient comes in, we already take in the family as well, that we also psychoeducate them, also involve them in some of the therapy sessions so that they can go back home and train them.
Good, thank you.
Yeah. Yes, Shamama. Thank you.
Just as Dr. Pratibha mentioned, take 25 things in a plate and then try to put it back in its place. Do you have any specific protocols wherein we can teach them the home-based cognitive therapies? Of course, learning new things is one thing. Other than that, anything
Other
else?
than that, they can start reading newspaper, they can do crosswords, they can do Sudoku.
Yeah,
Those kind
especially
of
the population being the rural setup with no formative education, that's where we find it a little difficult. So
yeah, for them we can start with sorting, like if you give some amount of what do you say, grains as well as pulses, if you mix it and just give it to them, they can start to sort it. That is where the attention training happens, and then we can move to the memory tasks, like where we will ask them the uh, recipes of the food or something, like just to keep their cognition active.
thank you.
Yes.
Is neuroplasticity intervention same as cognitive stimulation or cognitive reserve interventions?
Yeah, CST is one that enhances neuroplasticity. That is what we have seen in the studies as well.
Or vice versa?
Vice versa, I've not seen.
Any other questions? I'll just make a couple of points. Protecting your cognitive abilities should be part of your retirement plan, which means to say it should begin very early in life. So that brings us to the question, how far are we prescribing lifestyle changes like exercise and diet to the younger people that come to us with different medical problems? That further brings us to the question, how far is the medical community itself making changes in their own lifestyle, that is exercise and diet? Now, if we start following all of these in our own day-to-day life, then we have the conviction to prescribe this to all the patients and non-patients in our lives to make the necessary changes. And all these changes will not take place overnight. It has to be a process where one understands what works for them, what is more helpful for them. So these changes have to begin much early in life. Yeah.
Thank you so much for your presentation. It was very comprehensive in the sense that you have tried to include all the interventions. I just want to talk about cognitive reserve. Cognitive reserve also means that even if there is a pathological change in the brain, for example, there are neurological changes, why some people are able to maintain their cognitive functions and why some people are not able to. So, this is dependent on lot of factors, and it tells that, it's not like, after you have some, after the age of 60, that is when you develop the cognitive reserve. Cognitive reserve is like a bank where you start very early, and it is dependent on what occupation you are doing, what educational processes that you have gone through, what kind of stimulation that you have gone through. Many of them were talking about language, multilingualism. All of those things will lead to have a cognitive reserve. It is not something that you can achieve after the problem has already started. So cognitive reserve happens much before. Like, for example, in your teens or in your 20s and 30s, that is what will lead to a better cognitive reserve, which means that you'll be resilient to brain changes, where there will be you'll be able to adapt. You will be able to have new neural pathways, even when there are damages. So that is something that we have to do. Like ma'am told, we're talking about changes that we can make early in life, like lifestyle changes. So that's essential. The other thing, start from school. And one of the other things is that she was talking about CST. There are multiple studies that are done in India also. There are a lot of implementation studies that are done in India, in multiple sites in Delhi, Mysore. Mysore is also one site where they have tested the implementation of CST and try to understand whether it's feasible. And there are multiple challenges that have come across, especially related, because it's done in a group setting. How many of them can come to these groups? Is it possible to do at home? So all these studies are done also in Mysore. And ME Spectre has come down to Mysore and South India to train people in CST. So there are active works that have been done. So we need to look at what are the barriers and then move forward to see how we can address these barriers also. It's not easy when we talk about groups. Most of the groups are done in Western countries where it is done in care homes. So it is easier to implement these group projects, but in settings like this, it might be slightly difficult. So we need to see what, so studies can be done on community implementation, individual implementation also. Dr. Trishila, thank you so much for
Thank you,
bringing
Sujit
this
sir.
conversation.
Thank you, Bindu ma'am.
Thank you for a wonderful session, ma'am. It's an honor to have Dr. Trishala D. ma'am with us today. We request ma'am to accept our small token of appreciation, and I request our chairpersons to hand over the memento and honor ma'am. We'd also like to thank Dr. Bindu Anigiri ma'am and Dr. Sudeep PK sir for chairing the session. May I request Dr. PK Kulkarni sir and Dr. Ajay Sharma sir to present a small token of respect to our chairpersons. Thank you, dignitaries. One small announcement. Cultural program will be taking place at the old auditorium at the end of the scientific session at 4:30 p.m. May I now welcome Dr. Ajay Hanumantu sir, Assistant Professor, Department of Endocrinology, JSS Medical College, and Dr. K.C. Shashidhara sir, Professor and Unit Chief, Department of General Medicine, JSS Medical College, Mysuru, and Senate Member RGUHS Bangalore to chair the session. On the topic of diabetes and dementia by Dr. Lakshmi Nagendra sir, Associate Professor, Department of Endocrinology, JSS Hospital, JSS EAHER, Mysuru. I request the chairpersons to introduce our speaker.
I would like to introduce Dr. Lakshmi Nagendra, who's the Associate Professor in the Department of Endocrinology. She'll be talking about diabetes and dementia.
Thank you, Dr. Ajay. Thank you to ARDSICON and Department of Geriatrics for this wonderful opportunity. Now, I'm an endocrinologist, and speaking about dementia in this conference is like, preaching to the choir. All of you are experts. And I'm also very aware, like Dr. Ajay said, that I'm the only person standing between you and lunch. So I'll very briefly tell you the very, nuanced ways how diabetes can affect dementia and dementia can affect diabetes, and all the questions for the session will be taken up by Pratibha ma'am. So yeah. So this will be the outline of my talk. We'll answer a few questions. Is it common, diabetes and dementia? Why does it happen? What are the risk factors? How do we screen for it? Treatment implications in diabetes and prevention. So when we look at if it's common, we know that diabetes is associated with the 60% risk of any dementia in both sexes. But when we look at vascular dementia, it's higher in women compared to men. Non-vascular dementia is also higher. The risk ratios were 1.53 in women and 1.49 in men. Overall, women with diabetes had a 19% greater risk for the development of vascular dementia compared to men. But there's a newer entity called diabetes-related dementia. It's emerging as a different disease from Alzheimer's disease and vascular dementia, and it is characterized by slower progression of dementia compared to this, absence of typical neuroimaging findings, advanced stage, elevated HbA1c levels, long duration of diabetes, high frequency of insulin use, frailty, sarcopenia, and dynapenia. Now, dynapenia is loss of muscle strength, which is not caused by neurologic or muscular diseases. So why does it happen? We know the pathophysiology. Insulin resistance leads to acceleration of AD pathology, ischemia. Other mechanisms lead to cognitive dysfunction. When we look at diabetes and AD specifically, again, insulin resistance here is starting off the cascade of events where there's insulin resistance in the brain as well, increased A beta expression, neuronal dysfunction. On the other hand, there is decreased phosphatase activity leading to hypophosphorylated taus and again neurofibrillary tangles, which leads to Alzheimer's disease. And diabetes, especially uncontrolled diabetes, hyperglycemia, is also associated with mitochondrial dysfunction, oxidative stress, and worsening of Alzheimer's disease as well. So a lot of proteomic studies have also been, are coming up. We see that there are common pathways between diabetes and Alzheimer's as well. Now, both of them are very common entities, very commonly seen in the older age group, and they share common proteomic and genomic pathways as well. And this is just upcoming. So when we look at risk factors, if I had to list the 3 major risk factors for diabetes and Alzheimer's, it would be hyperglycemia, of course, hypoglycemia, and longer duration of diabetes. Screening, all our guidelines say that if your patient is 65 years or older, you have to begin screening for diabetes-related dementia. In younger age groups, if you see patients with significant cognitive decline, which can look like errors in calculating insulin dose, difficulty counting carbohydrates, they may come with skipped meals, skipped insulin doses, difficulty recognizing, preventing, or treating hypoglycemia, you should screen in them as well. They could be much younger. Now, commonly used tools like MMSE have been shown to be useful. As you can see, this is one study from India which has shown significantly lower MMSE scores and 3M scores in diabetes as compared to non-diabetes, and this can be done in the OPD. Treatment implications for diabetes. Now, this is very important. Most of our patients are on insulin or oral anti-diabetic drugs. So we know insulin is a major risk factor for dementia and diabetes, mainly related to hypoglycemia. But when we look at oral anti-diabetic drugs, a recent meta-analysis has shown that SGLT2 inhibitors and GLP-RAs may be actually beneficial in diabetes-related dementia, more than thiazolidinediones or DPP4 inhibitors for delaying the cognitive impairment. Now, all of them have shown some benefit, but the highest ranked are SGLT2 inhibitors and GLP-1 receptor agonists. When we look at sulfonylureas, they were actually associated with highest risk for cognitive impairment in diabetes dementia. So if your patient is at a high risk of dementia or in early stages of dementia, probably a good idea to use SGLT2 inhibitors or GLP-1 receptor agonists. So when we look at GLP-1 receptor agonists and dementia, now this is a very, very hot area because one trial recently concluded for dementia. The top line results were available yesterday. Now there were very many hypotheses that GLP-1 receptor agonists have neuroprotective effects by reducing the inflammation and reactive oxygen species. And these were the various theories that were put forward, and there was some evidence from real world studies and meta-analysis which said that GLP-1 receptor agonists can actually prevent dementia and diabetes. But this was a RCT recently concluded, EVOKE and EVOKE Plus, done by the company Novo Nordisk on oral semaglutide, looking at efficacy, safety, and tolerability of semaglutide, and also its effect on delaying the symptoms of Alzheimer's disease. Now, this was the study design. They looked at 3, 7, and 14 mg. This is also the doses that we give in diabetes and how we titrate. So it was oral, not injectable. And the top line results, there was just in the news 2 days back, and it did not show any effect on Alzheimer's. So this was very disappointing. Some of the hypothesis again after this trial is that most of the real world studies that we have seen are injectable GLP-1 RAs and not oral. So suppose you study GLP-1 RAs in a properly controlled setting, there may be some benefit, but that's again hypothesizing. But this is a upcoming area, and we have to look out in this space for more information. Now, statin use and dementia risk has again been in the controversy. So there have been many, again, hypothesized mechanisms where statin can actually worsen Alzheimer's disease by decreasing myelination and causing neuronal injury. But there have also been some proposed mechanisms that they are actually neuroprotective. So there has been a recent meta-analysis of over 7 million individuals on statin use, and just published in January 2025. And this reports that statin use significantly reduced the risk of dementia compared to non-users. It was associated with reduced risk of both AD and vascular dementia. Subgroup analysis, very interesting results. It showed the highest dementia risk reductions in patients with diabetes, those with exposure to statins for more than 3 years, and also populations from Asia. Additionally, rosuvastatin demonstrated the highest benefit compared to all the statins. Now, when we look at prevention, I think reasonable targets avoiding hyper and hypoglycemia would be a good approach. In older adults with diabetes who are otherwise healthy and have few stable and coexisting disease, a reasonable HbA1c would be between 7 to 7.5. If you look at time in range, it's between 70 to 180. This should be about 70% of their time, and if time below range less than 4% should be your target. But if you have adults with diabetes and intermediate or complex health issues and have variable life expectancy, good HbA1c target would be less than 8%, TIR between 70 to 180, and time below range target of less than 1%. And this is all there in ADA Standards of Care 2025. So again, looking at other preventable risk factors, we have modifiable risk factors as for any dementia that we have spoken about: education, hearing loss, hypertension, smoking, obesity, depression, physical inactivity, excessive alcohol consumption, air pollution, social isolation, and dyslipidemia. These are all modifiable risk factors in diabetes dementia, as with any other dementia, and treating this will lead to better outcomes in diabetes as well. So that brings me to the end of my presentation. Thank you one and all for your patience with me.
Thank you for the nice presentation. You made it very, very fast, I think. I don't know how many of you understood. Anyway, we'll go for early lunch. But any questions from the audience?
You mentioned about the sex difference between gender difference between male and female being higher. So what's the mechanism behind that?
I looked for the mechanism, but I did not find any mechanism. But if anybody else is aware of this, maybe you can tell me. I don't know, maybe because of earlier onset of diabetes also in women or linked to estrogen deficiency. I was trying to look, but there does not seem to be any explanation for it. Yeah, or multitasking maybe.
Dr. Lakshmi, is there any evidence of using a very small dose of GLP-1 agonist in patients, even though they're not diabetics?
No, there's no evidence for that because this was the only first RCT. The other evidence that we had was from real world studies, which did not study dementia as the outcome. But this was the EVOKE was the only study which studied dementia as an outcome. And with oral GLP-1, it was not showing any benefit. Injectable GLP-1, we don't have any evidence as of now. But as you know, there have been various studies looking at depression, alcohol dependence, and all of this, and they are showing benefits. But it's still a very upcoming area. Most of the evidence that we have is on diabetes and obesity and MASLD coming up now and heart failure outcomes coming up now. But I think there should be injectable GLP-1 RA trials soon in this space.
No, because cardiologists use it even if they're not diabetics. It's,
No,
it's
but
not
that's
just
approved. Yeah,
So
it's
there's nothing
studied and
like-
approved now.
No, right now not.
It's not approved for dementia.
Thanks.
My opinion, for last 25 years, I've seen so many diabetic patients. If patient is uncontrolled diabetes, family history of diabetes is there, or other other complications, vascular risk factors in the family. So what I prefer is better to start early initiation of statins as well as antiplatelet agents. So those who are on statins and antiplatelet agents, I have not seen any complication for last 20-25 years with or without insulin. So my opinion is better to start if it is uncontrolled diabetes is there, patient especially from rural area, they don't know how to take insulin or they are not refuse to take insulin. Better to start at least statin first initially, and in case if you want to add aspirin, if there is no contraindication, it's better. I think. Can you give your opinion?
Yeah, I think so. Even the meta-analysis, that was the largest one, which showed almost 7 million patients. It did show benefit. I think earlier there was a controversy, but now we are slowly moving towards statin being beneficial. And also, diabetes guidelines say that if your patient is already on statin in their 70s, 80s, better not to stop it because it does have benefit on dementia.
What's your idea about role of B12 in because majority of patients with diabetics will be on metformin for a long time.
Yes.
They tend to land up with B12 deficiency. Can it be a factor which can
So
contribute?
actually, all the evidence for metformin has been neutral. Actually, no evidence of increased risk of dementia or decrease. And they've also looked at covariates like vitamin B12. But that again, there has been no like proper randomized control trial. But from observational studies, it's largely been neutral. But B12 is a modifiable risk factor.
We have to see other risk factor like B12, thiamine deficiency, or hypocalcemia, other minerals, other things we have to deficiency we have to rule out. There,
So there's so many conferences like this where we say we go to orthopedics, we say that bone health should be a part like HbA1c. We go to geriatrics, we say MMSC and bone health. So there is a lot of thing to be done, but you know how our OPDs are, and you know if we are able to do HbA1c, then we consider ourselves successful. So a lot to be done in this area, but I think in a Western setting where you're only seeing 5 to 10 patients per day and you have that luxury, maybe yes. But here, what we can do is a staggered sort of. What I also do is, at the first visit, if you're not able to, evaluate them for everything, in the second, third, fourth, fifth visits, but at least once in, 3 to 6 months, they should be evaluated for all of the comorbidities. Yeah.
anyway, thank you for the presentation.
Thank you.
Thank you for a wonderful session, ma'am. It's an honor to have Dr. Lakshmi Nagendra ma'am with us today. We request ma'am to accept a small token of appreciation, and we request the chairpersons to hand over the memento and honor ma'am. We'd also like to thank Dr. Ajay Hanumantu sir and Dr. K.C. Shashidhara sir for chairing the session. May I request Dr. Kshama K. ma'am and Dr. Shilpa ma'am to present a small token of respect to our chairpersons. Thank you, dignitaries. Now it's time for the lunch break. I request the gathering to accept the lunch arranged outside and gather back here in the auditorium as soon as possible. Culturals are arranged after the scientific session, which will end around 4:30. So I request the gathering to. 2:30. The afternoon session starts at 2:30, so I request the gathering to gather back in the auditorium within 2:30. And culturals will be held after the afternoon session, scientific session, in the old auditorium. So I request the gathering to attend the culturals as well. Thank you.
ಆಡಿಯೋ ಬರುತ್ತಂತ ಅವಾಗ
Welcome back, everyone. Let us now continue with the scientific session, which is a panel discussion on the topic Integrating Care in Alzheimer's, Role of Various Specialists. May I now welcome the moderator for the panel discussion, Dr. Nayanabai Shabadi, Associate Professor, Department of Community Medicine, JSS Medical College, Mysuru. Ma'am is a IQAC coordinator and has 33 publications and 3 funded projects. It's a pleasure to have you with us, ma'am. Welcome, ma'am. I'd also like to welcome our today's panelists, Dr. P.T. Shivakumar, Professor, Department of Psychiatry, National Institute of Mental Health and Neurosciences, Bengaluru. Welcome, sir. Mrs. Venu Vora, ma'am, Chairperson, Alzheimer's and Related Disorders Society of India, New Delhi. Welcome, ma'am. Dr. Jamuna Rani V. Mirle, Secretary of Mysuru Art Gallery, Mysuru. Welcome, ma'am. Dr. Amitabh Kishore Dwivedi, Professor and Head, Department of Occupational Therapy at JSS Medical College, Mysuru. Welcome, sir. Dr. Arvind Kasturi, Head, St. John's Geriatric Center, A Ray of Hope, Professor of Community Medicine, St. John's Medical College and Hospital, Bengaluru. Welcome, sir. I once again welcome all the panel members and the moderator. Over to you, ma'am.
Thank you all. First of all, thank you for giving this opportunity to moderate this panel. This is one of the maybe important session in this conference, as all the stalwarts who have worked in this dementia and Alzheimer's are sitting here to discuss on the important topic. As we have already seen since morning the sessions, so the care in the Alzheimer's or in the dementia, it involves integrated care, which is required. So it is a multidisciplinary care which is required. For that reason, this discussion helps us in various the role of various specialities and what it can contribute in betterment of the patient care, as well as propose strategies to strengthen the integrated Alzheimer's care in India. I welcome all the panelists for this session. So as we know, we have a psychiatrist, we have a community medicine person who is heading the geriatric unit, the chairman of the Alzheimer's and related diseases association, and occupation therapy head, and madam who is one of the unique panelists over here is the artist. So, and she has mastered in many areas. We can discuss throughout this panel what are her experiences in the care of this Alzheimer's and dementia cases. The first question to psychiatrists, we'll start with the specialist in this. So, what early behavioral signs should families look for to identify the Alzheimer's, sir? Let us start with the basic things.
Yeah, I think first of all, I thank you for inviting me, and thanks for the organizing committee to have me here. So I think this we have already discussed in the previous sessions also. I think this is one of the challenging things. Most of the people who develop Alzheimer's develop a very gradual, insidious onset change. And particularly in the Indian context, when many of the elderly don't have very active responsibilities for complex activities, it's very difficult to identify and very easy to miss. So what the families have to actually watch out for any change where the person slows down. And the biggest risk is that we have an ageist kind of view, ageism, where we think it is normal for aging. So any change is assumed as normal. So it would be and the most important thing is to have an eye. For that, you need to have an interaction. You need to find out as to how the person is slowing down. Some slowing down is possible. If they have difficulties, it needs professional evaluation whenever there is a concern. So ideal person will be to is general physician or family physician who should be able to find out, and if there is a concern, then they have to risk. Because most of the symptoms, what we talk about, memory impairment being very prominent or behavioral changes, only when it comes to a more advanced stages, those things gets noticed, or not everybody develops also. So I think the first thing is any change where there's a slowing down, where they have difficulties, one has to kind of, as part of general health checkup, they have to do it. And the common symptoms, most common symptoms is people forgetting recent events. And in terms of other dementias like FTDs, where they have prominent behavioral change, even though memory is preserved.
So, in that, is the counseling underused in dementia care, according to you, or how can it can be encouraged in life?
See, when we talk of counseling, we need to see as to what we mean by counseling. Say, for example, in dementia, the process starts with disclosure of diagnosis. Now, this is a life-changing diagnosis for the individual and for the family. So, how is it being done? Many times it is not satisfactory. Even I would say, even in our institute with multiple resources, it is not easy. So actually, that needs a more kind of active engagement with the individual and the family, and a very sensitive way of doing, and then preparing them for the journey of dementia. So that is post-diagnostic support is required. Diagnosis disclosure itself is a big important thing, and at every stage there is a need for psychological and psychosocial intervention, which forms the actual say what is a large proportion of the care. The medication's role or more supportive. I think for everybody you need care which is non-pharmacological, and as of now it is underutilized. Underutilized because it is very resource intensive for both the patient as well as for the caregiver. So we need to, because whenever we need more intensive things, the family has to be ready, and most often the counseling is for the caregivers. But we do have people now coming up with early symptoms and are concerned and worried about what is going to happen in the future. And that segment of people is going to become more and more in future, wherein you have to deal with those people who are aware of their cognitive impairment, and then they're going to seek more answers regarding that. So we now have started something called as a post-diagnostic support service in collaboration with Dementia India Alliance. And I think all of us, we need to have adequate resources for us to offer such time-intensive kind of services. And we also need to emphasize the families and caregivers that this is equally important, rather than just doing doctor shopping and trying to find multiple consultations to review the diagnosis. I think these things required counseling or supportive interventions are very much required.
True, sir. We'll come for the next how to fill this gap later with a discussion. So, my next question is for Arvind, sir. From a community medicine and a public health perspective, what are the biggest gaps you are seeing in early detection and continuity of care in Alzheimer's?
Yes, good afternoon, ladies and gentlemen. Thank you for having me here on your panel. Yes, taking off from what Dr. Shukmar said, I think the acceptance of what is considered as normal aging has to probably change the perception among the community. Now, it is different when we look at those who reach hospitals. Mostly our conclusions are all drawn from people who present to our OPDs. But we must understand that that population is a self-selected population, a population who's either themselves reporting or being brought by somebody who's aware. But I always tell those working with the elderly that the bulk of the elderly are out there. They are not in the hospital. They are not coming to the hospital. They are nowhere near the hospital. Now, what about those people, and how do we detect early signs of dementia in that population is the challenge. So one is, of course, the perception of what is acceptable as normal aging. Like ma'am said in the morning, what are those first few things that people should watch out for to recognize that this may not actually be normal aging? This is something which should be taken up seriously. So that awareness is one huge area of gap. The second is obviously who's going to do it? As in, okay, so I have an older person in my house and I notice that there's something odd about him or her. That first sign which ma'am spoke about has happened. Now I go to my clinic nearby or out there, like I say, where do I go? First of all, do I go to a health and wellness center? Do I go to a primary health center? And if I go and tell that guy, look, this man is not doing this, or this morning I noticed this, what are the chances that something good is going to happen there? That something is going to be taken up and actually worked on and a solution? And I think we've got a long way to go in terms of all of that. Correct, we are developing our services in institutions, no doubt about it. I mean, it's great to see the spectrum of services available in institutions, including my own, where we are really trying to do what we can. But we must always be cognizant that if we are talking about the health of the public, then the institution is the tip of the iceberg. It's out there that we've got. So one is, like I said, awareness. Second is there should be obviously then a thrust to educating those primary care providers as to what should they do if they detect this. The provider, not the patient. Okay, that family has recognized based on our awareness, they've recognized and they've brought him to a primary care point. What happens there is also another big area, I think, which is a challenge for people to detect dementia early. There are more, but there are others on the panel. We need to hear them as well. So I'll stop here at this point.
Thank you for mentioning that main as awareness and the training the grassroots workers who fills the gap in the community. Next question for Renu ma'am. And this, how can we make community spaces like parks, activity centers, or daycare centers more dementia friendly?
Okay, talking about daycare centers and respite care centers, about dementia care, they already have standard operating procedures. So they generally have things like good lighting, grab bars, anti-skid, tiles and all that. That is always there. But what about outside their home or in their homes where these people, because most of the people are not going to be in respite homes. They will be either in their own home or in public spaces. Like that would be, of course, in the public spaces like parks, it should be, the signage should be good. The path should be properly lit, if not lit, maybe colored. A colored tile, like they have for those blind, those things which they can see with their stick, something like a colored pathway so that they know exactly where it is. And also at that time when these are the places where not just every elderly come, there are a lot of other people come. So we have to train not exactly train, basically make the guards over there aware that these kind of situations can happen. So like a person was, this lady, her father was wandering off. So she said, no, I can't send him to the park. But one day he did go to the park. He just escaped and went. And then she was left. She did not know where he was. And so this is where she realized that she had to go and tell the neighborhood guard, the neighborhood children who were playing outside, okay, look, this is my father. He's got this disease, and sometimes he'll be coming out. So please, so come out of your home and talk to people about it. So this is how we make our neighborhood, talk to also talk to the local police, the senior citizen there, that we have patients like that at home. So this is the first thing that we have to make them. And also what he said just now, this gentleman said that about awareness. The main thing is about awareness. The moment you are aware of a particular problem, you'll find a solution. But if you're not even aware of this problem, that there is a problem like dementia, how would you do anything about it? And sadly, even the general physicians miss it. That is the problem. We have to train the physicians, we have to train the nurses, and all these things. So public spaces is fine, but the awareness should be there as well.
Thank you. Ma'am, next is for the Jamuna ma'am. What from your work or contact with the community, then what practical challenges the caregivers and the families share with you when you interact with them?
Good afternoon, everyone. Thanks for giving me opportunity to be on this dais in this discussion. Dr. Naina, your question is what is the grievance that I receive from the people when I meet in different classes? Here I can make two divisions like urban people and rural people. There are certain subtle changes, In the urban area, as you know, the people will have easy access to the many social medias, as well as they will have a lot of contact with the doctors. They can go affordable to go to the clinics. Whereas in the rural place, as I have observed, especially when I focused on Mysore district, here almost 6 to 7 villages, there is one primary health center. So when as you know, of late, even the rural people, youngsters, for the sake of their bread and butter, they just move to the near town and cities for their works. And children, naturally, they go for the schools, whereas the elders will be neglected, and they had hardly very tough to move around. And if they have to go 6 or 7 kilometers to approach the primary center, health center, that's one problem. Second thing, after going to the primary health center, in most of the cases, I'm not generalizing, in most of the cases, in the primary health center, the doctors who are appointed, if they are not much trained in this disease, if they are just a general physicians, or they are not with much experience, there are so many facts I don't want to mention here in detail. So in that case, they may not recognize the disease in the first stage when they meet the patients. Second thing, the rural people, as you know, the elders, they will not aware. Awareness is very poor in the rural side about this. And even in the urban place, most of the people, general attitude of the people, they say it's because of the aging. It's just a age factor, you need not worry. When once they see the person physically fit and active, even if they express some shortages that they are facing some mess, they will say it's just a age factor, you need not worry much about. They take it very light in this matter, and they will not focus on this. This is another thing. Second thing, in the rural side, financial constraint will be very much, and they are not much affordable to approach the right to doctors, traveling all the way. So traveling is a one problem. Second thing, they should be affordable to meet the doctor. Third fact is, the awareness programs and camps are much more in the urban areas, but not in interior places. Recently, we conducted some medical camp in about 10 kilometers from this place where Dr. Pratibha was with me and few more doctors also. And because there is no deep awareness to the people, it is very tough to organize the people there. Even we give so many informations earlier that we are conducting a medical camp. It is totally free. You please come and participate. Even then, the people will not come. So the more awareness program is required. That's what I feel. And people in the house, youngsters, they go for job, and children go to the schools. So the elders hardly they get interaction with the people at home. What I feel deeply is, most of the people will be relocated. Like when the elderly person, they lose the spouse, they will be shifted to some other place where the children are there, maybe outside India also. And they miss their routines, as well as they miss their surroundings. So even these things very deeply affects the person. That's what I feel. So this is all I can give on this subject.
Yes, ma'am. Thank you for sharing your experience. Amitabh sir, with your expertise, what are some simple home-based strategies or modification that can make daily life easier for the Alzheimer's patients?
Okay. Good afternoon, all. Before coming to the topic, I just want to give you a situation. Like when the humans was in the forest, the stone areas, from that time, humans are trying to become master of the environment. This is regarding human and environment interface. So now in this area with the help of science, technology, or our creative problem solving, we have achieved mastery somewhat. Even in this era, we have not achieved all. Lots of things we have to achieve. Like if we want to see about, we want to fly in air like that. Many examples are there. I want to cut it short. But all these situations, all this mastery, all this command or whatever the control or comfort we have achieved for whom? For normal people who are able, who are considered normal as per our societal norms, like physical, mental, emotional, social, and all. But what about the people who are not considered completely able, completely normal, who have some problem, like dementia people? Their physical abilities are going to reduce their cognitive ability, memory, and due to aging, all the systems are declining. Even it's happened in the normal population when we are crossing our 60. So there is lots of gap, lots of cognitive and perceptual decline happens. If you are taking an age group of 60 to 70 and 70 to 80, even for normal, there is lots of the declines happens. So we are not thinking about these special people. So when we are going to consider dementia people, so occupational therapist is considering everything. This is a holistic approach. We are not just thinking that how they are performing ADL and all. So if we are talking about environment, there is two type of environment. The first is physical environment, and the second is psychosocial environment, where social workers, psychologists, psychiatrists have a great role. So I'm not going to focus much on that. Coming to this physical. So first of all, memory. Memory is affecting a lot. So for memory, you have to keep the reminders. Reminders must be digital or whatever alarm and all manual you can take. You have to keep these organizers. Even like medicine organizer is very common, where the Monday to Saturday has been written and evening, morning, everything is written. Then calendars, charts, diary, even Each and every activity you can schedule what you are going to do from morning to night. So by this, we can compensate the memory issues somewhat, even the leveling. Leveling, if you are writing something or if you are doing some activity, you can level. Then organizing the kitchen and other work space where you are working. If somebody is busy in gardening or some other activities or socialization, they can do all these things. Then if there is caregiver, they can give the cues and all. So this way we can manage the memory. There are many things. I can't, there is the limitation of lifetime. So coming to the ADL, when you are talking about ADL, I'm talking about dressing. The buttoning, unbuttoning is very easy for us because we have learned this motor learning and this is automated. Have you seen how children struggle when they are learning the buttoning? So same due to some problem, if they have lost the motor learning, then how to give adaptive dress. Like if I'm giving the large button, I'm giving the press button, I'm giving the hook button, I'm giving the jeep, I am giving the Velcro. So by all these things, I can make them independent. So same way, if there is the issue in feeding. So feeding, the plate guard is there, even in self-feeder is there. So in everything, we start with the very basic things, like the build up a spoon, build up brush, motorized and means self-guided feeders. The feeders are there, you just keep it on the table and fix it, schedule it. It will feed you. You have to just go there. Even if you have problem in the brushing, your hand is shaking and all. So we give weighted cup and all, but if it's not working, we can fix the brush in the table or wherever you are going to work in the kitchen or washroom, and then you have to just be there. That will do the work, right? And even the smart homes are there. If you are going in a kitchen or going in the washroom or going in the bedroom, all lights, fans, everything on your voice control, or you have the remote, by that you can control everything. So when patient used to come to us, we see patient as a whole, right? So in ADL, like this basic ADL, feeding, dressing, bathing, as Madam mentioned, that non-skid board and the knife and all, we have to consider. So many components are there. So next is like functional mobility. Functional mobility is also a very important area because you all know that fear of fall or fall is a very dangerous thing, and in that the people have to suffer a lot. So what I have seen, yet we have to work on this area, that we are prescribing the wheelchair, but the trend of buying the wheelchair or taking the wheelchair is very difficult, very different. Doctor have prescribed me a wheelchair, I am going to the shop and I have 10,000 rupees. I'm not saying which size, which type, manual, motorized, semi-motorized, inclined, uh, nothing. In 10,000, what I will get, I will buy that and come back. If there is some modification, the backrest is not good, rest is not good, or this width is not good, depth is not good. So we are not consulting any expert, and even we professionals are not prescribing like that. So we have to work over there. Even when we are giving a cane, a clutch, a wheelchair, a tricycle, whatever assistive adaptive devices we are giving, we have to work over there. So we do it as much possible. After this, if we are coming from memory, then ADL, IADL, and then we have to consider their leisure time also. We think that if somebody has some problem or they are aging, the recreation leisure is not a part of life. No, we must have to include it. Whatever they are doing, they are just doing some gardening work or they are taking care of the children's or whatever. So there we have to consider all the issues. After that, even the rest and sleep. Due to aging, the sleep cycle and sleep duration is going to reduce. So how to make situation like how to reduce the stress, how to keep the environment less light, and the avoiding this screen time, uh, closing it 1 hour before, and comfortable bed and safety when they are sleeping. So bed guard and all, so that they are not going to get fall down. Even when in night they are getting up and going to the washroom, the light, non-skid map, and contrast tiles so that the vision will be good, lighting will be much proper. So all these things, even when they are going to the bathroom, they must be instructed not to close the door. They can just cover it, but not lock it. So all these things in rest and sleep we have to consider. Even we have to consider their psychosocial component. So their personal interest, hobby, habits, and all the socialization. In that age, they are not socializing much. So we have to make a smaller group where they can socialize and they can share themselves, they can connect with others. So other socialization and emotional component and other professional will take care. Okay. So I'm coming to the next, that is spirituality. We are not giving much focus on all these components, but spirituality is also the part and parcel of the society. 95 or more than that people are believing in some other faith. So even there, if they are going to their churches or temple or whatever the place, what is the seating arrangement they have, and what is the barrier-free environment they are getting? Barrier-free environment in house is also important. If they are on wheelchair, so loading the doors, the slab or everything switches on the wall must be on that reaching area. All these things must be done. So there, if they are going for spiritual places, the seating and mobility, then their book holder and then front pages must be the large font and all, so that they can read it properly. So all these component we must have to consider. And as madam told that this is multidisciplinary team, of course, but we are giving focus on some specific area and we are giving less importance to some other area. So when patient is coming, we have to consider this is a human being who have limited ability now, but he was doing good. If a doctor or engineer or IS, IPS have retired, so we have to understand that what was his profession, so what is his mindset, all the things we have to see. Thank you, madam.
Yes, sir. So the thing is fragmented care, what we are giving as a piece in each, whenever they come to the specialist, we are giving it them as a fragmented. As sir mentioned, in all the aspects, if we see in them as a holistic one, as a one person, then if we start giving the care, maybe that gives them the complete Kanivana. When he was mentioning, I was remembering the movie that Kishkinda Kand. Anybody has seen the Malayalam movie? Yes. Though he organizes everything in his room, he'll get to know even somebody has opened that door, somebody has just opened the drawer. So that much of acquaintance they'll develop for that system. If somebody is coming, he'll open the diary. The things he would have written it with the photograph. Okay, friends, who are the friends, who are not so good friends, they may act with them, they may cheat them anytime. So they'll have an booklet with them. So whenever that person enters, they'll open it and see what is this person, what he talked the last time what he had spoken about and all. So I just remember that movie. If you, that is how the tips, whatever he was giving, the sir was giving, that was implemented there. Every note was kept, every alarm was there, everything, alerts were there, color coding was there. So that movie, I think, if we see that, they'll how they struggle with their life and how they make that in a easier way or in a systematic way, how they lead that life and all. The story is about something, but this is one character where he maintains his routine in such a systematic way so that he can live comfortably. Otherwise he'll be chaotic in his own mind. So coming back to Arvind sir, so as you mentioned, the health workers have to be trained how to identify the cases at the earliest. So how can the community health workers can be trained? What way we can help them to identify the cases at the grassroots level?
Community health workers. Okay. Well, ladies and gentlemen, 2003 is when we started the first rural geriatric clinic in rural. And if you look at the composition of the team which went out there and started these clinics, gradually we expanded into the team comprised of a doctor. I think in the earlier stages we didn't even have a nurse, but we had a community health worker. And I think that the role played by health workers when you are talking about the population out there is a very critical one, because they are an extremely useful, trainable, very good resource available as a link between the last person in the community and the health system. So our experience with community health workers has been that you can train them to do many things. Over the years, we started doing a community eye care and a community ear care project, where the prevalence of hearing impairment was our focus. And health workers were trained to the point where at our rural health center clinic, primary care clinic, if a person comes, a patient comes with a foreign body in the ear, you can send that person to the health worker, and that health worker will remove the foreign body. To that point, it is possible to train a community health worker. So therefore, the question was, what is the role of a community health worker in this cognitive impairment scenario? I definitely think that the community health worker should play a very important role. Now, in the public health system, who are we talking about? This is an institution, drop in the ocean. But in the public health system, when we say community health worker, who is it that we are actually talking about? We probably are talking about the ASHA, who is already burdened with a lot of things. You know that maternal and child health forms about 98% of her mental focus. And then the remaining is spread out to the rest of the programs and problems in the community. We are talking about the next level, which is the A&M, or the multipurpose worker female. And she also has got a fairish amount of tasks. So would it be feasible then to train these kind of workers in this and expect that they will actually deliver? I still think we must be optimistic. I think it is possible, because after all, it is not that every older person has cognitive impairment. No, it is that we must train them to detect early, prevent, of course. I mean, and don't get me started on what all they should do as far as prevention is concerned, based on what we heard this morning. I have a favorite mnemonic which I tell my students. If we have the time, I'll share it here. But in terms of prevention and early detection, to put it very simply, I think the community health worker plays a very key role. It's just a question of how do we actually work on the profile of the job of the community health worker to ensure that this is also taken up. And still, my second question is still there. I mean, the second problem I outlined earlier, which is when she detects it, what does she do? Where does she go with that person? And what will be the service available at that level for that person is something we have to sort out. Because community health worker If she feels that the next level is not strong, she's not anymore motivated to do her work. I mean, if you train her to pick up diabetes and hypertension, and she picks up, and then she takes the guy to the primary health center only to find, like Madam, I think, said, there is nobody there. Her motivation and that whole chain of events falls flat, you know? And so therefore, simple answer, I mean, after a lot of talking, is yes, a community health worker does play a very important role in the care, continuity of care for any person with any chronic disease, including chronic cognitive impairment, I would think. But there is a lot to be done in terms of equipping, training, and ensuring the next level is ready to receive what the community health worker takes.
Maybe the separate cadre of people, not existing one, the another human resource, increased human resource at the grassroots level can help out us when we think about mental
Maybe.
health as such.
Maybe, but government is not going in that verticalized line of specialized health workers. They are still considering integrating. But the same cadre of health worker, whether you can have more of, is the question. Yes, of course.
My question to the next with the continuation of this, as a psychiatrist, how you want to collaborate more effectively with the other specialists to fill this gap of fragmented care, where we are not compartmentalizing the care of the elderly in this dementia and Alzheimer's, how we can collaborate with the other specialists?
Yeah, thanks for the question. I think we are in a highly specialized world. So we have specialty for everything. If you take care of dementia, we have geriatric psychiatry, we have cognitive neurology, we have geriatrician, and then we have many other specialists, and from public health to kind of psychology, clinical psychology, neuropsychology, occupational therapy, physiotherapy. So I don't know whether we say that specialization is the solution for the patient, to whom to, because we are talking of a system where people, only 10% of the people seek help. So what we need to recognize with respect to specialty is a condition like dementia require multidisciplinary care. That doesn't mean people have to go from pillar to post like multiple settings. I think all of us, we need to know our discipline, our strengths, but also learn from other disciplines. Because I think India is not ready for kind of too many specialized services at this point of time. And but there are people who look for the most equipped specialist and come. But I think when we talk in this forum, we don't recommend that as the primary solution. I think this right from a caregiver to art therapist to everybody, I think everybody has something to offer, and we need to see how in our own practice we can use those skills when it comes to the patient or a family. A single window system to a large extent, and then consultations whenever there is required. Some inputs is more recommended than referral to multiple specialists. What we practice in our unit, we have a multidisciplinary team. NIMANS being a highly resourced tertiary care center, we have a focus on training and research. We have multiple departments, but within our own geriatric psychiatry unit, we have brought in everybody in one umbrella, wherein we have fellowship program for clinical psychology or social work, for psychiatric nursing, and then we do psychiatrists are there. We also network with various NGOs and other people, including lay counselors and other people. So I think everybody has something to offer.
So that is in one center, if
Public.
everybody is available, then we can collaborate with them, or else one person should learn all the basic things.
Yes, I think that is much more feasible than to create multiple demands or multiple specialists. I think we have enough of specialists to such an extent that
Should take a more
I think dementia is a problem everybody has. If they are a good clinician, they can offer. And I don't think at some point of time medical care becomes a prominent. At some point of time, non-medical care becomes a prominent. I think these are the both divisions where people needs to. Which one needs more active? It depends on the stage of the person. When the diagnosis is there, initial diagnosis, we have more emphasis on medical care. And within that, I think all of us can do the work. If they are rightly trained, all specialists can do the work. We need to respect each other, and then everybody has their own strengths. And people come to us if there is a person with a lot of behavioral problems. People land up in psychiatry. So if they have a lot of Parkinsonism or movement disorders, they land up in neurology. If they have complex, I think multimorbidity and complexity, they are more with geriatricians. So we have enough work.
Yes, sir.
I think all of us have our patients.
Maybe the frequent that as awareness, though we are specialists, we should be aware that the care requires this part also. That awareness, maybe if you improve or periodically, if we give to the caregivers or a specialist, then
Yeah, if I can just add on to what Dr. Arvind said, I think it is not that people don't know. It is about the system is already clogged with a lot of work and thinks that it is not my work. If you ask the PHC medical officer, it is not that they don't know dementia. The health worker, when we interact with ASHA workers, most of them know what is dementia. They would have seen in their lifetime, in their family, when they go to community. It is not that they don't know. It is about lack of systems to add these as a components. Even though on paper, geriatric care or a mental health care or a palliative care are all part of the services, scope of the services in health and wellness centers, reality is very different.
maybe the targets are not there.
Yeah, they don't have enough time and scope or incentive to do that. If you identify a person with a delivery for a antenatal care, you do the vaccine, you have incentives mechanisms. If you identify a person with dementia and bring them for treatment, you don't have an incentive. Unfortunately, our public health system works on incentive based system. There has to be a monetary incentive as well as the incentive can be otherwise. I took this person, the system is able to care for this person. Even that is an incentive. If you go and then say, why did you bring this person?
Maybe
You send demands. So as of now, I am 99% confident our public health systems or many of the specialists, they'll say this is normal for aging, don't go. Unless the person is really disturbed, we don't have the resources to spend time and provide care, which is the big ask. And for that, you don't need specialists. You need empowered individuals. Everybody, any discipline can do that. It is not a rocket science.
To the Jamuna ma'am, how your artwork can help in prevention. First thing is prevention of this problem, and in coping up with if at all the person is having any early dementia symptoms or anything, how can they cope up with the art things? Any of the art role?
Yeah, thank you, ma'am. In fact, first, what I would like to say is most of the people who are around me, with whom I'm associated more, are all above 75, 80. Okay, and I'm having one lady aged about 101 years. Last year, she wrote a book, and it was a privilege for me to be a part of the function of releasing that book at her residence. And every year, she prepares sweets when I visit, and she wants to offer to me in the new year. See how she is so active at the age of 101. I observed something. She was not highly qualified. She could educate up to the fifth standard, but she had a passion to know more, and she's made self study, and she educated plenty of more than 3,000 children who are economically backward. She taught Hindi language and made them to take exams and make their own lives. Financially, they could become sound, and she has written Kannada books, more than 16 books, and the 16th book was at the age of 100. And she is staying in Brindavan extension, Mysore, and very often I meet her. See, this is one example, and there are plenty of dancers in Mysore city also above 70 years. Even today they perform. I am 66, and at the age of 64 I could perform 1.5 hours solo program. See, what I feel is when you keep, thank you, when we keep very alert, and first thing, person should love what he does, he or she. So they will have, even the cooking is an art, unless until they are exposed, and they always keep, as I said, they should not be there routines. So, see, as an artist, I want to dance, I want to do some yoga to keep my health fit, and I want to sing, I do some painting works. My field may be different, but as a painting artist, you take. If they want to create a scenery from the childhood or from somewhere in the middle age, they might have picked up this art as a hobby. Due to some reasons, they might have picked up late, or some may start from the young childhood. And it is any art you take, dance, music, writing hobby, or painting or craft work, it needs creativity. One has to create something unique. What I do that you cannot do, everything will be unique. So the brain can be kept more active, and it will keep stimulating when they start doing something, and at the same time there will be a joy inside when they start doing something they like. So that keeps a person very healthy. That's what I have observed, because people who write articles or poems, something unique what they study, and they go deep into that, so then they just forget. For example, sometimes, rarely, I suffer from migraine headache, but when I get the headache, I can't dance, it trigger. But when I just started doing the painting work, I just spread the colors and start doing something. By the time I finish a artwork, I'll be fine. I will not take any tablets at all. So we can avoid many things by doing art. It helps a lot, because even gardening, it's a very good hobby. If somebody has learnt it, they should not be restricted. In many houses, what I observed, you are aged, why you want to do now? Enough, all these days you have done. Now you can relax. This kind of negative thoughts they push. Let's not restrict them. Even at the age of 85, 90, or 100, encourage them. They have a right to live on this earth till the end with whatever they like to do. Let them do it. Let's respect their hobbies, their interest, and give support to them. So regarding this, we need lot of awareness in both urban areas as well as in the rural areas. But in the aged people in the rural place, you see, at the age of 80, 85, their hobbies is to graze the cattle or sheep or any domestic animals they raise. They will not have any such health issues at all. They remember everything. They talk the ancient anecdotes as well as the present situations. Maybe because they are exposed so much to the greenery, the supply of oxygen, they get more, and they enjoy what they do. So any paperwork, any artwork or writing hobbies, I feel one should have a hobbies apart from the academic career, so that as they grow, as the age passes, I'm just against thinking of age, because everything has been created. So the nature, when you see, no tree or no animals think of their age. Just it is a process, it is going on. We have taken birth, it's a process, it's going on. Let's not think of the end. When it comes, it will happen. Let's not worry about that. Let's celebrate the moment. And whatever the hobbies we want to do, give freedom, give encouragement, let them do. Suppose a painting artist, if he or she is suffering from dementia, most probably, I have not tried this experiment, but if you give some colors and papers, they may start doing something. Most probably this may help them to come out from their situations.
Thank you, ma'am. Thank you for sharing your own experience there. And yes, maybe this is one part of the puzzle we always miss in giving the care for the needy one. But this is also a part of preventive care, what we can, or management, healthy management of the dementia and Alzheimer's, where we can stimulate them to come out with their own hobbies and practice that and this. Thank you for sharing that, ma'am. And to Renu, ma'am, can you share one or two real life stories where community support made a significant contribution in a difference in the family or in the care of the Alzheimer's?
Uh, let me talk about first where there was no support, and then there was support. So it started with my own experience. when one day I received a postcard written by my father. You know, olden time we used to have postcards, and he said that why don't you come and see me? And we are staying in the same city, and I said, why haven't you given, phone call to me and asked me? I was very worried and I rushed and I said, Dad, what happened? Why did you do that? He says, oh, your mother is not giving me food. I was shocked. I said, what? I mean, she's such a great cook and everybody admired her cooking taste and everything. So I said, Mom, why aren't you giving him food? She says, oh, I gave him once, he asked for it again, then I gave him another time. Again, he had it. And then when I went to sleep in the afternoon, he opened the fridge and started eating food again. And now he's got a bad stomach and he's in the bathroom all the time. So I was said, okay, he's old, Mom, what does it matter? Give him little more food. So she started crying. She says, he's always fighting with me because I'm not giving him food. I never understood this. And all the time I was going home to sort out their problems with each other. Sometimes he was tearing off some papers. Sometimes he was doing some funny things. And I did not know about it. We didn't even think of going to a doctor, in the sense that, what do we say, that he's asking for more food? Do we go to the doctor? Or he's tearing off this paper? Shall we go to the doctor? So, and I remember my mother was miserable. I used to fight with her all the time. You're not taking care. And all that thing happened to me I never realized what was happening. Then, of course, I got involved with Alzheimer's. I came to know what was. And I realized, why did he write me a letter? Because he forgot how to dial. He forgot the first number. He must have got frustrated dialing. And that's why he wrote me a letter. Anyway, so that was one thing. And secondly, when I joined Alzheimer's and I knew more about it, I got training in it. There was this, one of our, not somebody we knew, she rang me up. She says, my father, who's suffering from Alzheimer's, which I knew about it, and she says he's in the hospital, and he was from Kerala. So he knew Malayalam, which was his mother tongue. But he was living in Delhi, so he knew English very well and he knew Hindi very well. And then he says he's in the hospital, and now the nurses, he's forgotten Hindi and English. He's only speaking in Malayalam. And the nurses can't give him medication. They won't allow me to go into to his room because there was visiting hours, so what do I do? I said, okay, now I know more about it. I said, I'm coming to the hospital. I went to the hospital. I spoke to the doctors. I spoke to the nurses. I said, look, this person is suffering from Alzheimer's and he has forgotten this language. And you're talking to him in Hindi. Open your mouth. We want to put medicine. And he's screaming and shouting. He doesn't know what you're asking him. So he has only remembered the thing. So this is how I said, not as a community right now, but as somebody I knew I could help them. And then the daughter was allowed to go inside the room at all times. She was allowed, so she could take care of the father. And the father was not, earlier they had tied him up to the hospital bed because he was running away all the time. He did not know why he was there. So these are the things which I personally felt, and this is how we as community, we know about it, we should talk about it to people. So more and more people are there, like that's why we do awareness programs, so more and more people know about it. And only then we can help them. Unless they don't know, nobody can help them. In my case, this is what happened. I couldn't help my father. And I helped this other somebody else's father. So that at least I did something for my father.
Yes.
Thank you.
So it's always the case by cases. We have to customize the care. It is not one case we treat like this, that we cannot generalize it to all the cases. So maybe that awareness gives that modification what we can make in every case to give them the comfort and give them the care, and that is what is required. Sir Amitabh, sir, like how does the occupation therapy fit into the long-term management of the cases if it, especially the disease progresses. So
It means progressive and chronic like that.
Yeah.
Yeah. So I feel occupational therapy is much more fit in this type of the situation. Like if there is a acute care where remedial therapy is going to help and recover all the things, then I think one person is affected and the person is going to become cured. But you just imagine that this dementia patient, chronic patient, he don't have control on ADL and other functions. He is in severe pain, stress, and other issues. So what is the suffering? The suffering is not just for that a single person. The family members, the close relatives, and even neighbors and society, everybody is suffering. Because when they are seeing that that person is crying in night, that person is needing help if he want to go away from the home to the visit the doctor or park or some other work. So everybody feels, oh, why this person is suffering? This is so sad. Like that. So if we are rehabilitating a chronic patient, it means we are rehabilitating over all the society. Of course, mainly to the patient, secondary the family members, and third is the social connections. So what occupational therapists do, in short terms, making dependent person functionally independent. Dependent mean in any age, from the childhood to the elderly to palliative to terminal, whatever. If somebody is not able to do whatever they want to do, they need to do as per their cultural value beliefs and their demand of the society and in person. So occupational therapy help them to become functionally independent. I'm not telling dependent, independent. Independent, we are not God. We can't make everybody independent. But functionally independent, we can make. With the help of simple aids, appliances, activities, and even the technology, we can make anyone functionally independent in this world. This science has been grown up like that. So when we are talking about this, the pain, first of all, we are going to make a baseline that what the residual ability a person have in all the domains like physical, mental, emotional, social, personal, ideal, whatever. And then we are trying to give the remedial therapy. If remedial therapy is not helping much, then we are going to do the compensatory technique where assistive technology, assistive technique, adaptive device, adaptive approaches are going to help. And if that is also not helping much, then we do the compensatory technique that modifying the environment. Modifying the environment means not just this table, chair, kitchen and all. Even whatever the tools, whatever the things they are using, as I mentioned, the adaptive dressing and all. So this way we are going to make them independent. So like a pain management is very important in this chronic cases, right? So where we use even physical modalities, simple diversional therapy and all. The second in this age, fall. Fall is very important and I consider fear of fall is more important for occupational therapists because fear of fall restrict the activity and we are occupational therapists. Our job is to keep the person occupied, give them the activity where he is working. Of course, activities designed as per their hobby, habit, cultural issues, abilities, and all. So, if he is actively involved in some activities, he is doing himself. So, he is going to become motivated, and that way he will cure himself because our brain is much more stronger and more powerful than what we think. Like if you are thinking about cognitive brain, conscious brain, so we use only 9 to 12% of our brain. Our brain ability, we are just using maximum 12%. Even Newton, Einstein have used the maximum like that. But our subconscious brain have much more power and we are not utilizing that. Yeah, of course, in ancient time, our rishis and all people have used that. So point is that the activity restriction, when there is the fear, a person want to go and sit on the table, want to write something, but he have fear that if I will go, I will fall. So fear of fall is very important, and for that we modify the environment. See, the environment you have been adopted, a spatio-temporal adaptation, right? Whatever the house you have, a cottage or a bungalow, but you are very comfortable over there. If I am covering your eyes, you will do all the activities whatever you are doing. So in this cases, we avoid or reduce all the challenging activities, challenging stimulus. We are not keeping many things in the room. And even we are taking care of the edges of all the table, chair, furnitures, so that if by mistake they are stuck in somewhere, they are not getting serious injuries. So by this way, we can make them little more comfortable so that they can be more mobile. So all the perceptual issues we see, color, contrast, and slippery floor, and sound, light, everything. And after that, we have to see their quality of life. Like WHO have given a brief quality of life. Even we people need to know that, and this is free. You can download, and you must have to follow this. We Indians are little poor in that. So quality of life we have to maintain. Even caretaker, the caretaker training is very important and crucial for helping this type of the people. The fatigue management, energy conservation, all these points are very, very important when we are going to help the chronic patient. So I don't want to elaborate in much.
In this, sir, if at all you want to advise these things, do you visit the house and plan the this thing, or is it based on the inputs what the caregiver is?
Madam, without home visit, we can't do anything.
Yes.
Because if I want to modify the house, see, if I'm taking history from the patient and he have explained everything, that my house is like this. But when I am visiting his house, before going to the tour, there is 3 steps. And he is wheelchair bound. Or his mobility is compromised, he can't climb the stair. So without visiting the house, we can't do anything. Even in normal patient, we used to go to the site. I'm just want to share one story if you want.
Yes,
Is it
sir,
allowed?
please. Yes.
How much time I have?
Another 2 minutes.
Okay, fine. So I was studying in Manipal University. I have done my master's from there. So there was one 22 years old patient. He have just injury in the thumb, 1 digit only. So people was taking it lightly. Oh, it's okay. There is no pain, no scar, nothing. Only the ROM is little bit restricted. So it's okay. You can manage. But he was insisting, no, sir. Why I am not able to bend like this? Why the power is little less? So everybody thinking what he is doing, man. So I asked, what is your profession? So he told that, sir, I work in Manipal Press. Okay. Yeah. So I asked, I will visit that. After going there, I observed that when they are carrying the ink, that is the cane of almost 10 liters, and they have to keep it up above head and then draw it. And there is rolls. Rolls is very heavy. They have to hold it like this and then keep it over there. And one more observation was there, when the paper is coming on the roll, or what is the name, I don't know. So they are immediate, they have to pick suddenly like this. They have to pick the paper, see it and keep it over there. So after observing that, I came to conclusion that he is not able to hold this roll. This muscle power is good, but here grip has been poor, and overhead power is poor. Then picking the paper is tough for him. So after that, I have modified all my activities. I have simulated the special activities for him as per the work demand, and then he has been independent. And next time again I have visited, and I have seen his performance, accuracy, speed, and all. Then he become independent.
Sure.
Thank you, ma'am.
Without seeing the actual situation where they perform, so the care or the management is incomplete, I think. So finally, I ask Arvind sir, what model of integrated geriatric care which may feel as success according to you has worked well, if at all, if you've seen anything, or if you want to propose?
Okay. I work now as the head of the St. John's Geriatric Center, which is a 7-story standalone facility dedicated to the care of older people and those requiring hospice and palliative care. But the first nail towards this was actually, I did some research on it myself to see the history of how we came up with this finally, was in 2001 when we proposed a 3-tier model for geriatric care. We said, we need a strong foundation at primary care, and that is where your community health worker, first level health responder, all of them have to be at least aware, brought up to the point where they are able to detect and offer a solution at that level. And that is the base of the pyramid, the tip of which are centers like this, which I am now sitting in. So if you ask for an integrated model, we have one in our public health system. Our public health system on paper is very good. It's got a lovely village level health worker. It's got a health and wellness center. It's got a primary health center, a community health center, a taluk hospital, a district hospital, and a referral hospital. I mean, it's all very beautifully outlined. It's just that it doesn't work many of the times like that. And I think that if we are able to strengthen that model and enable each level of care to work to actually achieve its potential, you don't have to search for a new model of integrated care. We've got it, actually. It's just that it doesn't happen like that. And like Dr. Sukma rightly said, patient is also now disenchanted with that, to the extent that if he has a headache, he says, I want to see a neurologist. Because he has lost faith in the primary care system. He doesn't believe that primary care can deal with his problem anymore. It's only if you have to go to primary care because you have no other option that you do. But that is not how it should be. It should actually turn it over on its head and you say, first you go there, man. Then you come to St. John's Hospital, But then we get into the training of the medical student, where the medical student is taught that if you have a headache, you go to a neurologist. So where are we going to bell the cat and actually make this training in such a way that this integrated model of care of cognitive impairment is what this conference is about. But care of anything for that matter needs a huge, strong base of the pyramid, a middle sector, and then the tertiary sector, whereas it's most likely the other way around.
Yeah. The tip is probably has to be a tip, but it is becoming the broader. Yeah. So, Sir Shivkumar, sir, for this thing, to bridge this gap, one help what we can take is digital tools or technologies. So, has digital health and like telepsychiatry has ever helped in this bridging the gap?
Yeah, I think it is inevitable that we have to use technology because particularly in our health system where people are not seeking help only to the local nearest health facility. or if they consult a specialist, they don't go back to the nearest health facility. If you refer back, they drop out and they go and visit another specialist. So I think I don't think in our lifetime we will have an ideal transition to an ideal health system which is non-existent or which is unrealistic in the current state, because we are going more and more specialized and we have a public and private system thriving, and we don't have integration across these health systems. So in that case, technology is really playing an important role. In our center, we encourage a lot of tele-follow-ups. Now, for example, in mental health care, which includes for dementia, now people can reach out by telemanas, which is a 24/7 first line of help, what is called as a national tele-mental health program. There's a number 14416, which is available where people can reach out, at least an initial kind of clarification or a consultation. It was actually conceptualized as a model where it will integrate with different levels of health system, from a non-medical system of psychology, psychosocial support to primary healthcare, secondary healthcare, or referral institutes. The plan is there, but the problem is integration on the real life system is much more challenging. The other example of use of technology is the elder helpline 14567. Again, it is something which everybody should know, because the biggest challenge is when somebody, even with a severe problem, how to get help, how to get that person to a hospital, even that is a problem. Or when there's a crisis, what is the kind of help available? So this is a helpline for elderly, which is very timely. Help can be possible through the integration of the police system. One can have telemedicine. Government has a mechanism. I don't know how effective, because of we have large numbers, but the quality in terms of how much time they're able to give, continuity of care, all these things are by challenge. In our own level, we encourage telepsychiatry, and a lot of our residents, they do, and we have a system. It is one to continuity of care for the patient, as well as continuity of training for the trainee, for them to know what is happening. Otherwise, the dropout is very high. In a center like us, only less than say almost around 30% of the people don't come back after the initial consultation, and only 30% of the people come after for more than 5 visits. So dropout is huge because our systems are like that. So we need to use tele to actually ensure continuity of care, and then add value, improve the quality of the services.
Arvind, sir, in your center, is it any utilized any digital health system for caring the geriatrics in specific with the dementia?
Yeah, well, we've created a telemedicine facility. We haven't yet started it off, but one of the 5 programs of that telemedicine facility is telemental health, like what Dr. Shilpa referred to. And being a geriatric center, we certainly anticipate that we will be dealing with elders with cognitive impairment of different levels. And the tele platform reaches out to the caregivers as well. I mean, caregivers and patients, both are the target groups of this. We haven't started it yet, but it is very much a part of what we want to do.
Okay. Maybe that is also one of the promising way of integrating the care, we can say. So finally, at the end, the other 3 also I want to, sir, Amitabh sir, your takeaway message. What is the way of integrating, according to you, with your specialty? How this caring for the dementia and Alzheimer's, how we can integrate?
Madam, actually, this totally depends on the policy, the central government, state government, how they are making. And then even the in private, who having the ability to open the organization and all. So we are not expert in that, but if you ask me my idea, then specialty hospitals are also needed, and the groundwork, CBR, and awareness of the primary health center professionals, Anganwadi workers, all are very important. The secondary, the social stigma, we have to fight with that also, because still we are in medical model. We are trying to move towards rehabilitation model and health promotion model, but long way to go for health promotion model, right? So when one person is aging, we have to respect the aging, and whatever the problem is coming, we have to accept it. If they have some memory issues, they have to go to the specialist. They have to consult the specialist. But in our society, what they think that no, this is aging. There is no solution, no treatment. So all the things are waste. So this level, the Anganwadi or other worker who are closely working with them, they can help them. And when it's coming to the institution-based rehabilitation, their specialist must be there. And if at one place they are giving all the suggestions and all, that will be more helpful. So even the caregiver training is very, very important because this is the societal change we are observing. Like the people from village, they are coming to the small city and the big city, metro city, and people from the big city or metro city, they are going to Gulf countries or Western countries. So our joint family system has been broken, and our parents are dependent on the caregivers, and caregivers are not their son and daughter or their close people. They are hired people, and most of the situation they are very less educated and not educated like that. Even their concern and connect with the person is very less. But if you are going to take care of somebody, your connect is very important. As I mentioned before, that a doctor, a engineer, or a IAS officer or a army officer have retired and he is living somewhere and he is dependent on a caregiver who is illiterate. He don't know what is non-verbal communication, how to make the proximity. He don't understand that when some person is angry or his facial expression is changing, I have to keep quiet or I have to go away. He will talk what stupid things is there in his mind. So his communication, his connection with the person, like what value belief he had, what religion, what level of the social responsibility he have supported or helped to the society. What is his vision about society, humanity, and the world? So that level, even he can't talk to that people. So educating, like if somebody have dementia, so the caregiver is not knowing what is dementia, right?
Yeah.
So if the person is forgetting something and he is repeatedly asking, "Give me water, give me the water, give me water," he is getting irritated. So if the caregiver is aware about dementia, so the virtual tool, real training education to the caregiver, even like many situations, what the system when this condition is happening, memory and motor and other system is declining. So what to work over there? So there is a very nice thing that train journey. I just want to speak one more minute. It's okay?
Yes, sir.
Yeah, like a train journey. This is very common example. Train tour, like you are traveling from here to Delhi, and after traveling one day, next day morning you are getting up and you are asking, who am I? Where I am? Where I have to go? Which is my birth? So this is the situation with dementia people. And when that people is asking all these questions, other people is telling, no, you don't know. You don't remember even the birth. You don't know where you are going. Are you stupid? How you have taken the this train? Nobody is with you. So all these situations is very bad with it. Okay, sorry.
No, no, no. Ma'am, as a chairman of the association, and this, what a policy recommendation you want to give with for the integrated care and this, especially in the dementia?
This is that the key message is that community readiness is at the heart of dementia care. Unless the community is ready, dementia care, because we only are talking about care at this point, then dementia is not just a health issue, it is a collective social responsibility requiring multi-sectorial coordination. Then also policymakers must invest in awareness campaigns, caregiver well-being, and social protection systems. Then the ultimate goal is to create communities where older persons live with dignity and caregiving are supported, reducing stigma and ensuring inclusion. So now ARDIC serves as a national link among all the stakeholders. That is running memory clinic, daycare centers, and respite clinics, developing caregiver education manuals in Indian languages, conducting and providing training modules for daycare as well as respite care. So this is what we are doing, and this is what we expect from the policymakers to do as well.
Thank you, ma'am. Lastly, ma'am, Jamuna ma'am, is one sentence if you want to, as a key message for integrating care in Alzheimer's. What is the key message from you?
Thank you, ma'am. This is really very challenging matter. However much whatever we discuss and decide on the platforms, this is concerned to some unique individual family and family politics and family members. We have to give lot of counseling as well as awareness to the caretakers and family members, and it is it is very sensitive. A mother aged about 94 is this is a living example I'm giving. A lady aged about 94 has been shifted to a old age home. My friend is running a old age home there. The reason is her daughter is around 70 years. She is suffering from multiple health issues, whereas the mother is 94. She is perfectly fine. But after shifting to the old age home, she started facing certain problems because she felt that she is isolated. Why my daughter she has sent to the old age home? She is not in a stage to realize the circumstance of her daughter. But for her daughter, she is having her, she is undergoing some dialysis. She's a BP patient. She's having multiple health issues. She is unable to take care of the mother. So this kind of so many things are there. So I feel strongly that lot of counseling and awareness is required for the caretakers, and they should feel that there is a community which will help when they are in need. That is very much required, because they feel so helpless. They have to take care of the parents. Suppose if the single parent is taking care of their parents along with the household responsibilities and educating their children, the present situation of the society I'm speaking. So in such cases, they find it very tough to manage both. So time management and mentally balancing everything and meeting the challenges are so tough. Hence, I request that community should give more awareness to the people, and if community can help in one or the other way to the caretakers too, that will be nice. So once in a while, they need a small break when the continuously when they are taking care of the patients. In such cases, there should be some community or some club or whatever the organization they have to support. They should feel that there is somebody to help us to come out from this situation, ma'am.
True.
Thanks.
Thank you. Thank you, all the panelists, for contributing beautifully into this discussion. As the India is becoming the capital of geriatrics population soon, so we are going to face this in a large number in sooner or later. So we have to be prepared ourselves, as well as our community should be prepared for handling these, high number, so much of burden of this disease or this condition. It's naturally which is happening, but definitely the prevention takes the major role here. Once the prevention has failed, once we enter into the condition, disease condition, all this integrated care which comes into play a role, important role. So throughout the discussion, there are some key points which we have heard many times. One is maximum heard is word is what? Awareness. So awareness is the one which can make us empower in handling the situation. So one is awareness, another is another important stakeholder in this is caregivers. So caregivers training. Then the third key point what we have come out with is training of the healthcare community, that may be at any level. That's not only the ASHA workers or something. So starting from the grassroots levels, ASHAs, the ANMs, the medical officers, the specialists, everybody should be trained in caring of this thing. And the community support. The community is not just our own family, our own neighborhood. Everybody in the community becomes the part, including the health sector, and other than health sector also education system, the economic situation also has to support us, the social life situation, what is there in the community, everything matters. So all these are the points which came into during this discussion. And each one of them are doing great in their own field, and we tried bringing them on this one stage and give the comprehensive opinion about all these experts on this topic. Any questions? One or two questions we take from the audience. It's Kishore sir.
Keen to know, how did you visualize that?
Like I said, it was a journey which started many years back in the communities where it started, where we started primary care for elderly people at the village level. We started a few more programs, a home health service where we register older people, a doctor and a nurse visit them at home once a month. We got old age homes looking after destitute elders, visited them once a month. So all these programs went on for about almost 15, 20 years. And it was then that we had this dream in our mind that we need a center for older people on the campus of St. John's Hospital. And we put it up to the governing board. They gave us the space for it, but said you have to raise funds to build it. And 1 week later, we went into lockdown and the pandemic began. And despite that, because they had given us the permission, we went ahead with fundraising. And today, 22 June, we broke ground, and 24 December, we finished. And today we are in the center. But your question is really, what is that model? And I revert back to what I said earlier, sir. Really, I believe that centers like that play a role, no doubt. I mean, it is, after all, a place. But what it stands for is actually sound primary care, on the back of which we need specialist care, we need transitional care. What we offer there is day care, outpatient care, transitional care, respite care, palliative care, and hospice care. That is the care that is offered there. But there are 4 other dimensions which we want to start, hopefully over the next few months, which is training of the workforce to look after older people. It could be home health nurses, could be geriatric nursing, it could be geriatric physiotherapy, any other group which is involved in the care of the elderly, which we want to train, and we've got a space for that. The third is community engagement. We want to enhance wellness and what we call healthy or successful aging. which starts, yes, the mnemonic and the whole prevention and all those activities and education. The fourth is research. Like, St. John's has a research institute on our campus. So we want to promote research on aging and geriatrics, and we've got some spaces for that as well. And the fifth is telemedicine. So we're trying to bring all that together in one place, but it is really built on the back of primary care, which is where I think the real challenge is. Thank you, Dr. Kishore.
One from students. Yeah.
We, in spite of having been in so many years in India, geriatrics itself is yet to take roots in most places. If you look around, there are many national aging centers and many funds devoted for geriatric centers, which are really not happening, even in the government sector. So in the setting where geriatrics itself is not developed, how many more years would it take for people to understand what dementia is? Sometimes I wish if one of our political leaders developed dementia, or if they only if there is a need to travel across the country to take treatment for dementia, will questions be asked, why is it not there in India? So probably there we need to invest and bring in. Today, 2 days ago, I wrote amyloid beta scan for a patient, PET scan, and I was talking to Dr. Shivkumar today, and he was saying it's not available in most places in India. So if this needs a person to travel somewhere else to get it done, we need to bring in all these. Otherwise, people will keep thinking of dementia as an old age disease. This is my comment.
Yeah. Thank you. Any comments?
I think a lot of politicians have developed, so it is not going to end there. I think the challenge is that they get everything what they need. So they have the access. They can go to AIMS, they can go to demand, they can go to the best of the places and get it. There is a lot of. I think if things have to change, it has to start with common man. The biggest challenge is the demand. Is as to what people ask for it. I think slowly things will come, and there is a lot of noise happening now. People are getting to know more. For example, all of our services there are there, and many NGOs are working now. ARDSI is working, Dementia India Alliance is working. Many people are working towards that. Many centers, those who have affordability, a lot of things are coming up. And for example, somebody told that recently new drugs have been approved, CSF biomarkers have approved. It's not that things are not changing, but we still have a long way to go, not just in dementia care, and many aspects of healthcare. So it's about again awareness. A lot of people know about awareness. It is about right kind of acceptance is a challenge as to what is the right thing to do, and am I getting the right kind of help. So that's where guidance and continued handholding. The problem is both with the public, how we approach our health system. What we demand is what is available. Tomorrow everybody decides we will go from primary care to secondary care to tertiary care. The primary care physicians will become more. Now we think that okay, everything is specialist. We advertise and glorify that. People are going to also have. It's a complex solution where I don't think we have a U-turn available now. We have gone over the last 60, 70 years in one way, and how to kind of minimize the problem, how to kind of make it much more working on the ground at our own level, at least whomever we come across, whether we are able to do anything better than what we can do. I think that is what is important.
Will not take much time. So I just want to put 2 points over here. This is system, and system never change in the few years. It will take lot of time. And as sir told that demand. So now need is there, but we have to create the demand. The people are suffering, they have problem, but we have to make them aware that there is the solution for this, and if you are approaching these people, they will help and you will be independent in life. Thank you.
Thank you so much, sir. Thank you all. And maybe the geriatric group, if it is important for the community, then the the same. So that is the main point. Even yes. Okay. Thank you all the panelists.
Thank you, dignitaries, for the amazing panel discussion. I now call upon Dr. Hanumantachar Joshi, sir, Principal, Shada Vilas College of Pharmacy, and Dr. Venkat Rao, sir, Professor, Department of Pharmacology, Shada Vilas College of Pharmacy, to honor the panel members. I request Dr. Hanumantachar Joshi, sir, to hand over the memento and honor Dr. P.T. Sivakumar, sir. I would like, sir, to honor Mrs. Renu Vohra, ma'am. I would like, sir, to honor Dr. Jamuna Rani V. Mirle, ma'am. And I request Dr. Venkat Rao, sir, to hand over the memento and honor Dr. Amitabh Kishore Dwivedi, sir. I would like, sir, to honor Dr. Arvind Kasturi, sir. I would like, sir, to honor Dr. Nayana Bai Shabadi, ma'am. Thank you, dignitaries. Moving on to the next session, I now welcome Dr. H.P. Shobha, ma'am, Medical Superintendent, Care Hospital, Mysuru, and Dr. Archana Yes, ma'am, Associate Professor, Department of Anesthesia and Chief Coordinator of Skill and Simulation Center, JSS Medical College, Mysuru, to chair the session on Dementia and Human Rights Ethical Framework in Policy Making by Mr. Sailesh Mishra, sir, Founder, President Silver Innings Mumbai, India. I request the chairpersons to introduce our speaker. For the session, I would like to announce that cultural programs will be conducted in the old auditorium at the end of the scientific session at 5 p.m., followed by dinner in the same place. Thank you.
Hello. Hello. Are you there? Last session, we all are sleeping. Can you have some? You have 1 minute. Can you stand up? Everybody. Some activity to prevent dementia. Okay. One laughter. One. You have to laugh. Okay. 1, 2, 3. Ah! One. Okay. community work and what should be done in policy and government. So let me tell you initially, most of the work in dementia in India is done by all the NGOs or the civil society. Very few work is done by the government. So I will take you through this aging, what is dementia, what are the recommendations, what we should do. So India, as you know, we are growing. We are 143 million senior citizen in India at presently. We are growing. Longevity is there, fast longevity is there. We are growing faster, and the population is growing. But we are living longer because due to the medical, advance, and also we are fit and fine now. So we are living longer. When we live longer, we bound to have some kind of problem, which is dementia might occur to some people. And people, 60 plus people, population will grow 340% by 2050. So is India ready to take care of old people? We have heard we are not ready actually. But we think old people has to be respected. But what have to be done? Do we have enough geriatrician? Do we have enough old age home, elder-friendly cities, facilities, hospital, care center, caregiver? Nothing. At present, we are at very low stage. 70% of Indian old people are in rural area, in the villages, and very few things in the villages. Feminization of aging is happening. More females are aging. They are living longer. Male go faster. Females are living. Why? Any thought? Why females are living longer? It's a good situation, huh? Earlier, my dad was like 12 years, 15 years older to my mother. So age gap was more. So at that time it was okay. But now I think it's not there. We women are living longer. Of course, they have don't have any addiction. They do a lot of activity. They are multitasking. So there are many reasons actually. So because you will live longer, you might get dementia. Might. And I run a home for dementia. 70% females are with us are suffering with dementia. Also, we are in very health facilities not there, and especially rural area, there is a problem in genetic care. Also, 20% of Indian population of elders are suffering in some form of mental health. Around 8%, 80 million people in India are suffering with, 8 million people are suffering with dementia, some form of dementia. Higher prevalence in rural area, also females are suffering more. And every state has a different kind of percentage. Kerala is different, Maharashtra is different, Uttar Pradesh is different. We have different kind of percentage prevalence in different states. So we can't have a blanket policy and program for dementia. Every state has to have the unique thing. So what are the policy? At presently, there is no policy. Nobody is thinking about dementia. Of course, NIMANS and a lot of people are working on dementia, but government is not thinking about dementia. For me, challenge is dementia is whose child? Is it child of health ministry or nodal agency, Ministry of Social Justice? Nobody knows where dementia goes. So everybody is working, but I think that's the biggest challenge. Sir will know because Ministry of Social Justice is working for old people, and Health Ministry is working for health. But they don't think old age people should be considered Health Ministry. So that is the biggest challenge. We have national policy of older person, which is not implemented till date. It's on the policy 1991. Then we have Maintenance Act, which cares about the maintenance safety of senior citizens. Still, 2019 amendment is pending in Parliament. Then we have NPHC, still not yet implemented. Sir is smiling. And since 2010, there is a mental health policy, which provide legal framework. Then have rights of disability person. We have to look to all this policy when you're talking about dementia policy. While speaking on guardianship of adult guardianship, so we were discussing with Money Life Foundation, we found National Trust Act actually has many good things which can be incorporated, or dementia can be part of it. So it will provide a lot of things. Then we recently Kerala government has a dementia friendly policy. We need to look into it if there is something good in it. And at our home, we are the first in India to have rights of resident for dementia person. Basic rights. They can practice the religion, They can have their own doctors. They can have grievance center. They can have food choice. So some rights we have included. So this is something we should look into before we make a policy. So there is no comprehensive policy. There is no national dementia policy. We have been talking since so many years. Alzheimer's Society, ARDSI, made dementia national policy strategy or plan India report in 2010, and we gave it to a lot of government department. But they're using it as a framework or guidelines to make some laws, but still they are not working on it. They are limited for workforce. I have a home and I know so many people. I get so many calls in Mumbai city. Very difficult to find caregiver for old people. Nobody wants to clean old person. Nobody wants to clean a potty of old person. Mental health, dementia, forget. There are a lot of jobs in malls. Swiggy, Zomato, Ola, Uber. No young person want to go there. So very difficult to find people working with dementia. So we have to see there is no glamour. There is no hierarchy. There is no bonus. There is no salary. How much you will get? There is no promotion. We have to think. We had people from Canada who used to visit us at our home for internship. They are nurses, they are caregivers, but they have tag, beautiful tag. I don't know what kind of. It can be Buddha Mitra or something like companion, and they should display care, and they used to have promotions. They has to have salaries, So here in India we don't have anything like that. So we have to think about it. So in rural area, of course, there is nothing available. So access is not there. Stigma. Somebody spoke. We are in denial. We don't. If we find somebody's forgetting something, somebody is making mistake, we don't want to tell anybody. We don't go to doctor. We don't speak about it. So we don't have any access to it. Late diagnosis. And that's the reason we don't go to doctor. If at all doctor says somebody goes to Nimal, they won't go to second round. Okay, this is old age problem. We won't take any help. So dementia is not considered as a health problem. It's considered as a normal thing. Insufficient data. There is no national survey. There is no national statistic pan India. Every state somewhere somebody has done some surveys, and so we don't know how many people are there. So there is, because we don't have numbers. I can go and ask government for budget. I need 1,000 crore for so many people. Because there is no data. We say Maharashtra mein itna hai, Kerala mein, Karnataka has something. But what in pan India? How many people are suffering? Or what is the kind of suffering? So we don't have anything about this. So who is the nodal agency? I spoke about it. There is no ministry who is going to take charge of dementia. Nobody wants to, hold this baby. So WHO has prepared something where it talk about participation. It should be non-discrimination, empowerment of the person. So support the policy, what we make should be human right based for the person and for the family members also. It only not about the person. It should give decision making thing to the person, and also respect their preference, what they eat, what they want, how do you want to stay. And also now we have advanced directive. What is the last stage? What I'm going to be taken? Do I want ventilator or not? So it should be non-discriminatory. My privacy should be respected. If I have a home, I have 10 people. My medical thing should be confidential. It should not be shared. Access to justice. If there is a problem, can I approach court? If there is a property dispute, nominations are there. A lot of issues have come up with dementia. It might be bank account, properties, a lot of things, and there are a lot of issues are there. So who is going to protect dementia person? We don't have any guardianship law. We don't have adult guardianship. So where the money goes, where the property goes, it goes in dispute or it goes in the bank, which is there lying in the bank. So there's the least. Also, what intervention I need, it is available or not. So we need to have national dementia strategy, which already there in some of the countries. We need to see it should be right-based approach, also taking into consideration of national policy of care of elder and the state health plan. We have to set up a workforce. Workforce is not about training a normal caregiver. It has to be doctors, nurses, Asha worker, community. In fact, all the judges, all the police, the workforce has to be multi-stakeholders. It can't be just 3, 4, 5 people to be trained. Everybody. Doctors mean only not psychiatrists and neurologists. A cardiologist, a diabetologist, MBBS, everybody should be trained on this. So create a memory clinic in different districts, health centers or hospitals, wherever possible we can do that, support caregiver, give them financial incentive. I am looking after my father or mother. The government has included 18% GST. They are punishing me to take care of my parents. So why should I look after? So this is a big problem now that has come up. So can we give them financial incentive? Can we give them some tax benefit? Something should be given, or subsidy in medicine or long-term care. It is not one-time care. Insurance is not there because they are not going to be admitted to hospital. Expenses 45,000 rupees per month. Where is the money? It's a rich person disease. So we don't have any insurance plan. We don't have any financial plan. The children are suffering. Parents are suffering. Whole community is suffering when somebody has dementia in the family. So also the research, we need research, we need funding. So where is the data? We need to support that. R&D should be supported. So legal safeguard should be there. Consent should be taken. Guidelines for guardianship, as I said. Standardize homes with different states, because India is a very diverse country. So every state will have a different thing. Confidentially, grievances center, where should we approach, whom to approach? Is it human rights issue? Should we approach a state human rights commission, or which is a body which will look after this? So we have some example of UK national dementia strategy. China has some plan, and also some evidence based. In Indian, we can find out what could be done. So what we should have is government should declare dementia as a national health priority. How we should do? Somebody was saying with politicians suffering or not. Many politicians are suffering, but they don't accept, or they're not going out. But we should continue to do our work. We should not stop here. So we should go out, and in fact, this conference should publish a white paper and give it to government. And having policy is not enough. If budget allocation is not there, nothing is going to move. The policy should be there with the budget allocation, and mandate dementia training, compulsory training with all the medical college, nurses college, support caregivers, and ensure legal safeguard. So prevalence of, so we have dementia registry? I think sometime we had a discussion. So do we have how many people of dementia are there? So if somebody comes to Nimans, do we have a registry? Or any hospital? We don't have any dementia registry. So district level registry can help to get a lot of data, and what kind of dementia, what are suffering, what level of care they require. We don't have any data actually. So number of memory clinic, trained workforce, again caregiver support, reports of elder abuse, knowingly, unknowingly, in our home and in this institution also. There are a lot of abuse happening there, and also budget. So dementia touches the dignity of the person. So they have a right, they are human being, and also social fabric of the country, the family, community, everybody suffers. So we have to see everybody is protected. It has to be right based. ARDSICON and Silver Ending, we are ready to partner, and a lot of other organization, Dementia India Alliance, a lot of like this college also can be part of it. So education institutes also should be made part of policy making. I think there it will have a lot of effect. So to end it, is it not other person's behavior that creates a reaction? Instead, it's our judgment about the behavior that triggers our reaction. So person is not doing purposely, dementia person is not doing something purposely. So we should not react because of their reaction. We should understand. We should not be judgmental, and then only we can do something. So to make a dementia policy, we need to understand the person is a human being. He or she is not a patient. But when you start treating him as a patient, only medical aspect, we forget a non-pharmaceutical approach, and we can't do anything much. So we should see as a person, family member, then only we can help him or her, and we can make a dementia-friendly country. Thank you.
Thank you, sir, for that wonderful session. I have a query here. Being said that there's a lot of dementia patients coming, and as you said, a lot of care homes are coming, and then this thing. Do we have any standards that is set up for these care homes? Because we know, like every nook and corner in the metros now, we're having a lot of care homes, elderly homes, and home care. Do we have a policy wherein these are standardized, or that has to be done for the care of the patients? Because everybody can open a care age home, and then how do we maintain the standards and the policies in those care homes?
So, no, there is no policy. Actually, earlier, dementia homes or dementia care center were run by RC or NGOs or a sub institute. Now it has become business. Example, when I started A1 Snanjali or home in 2013, I had a mind, this is a social thing. I'm not going to earn it, not no profit, no loss. But now it has become business because it is around for 1 lakh rupees per month. And they, of course, they have standard, they have good quality infrastructure, but there is no proper policy or guidelines to actually what kind of dementia home should be there. There's a guideline for retirement township in India now. In 2000, I think 2-3 years ago, government has started, but they are still not thinking about dementia center. So it is a physical infrastructure we should see, also social thing, psychological thing, rights of the person. So there is no policy. Every Tom, Dick, and Harry comes and makes something, and but people are doing good work. There are a lot of help is available now. So again, we don't have any monitoring agency. What kind of work is going on? There is no licensing system, or at least there can be a Google rating, 5-star, 2-star rating. Where I think Nimansi is working on it, I suppose. Yeah.
Yes, sir. Yes, sir. Healthcare sector skill council is one of the thing which slowly they
National Hospital. I think this year they have come up with.
The reason I'm saying this is the NABH accredits hospitals. So now our hospital is NABH accredited. So now that we've started the geriatric center, the question came about adding that to the NABH certification. But then we realized that there is another set of standards called the NABH standards for care homes. Now, care home is slightly different from a hospital. So it's stuck that's our peculiar problem. We are stuck somewhere in between. But to answer your question, ma'am, there is now a set of standards, and those standards are pretty good. I've attended two programs where the standards were presented. One of them I found really engaging because the standards are really good. And if we actually adhere to those standards, I think we'll do a fine job of setting up a care home.
Very nice.
Just I wanted to make some points that I think dementia is a health condition. It comes under health ministry.
Okay.
There is no ambiguity in that.
This is clear now.
It comes under mental health division.
Okay.
It is recognized as one of the health conditions under the mental health, officially as per the ICD-11, and that's how the in the different divisions of the ministry it comes. But there is a overlap also in terms of where psychiatry has a role, neurology has a role, geriatrician has a role. So sometimes in the administrative circle, different papers are passed on to different people.
Yes.
But nevertheless, everything comes under health. The care of persons with dementia in terms of social care, that comes under Ministry of Social Justice Empowerment. The health ministry is only concerned with diagnosis and treatment. It is not about the care facility. Daycare, residential care, those things come under Social Justice Ministry.
Yeah.
So the policy, as far as this, as of now, it is covered under mental health policy.
Okay.
And the senior citizens policy is also under revision, but again, that will have some scope. Lots of things. I think the National Health Program, if you see everything, there is some progress. Whether
Yes.
it's about building National Center for Aging, it may be far from ideal. But I don't think we should say that nothing is happening, because if you look at National Mental Health Program, it has expanded to more places. It is far, far from an ideal situation. Whether
It's moving slowly.
there is some progress is happening. There is some progress. And with respect to standards also, there is some movement in the ministry. There is advocacy going on. There is a draft being circulated opinion for dementia care standards. But what will these standards actually do? The standards can never be in a very, very high level, because there are people who are running on charity based, and it is impractical, because you can have a policy, you can have a standards, but it becomes impractical because the more and more rigid you become, it becomes more expensive.
It can be guidelines.
Yeah.
It can
For
be.
example, dementia care center has to be registered under Mental Health Care Act.
Okay.
How many of them have actually registered? Because it is actually, see, it's a violation. Even old age homes who are having a lot of people with mental health problems, they have to be registered as per the technical definition of Mental Health
Mental
Care Act.
Health Act.
But these are impractical many times.
Yes. Any more questions?
Very nice talk, sir. Actually, you very nicely narrated the problems suffered by geriatric patients and also their caretakers. Thank you.
Thank you.
Sir, in care homes or in nursing homes, dementia care homes, how do we decide about the advanced care planning? Suppose a patient with dementia develops any acute infection. See, if we have to decide about how far we have to go on treatment, do we have anything legally in place, like an advanced care planning?
Mental health.
Advanced directives. You can decide. You can actually. There is a mechanism. Till date, I have not had anybody coming with it. This is a concept which is kind of incorporated in the Mental Health Care Act. But I think what most people practice is do not resistate orders. I think that is something quite common, and families take decision. You can authorize the family member or whoever is the person to take that to kind of express your wish, and doctors have to respect it. If the person has a capacity and you have actually done it, it is legally valid. It is, if there is an ambiguity, for example, one son wants you to put in a ventilator, the other son doesn't want to give you active treatment, then the doctor is in trouble as to who is the, because many times they will not have legal guardianship. You have spouse, you have 2 children or 3 children, and so when there is a consensus, doctors generally don't get into problem. When there is no consensus, you will have to kind of refer to an appropriate center, then the family has to take a decision. Whoever is available to you, they, as per their consent only, you can do it. Without their consent, you can't put him on ventilator, you can't do anything, because without the consent, and usually in this kind of situation, the person who is affected is not in a position. And even if they have an advance directive, somebody has to bring and show you the advance directive. And even if they are an advance directive, when the person has lost the capacity, the word of the family member who is available, that takes a lot of precedence. Unless you take family into confidence, or the person has made a very clear written instruction, which is not contested.
Many times we found family fights between themselves, the siblings and brothers.
Go by the consensus is safe for doctors. We don't need to be adventurous, risking our safe.
What we do is we have family. Suppose a person is gets sick and we admit the person to hospital and is in ventilator or some problem. So family comes and they have dispute with daughter and son. Then we do counseling of the family members. We tell them, because doctor said now it is last stage, you have to take him home. But they say no, keep on ventilator. We have to tell them why you want to make the person suffer. What ventilation. If you tell them, family agrees. Family agrees to take them home. But again, advanced directive, living will, we should actually make a big seminars and awareness. We should make everybody sign that. It's very important for our future. I don't want ventilator, but I have to sign them. Like we make a will, like we make nomination, power of attorney, same way we have to make this kind of living will or advanced directive. Thank you.
How do you decide on capacity? Like if at all,
doctor.
Yeah.
How do you decide on capacity? So do you have any tool to decide that, like standardized ones?
As per, there are 3 things. One, the person should be able to understand what is happening. They should be able to make decision. They should be able to communicate.
No, because
these
there
are the
would be
3
people
aspects.
of dementia who probably they are telling that they would want to make a living will or something like that.
Yeah.
So to decide capacity, we have
Capacity is task specific. If any task, for example, whether they want to get admitted or not, they have to they have to understand why they have to be admitted. They should be in a position to take decision. They should be able to communicate. As a clinician, we should be able to interview the person and then come to a judgment.
So do we have a tool, sir? Like so that
The tool is actually very simple. For example, if there is a format what is
that's
available
what
as
that's a
per Mental
format.
Health Act.
Okay.
We have a tool which is being used, and that has to be documented for every patient with mental psychiatric illness who is getting admitted. But it's not a very complicated thing. If the person is completely non-communicable, there's no capacity.
Yeah, right.
If the person is not able to understand anything what you say, again no capacity. If the person cannot take decisions for that particular decision, if for example whether to admit or not may be a decision, but if there is a the capacity may be assessed in another context where the same person who is able to take a simple decision may not be able to take a complex decision. So it varies from situation to situation, context to context. It is a dynamic thing.
So there is a format in place.
It's not a very complicated thing. It involves clinical judgment. Ultimately, it involves clinical judgment. A clinician
Because
should
it's
be able
kind
to
of
judge.
ambiguous when you talk about because one of the children might say that he is not in capacity to give decisions like that.
A qualified doctor, like in Mumbai, what we do, we have JJ Hospital as a government hospital. The JJ Hospital dean, if he signs, so he is authority. Government has given him authority. Same way everywhere, I think government hospital dean has the authority to sign, say that person is suffering incapacitated, so they can do it. Family will always object because they have vested interest also. Many times they want to keep them alive. Many times people come to us, like my dad and mother is suffering with dementia. They won't just write the word dementia Alzheimer's. So there are a lot of family issues are also there. We have to take care of the doctors and also care home or service provider that we have to protect dementia person. Yeah. Thank you.
Thank you for a wonderful session, sir. It's an honor to have Mr. Shailesh Mishra, sir, with us today. We request sir to accept a small token of appreciation. We now request the chairpersons to hand over the memento and honor sir. Thank you, sir. Thank you, dignitaries. We'd also like to thank Dr. H.P. Shobha ma'am and Dr. Archana S. ma'am for chairing the session. May I request Dr. Steve Paul, sir, to present a small token of respect to our chairpersons. Thank you, dignitaries. With this, we conclude the scientific session of Day 1 of ARDSICON 2025 International Conference on Dementia, Policy, Practice and Progress. I thank all the speakers, chairpersons and delegates for your active participation. Thank you one and all. I request the gathering to accept the refreshments arranged outside and gather back in the old auditorium for a colorful evening filled with beautiful performances by the students of JSS and SVCP. Thank you one and all. Have a great day.